you for this 8th edition of the National Update on Clinical Diabetes held on today and tomorrow. This is a flagship program of the country, and this year's program is fabulous with faculties both national and international and topics covering every clinical practical aspect of diabetes. I will hand over the mic to the organizer, the chief of the events, Professor Dr. Alok Kanungo, to take it forward. Alok.
Thank you, Professor Das, for your kind words. Dear friends, colleagues, my teachers and guests, this is a golden opportunity for us. In spite of the COVID-19, we are able to continue NUCD, the 8th edition, virtually. And this edition the program has been so well designed by our scientific team headed by Professor Ashok Das, Professor Jayant Panda, Professor Abhay Sahu, Professor Sambit Das, Dr. Vijay Misra, Professor Lalit Meher, and Dr. Devashish Das. So we have tried to make a clinically oriented program for you over these coming 2 days. I want to thank all my guests, well-wishers, and Professor Sanjeevi is here with us. We'll gradually go to some of our guests to speak few lines. And now I request the organizer to start the lamp lighting, followed by the devotional recital by Dr. Mamta Tripathi, Vice Chairman of the organization.
Shubham kurutvam kalyanam arogyam dhanasampadah. Shubham kurutvam kalyanam arogyam dhanasampadah. Shatru buddhi vinashaya dipajyotir namostute. Dipajyotir namostute. Dipajyotir parabrahma. Dipajyotir janardanah. Dipajyotir parabrahma. Dipajyotir janardanah. Dipo hartu me papam. Sandhya deepa namostute.
Dr. Mamta, please.
Namaskar. I'll start with the education shloka. Vakratunda Mahakaya Surya Koti Samaprabha Nirvignam Kuru Me Deva Sarvakareshu Sarvada. Om Gam Ganapataye Namo Namah. Shri Siddhi Vinayaka Namo Namah. Ashtavinayaka Namo Namah. Ganapati Bappa Moria. Om Gam Ganapataye Namo Namah. Shri Siddhi Vinayaka Namo Namah. Ashtavinayaka Namo Namah. Ganapati Bappa Moria. Om Gam Ganapataye Namo Namah. Shri Siddhi Vinayaka Namo Namah. Ashtavinayaka Namo Namah. Ganapati Bappa Moria. Om Gam Ganapataye Namo Namah. Shri Siddhi Vinayaka Namo Namah. Ashtavinayaka Namo Namah. Ganapati Bappa Moria. Ganapati Bappa Moria. Ganapati Bappa Moria. Thank you. Namaskar. I heartily welcome all the delegates, faculty members, and guests to this NUCD program. National Update on Clinical Diabetes had started 8 years ago with a mission to focus about every possible new endeavors and research done in recent times related to clinical aspects of diabetes, so that practicing doctors will have a clear picture about the latest developments. On behalf of NUCD, we want to pay our gratitude to Professor K.C. Samal, Professor Niranjan Tripathi, Professor K.C. Misra, Professor Dr. C. Sanjeevi. I thank Dr. Ashok Das, Dr. Jayant Panda, Dr. Abhay Sahu, Dr. Sambit Das, and all the members of the scientific and organizing committee. We are thankful to our sponsors for their academic support. I thank Saurav Tripathi for giving this virtual NUCD a new shape. I thank members of RX Events for their continued technical support. Wish you a wonderful academic journey for this coming 2 days. Thank you very much. Thank you. Namaskar.
Ashok Bhai, please.
Dear friends, thank you very much, Dr. Mamta. Let us all rise for the national anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you. May I now request all our esteemed guests to give us a one-liner message on this great occasion. And I will start with Dr. Sanjeevi.
Thank you very much, Dr. Ashok. Thank you, Alok, for inviting me to the inauguration of this NUCD. I have been a part of NUCD right from the beginning. It's been a great story. It's just that because of COVID, we are not able to meet in person, interact, network, which is much more important than the topic that we will listen to in the lectures. But nevertheless, we have to live with our times, and I sincerely congratulate Alok for putting together a wonderful program. And I congratulate Ashok Das for making a nice scientific program, got all the best people to come and speak. So I wish you all the best. Thank you.
Sambit.
Thank you, Sanjeevi. Professor Niranjan Tripathi, sir.
Sir, Professor Niranjan Tripathi.
Niranjan Tripathi is here, and I am standing before you with all humility to talk something about NUCD, which is first of its kind in India and probably abroad. This is organized by one man and which is a national congress from Odisha. Others are provincial congresses, and this is only congress which is a national only route, that is Bhubaneswar, and comprising of all of Odisha. Congratulations, Alok.
Thank you, sir.
Number two, KIDS is the only center where all specialties of related to diabetes, all multi-speciality diabetes problems are treated in a single route. So, combination, and this is running for last 9-10 years, because 2 years of planning and 8 years of Congress, which is a national cum international Congress. But this is for the first time this Congress is being organized in a virtual way. And I see almost this is a international conference because there are 3-4 international faculties and Dr. Sanjeev is there always blessing the Congress. And moreover, he is also Vice Chancellor of the Satyasai University. I saw him strolling in a snowfield in Switzerland. So naturally, this world has become such a small world and Alok is the key for maintaining all these things. And for last 8 years, 9 years, he has taught almost all Odia physicians. And through this type of Congress, clinical diabetology has become very much approachable and almost all physicians are now capable of treating diabetes. That's because this type of congresses are being arranged. And Alok is a pioneer physician who just constructed one institute for diabetes and also is a pioneer physician who organized the national and international congress for the NUCD. Clinical diabetes earlier was not given much importance. And this program, which comprises of clinical diabetes in all parameters, will teach all of us all the good things about diabetes in the future, and probably diabetes is going to be much controlled and cured. And the name that India is Diabetes Center of India, Diabetic Center of the world, is going to be eradicated in next 10 years. Thank you.
Thank you, sir. Professor P.K. Misra, sir. Sir, unmute. Prashant, sir, please unmute.
It is a definite pleasure to be associated with you and the conference organizing. The present conference, the clinical update, is really what is beneficial to all physicians dealing with diabetes, from the general physician on graduate level to specialty level. It is also a pleasure that Dr. Sanjeevi is associated, is the key man with you I think of all the success of this conference. It is also a pleasure to see my friend Professor Zargar and my respected teacher Professor Das, and then my colleagues, seniors and colleagues on this forum. But it is hope that next time we'll be able to have a physical meet more with each other. Thank you all.
Professor Professor Bhansali, please. Sir, please unmute.
Yes, thank you, Dr. Alok. It's always a pleasure to be associated with you, and I am thankful to you for inviting me for this great conference, which we are going to have in next 2 days, and your untiring efforts to make this conference as a grand success is laudable, and I wish you all the best and good luck for this next endeavor. Thank you.
Thank you, sir. Professor Jargar, please, Vice Chair.
Dear friends and colleagues, I first take this opportunity to pay my homage to our legendary teacher, a late Professor R.J. Dash, and convey my hand-folded condolences to Mrs. Sumitra Dash. I'm also grateful to Dr. Ashok and Dr. Alok making me part of all these meetings and for all the affection that Bhubaneswar people have shown us, right from Mishra ji up to Sumit and Sahu. I'm sure that we're going to have a great conference in these coming 2 days. Best of luck, Alok, and best of luck, Ashok, and best of luck to all of us. God bless us all.
Thank you, sir. I just thought of talking it a little later, but let me mention that as a regard to our late Professor R.J. Das, we are going to have our first NUCD oration by Professor Ashok Das on Professor R.J. Das. So it is RJ Das oration. And to our good, we are lucky that Mrs. Das, Sumitra Das is with us, and she will be speaking to you before the oration. Professor Vijay Misra, sir.
Good afternoon and a grand welcome to all our international and national faculties and all our delegates to this 8th NUCD program which is in the virtual mode. So I wish all success to this program, and this is an annual program, annual update for all physicians irrespective of the specialty. Thank you.
Professor Prasanna Kumar, please.
Good afternoon, everybody. Thank you, Dr. Alok Kanungo and Dr. A.K. Das. Congratulations for an excellent NUCD 2022. I have been associated with NUCD from 2016. This NUCD has been very useful to all physicians and those interested in diabetes, and you have got the best of the national and international faculty. Most of the topics are related to practical problems, and it is very pragmatic. I congratulate Dr. A.K. Das and Alok Kanungo for an excellent program. Thank you.
Thank you, sir. Dr. Bansi Sabu, the leader of diabetes in India. Bansi, please.
Congratulations. First of all, congratulations, Dr. Alok Kanungo, sir, Dr. Ashok Kumar Das, sir, Mrs. Mamta Ben. I can see congratulations, and all the national and international eminent faculty. I can see the Karini also, Sanjeevi, Dr. Sanjeevi. I'm the part of NUCD, probably from the day one. I mean, as a speaker. So I'm really thankful, Dr. Das and Dr. Kanungo, for inviting me every time for this meeting. Definitely missing the hospitality of Dr. Kanungo. And now since 2 years, we are meeting online only. That's the only possibility. I think now this has become a new normal. So probably now we can't complain of that missing the hospitality. Now it's online hospitality only. That is only possible. And congratulations to Dr. Kanungo and Dr. Das for a wonderful program which you have. So sure we will be there at our time. When I have talked today at 3:20, I think it's on technology session. So very excited to listen other speakers also. Thank you once again. Congratulations.
Thank you. Dr. Manoj Chawla, please.
Good afternoon, everyone, and it's a pleasure again to be here and associated with NUCD. It's one of those national congresses which has been extremely practical and brings a certain amount of warmth with it. And that's what I have cherished and enjoyed this association over the last few years. Always loved being in the presence of all the seniors and colleagues in Bhubaneswar, and hopefully that will happen soon. May I wish Dr. Kanungo and everyone associated with NUCD a wonderful Congress today and tomorrow. And thank you so much for making me a part of it again.
Thank you, Manoj. You are incomplete without Purvi. Purvi, 2 lines, please.
Good afternoon, everyone. Heartiest congratulations to Dr. Alok Kanungo, sir, and Mrs. Mamta Tripathi, ma'am, for the 8th NUCD. Again, heartiest congratulations to the entire scientific team led by Professor Ashok Das, sir, Professor Jayant Panda, sir, and the entire team. Besides being an excellent conference covering the broad spectrum of diabetes with special focus on type 1 technology and everything, I think, so besides this roaring scientific program where I've experienced, the greatest orations or the best clinical discussions of my life, it is personally nostalgic, and we miss Dr. Alok Kanungo's warmth, affection, and his personal hosting and welcome to all of us. So it has a feeling of family bonding and with focus on such superior scientific discussions. Congratulations again, and thank you.
Thank you, Purvi. I will request our Vice Chairman, Scientific Committee, Professor Jayant Panda. Jayant, are you there? Professor Abhay Kumar Sahu, please.
Thank you, Kanungo sir. Actually, along with Kanungo sir, Ashok Das sir, we try to design a scientific program which will be not only beneficial to all our physicians, along with all the faculties who have joined in this conference. Everybody will get benefit from that. And of course, it's a virtual meeting, so we could not give our wholehearted hospitality in this, but still we try our best to do in this conference. So welcome all to NUCD 8th NUCD program. Thank you all.
Thank you. Professor Sambit Das, please.
Thank you, sir. A very good afternoon, one and all. And at the outset, I must congratulate Alok Kanungo sir and Ashok Das sir for the nicely crafted scientific program. I think it will be beneficial for all of us. And I wish a grand success for the conference. And I thank again Alok sir and Ashok sir for giving me this opportunity to be part of it. Thank you.
Dr. Sisir Kumar Mahapatro, please.
Thank you, Dr. Alok Kanungoji. It's really a proud moment for all of us that we are celebrating this NUCD on the 2 days of 15th and 16th January 2022. These are definitely the memorable days in the history of NUCD. I am sure this is only possible because of the able leadership and guidance of Dr. Kanungo, Professor Ashok Das, and Dr. Jayant Panda for organizing such conference for last 7 years. And I speak from a core of my heart that the entire credit goes to Professor Ashok Kumar Das, Dr. Jayant Panda, Dr. Vijay Kumar Mishra, other members of the scientific team who has such a way designed what I feel is definitely helpful to the clinicians, the doctors, the members of medical fraternity working in urban and rural areas. They are all intending to join such a conference only to update them. And you know, Dr. Kanungo, the science is so vast changing, they want to update because the therapy of yesterday is old today and today's therapy is old tomorrow. The scientific program is so designed to make these doctors to updated from basics to the latest updates. And we are extremely honored to have such a great national faculty like Professor Bansal, Dr. Jargar and Dr. Chawla and Dr. Sanjeevi, who are of national repute, and they will be speaking to the audience that they are intending to listen. So my request will be to the delegates, please do not feel embarrassed. You put all the questions, get yourself clarified, and be an updated doctor to a national level, because doctors feel embarrassed and underestimated if they put a silly question. No. This is such a NUCD platform that everybody should get their doubts clarified so far as their practical aspects in managing diabetes patients from day-to-day life. Thank you. Wish you all success. Congratulations, Dr. Mamata Tripathi, for giving his introductory speech, and all the delegates, and Dr. Jayant Panda is extremely experienced in organizing such scientific program, which definitely suits to the working doctors in the practical field. Thank you, everyone. All success for NUCD.
Professor Jayant Panda, please.
Thank you, sir. It's a close family matter. So I'm excited to be a member of the group team NUCD for all these years. And I put my heartfelt gratitude to all the national faculties, all the committee members, all the delegates who have loved NUCD in the yesteryears years. And every year we are doing better. In spite of the COVID challenge, we have kept the show going on. And I'm sure with the guidance of Professor Ashok Das, with the dynamic organization of Dr. Alok Kanungo and the whole team, Odisha can go ahead year after year launching this flagship program, and we can take academics to very high. So all every part is touched upon by all our members. I wish NUCD all success, and I wish the love and support of all the faculties, all the delegates, and all who matter to us in the coming years to take it further. Thank you, everyone.
Thank you, Jayant. Dr. Devasis Das is our youngest scientific member and most active. Devasis, please.
Sir, namaskar. Thank you, Alok sir. And thank you, Ashok sir. Thank you, Jayant bhai, for making me a part of NUCD. I feel always honored and privileged. I have been part of NUCD, I think, from the beginning. And I have seen it involving the relevant clinical aspects of diabetes management, I think, which really helps the physicians who are practicing in our, not in the metros, but also in the peripheral part of Orissa. And that is the main motive of starting this Congress. So with that note, I again congratulate Alok sir, the Mamta madam, the whole KIDS team, and our team, Sambit, Abhay bhai, Jayant bhai, Ashok sir, and Alok sir. That I hope that we have crafted a good clinical program, and all of us would get benefit into that. Thank you, sir.
Thank you, Devasis. We are just almost going to close it, but before that, Professor Ashok Das is going to have the first RJ Das oration. Before that, I will ask Professor Das to say a few lines about the NUCD. He has not told yet. And then we will request Sumitra ma'am to say whatever she would like to. Ashok bhai.
My dear friends, I'm overwhelmed by the presence of so many national experts in this meeting. I will only tell 3 sentences. Every year, NUCD Scientific Committee tries to bring in something new. Last year, we brought in, it was Saurabh's idea, we brought in the issue of a theme talk. We brought in the interviews. We brought you the thematic talks and the question answer. This year's program is centered around 3 things. Number 1, every session is followed by 35 minutes of discussion, including question answer, point of issue, and the fact of the matter, which will give you a lot of take-home message. We have a session on the clinical pearls of practicing diabetes. Number 3, this session, this particular program is also centered around the most important contemporary clinical practical issues of diabetes in 2022. If you enjoyed the program, we will hope our endeavor has been successful. Over to Alok again to invite Sumitra madam.
Respected Sumitra ma'am, we have no words to express. Professor RJ Das was the lifeline of NUCD. There was not a single conference when Sir was not present on the first line, and you have been a companion to Sir for all this time. NUCD thinks, all of us, we think that our guardian is not present today. So I will request you to say a few lines, ma'am. Whatever comes to your mind, please.
Thank you, Alok. Firstly, my heartiest congratulations to the organizers of this conference for carrying on even in this period of chaos and national calamity. I convey my best wishes for the success of this meeting, and I hope all participants will take some pearls of wisdom along with them when they go out of this meeting. Well, I'm also very grateful that Dr. Alok Kanungo of NUCD has introduced an oration in the honor of Professor Dr. RJ Dash, and my sincere thanks to the organization for the same. And as you all are very aware, and as much as I am, that Dr. Dash was totally dedicated to the cause of diabetes care. His prime objective was, of course, to educate the patients and the treating physicians so that optimum care is rendered to these patients. To strongly propagate the awareness of the increasing cases in our country, he chose students from all over India, trained them, made them masters in this field, and they diligently followed his path and have done extremely well in their respective states. And I'm very proud of this fact. Actually, when we relocated to Odisha, more than him, I was apprehensive about his academic involvement. But we were very pleasantly accepted by the fraternity, wholeheartedly, with lots of love and respect, along with a very friendly academic atmosphere to thrive on. So I'm very grateful to all the fraternity, to all people who were associated with him, with whom he was very loved and respected, and I'm very grateful for this whole thing. And my best wishes for the conference. That's all I have to say. Thank you very much.
Thank you, ma'am. Very soon please stay with us. Very soon we'll be starting the first RJ Das Gold Medal oration by NUCD. Before that, it's my humble duty, and Professor Bansali will be joining as the chairperson or with us. But before that, my humble duty is to thank everybody, starting from Professor Das, Ashok Das, Professor, all the members of the scientific committee, Professor Jayant Panda, Abhay Sahu, Sambit Das, Vijay Kumar Misra, Lalit Meher and Devasis Das, and all the seniors, all my teachers and everybody. And this time, this conference is being hosted by Dr. Kanungo's Diabetes Center, a specialized diabetes care unit at the heart of Bhubaneswar city at IRC village. And we are hosting this program along with kids and CDRF. But that is the new entity that we have created. And I want to thank all the sponsors like US Vitamin, our platinum sponsor, and Farida Madam, and all the team of USB for being with us at the time we need. Novo Nordics, Mr. Vikrant Sotria and the team along with us. There is AstraZeneca, there is Alchem, there is Abbott's, and there is Medley, and so many other pharma companies, few of other pharma companies like Mankind and others, if I am forgetting anyone, but all of them, we are grateful to them for their academic support. And Sanofi with the whole team is with us, very closely they are with us, and everybody has done their job. They have spread the message to all the delegates, and it is going to be, I think, coming 2 days will be very good. And for all these things, I want to thank RX Events, Hardik and his team, Stuti and her team, and Saurabh Tripathi, my son, who is a technocrat, who is an economist, but he has designed the whole program virtually and single-handedly. He has managed the program and still managing. So we are there, and I want to thank Mr. Krishnan Kuti, who has been in touch with most of the delegates and everybody. So thank you very much. And I request Professor Bansali to start the oration, please. Professor Bansali, please. Professor Bansali, have you joined?
Thank you. Thank you, Dr. Kanungo, for it's always a pleasure to be with you, associated with you. And I'm also grateful to you that for inviting me for the as a chairperson for the Professor RJ Dash Gold Medal oration. And it's always a pleasure that my friend and my great helper, Dr. Ashok Das, is going to deliver this first oration on Professor RJ Dash Gold Medal oration. And Professor Das, who is a doyen in the field of diabetes, who is working for last almost 40, 50 years. So 4 or 5 decades, a great experience, a great teacher, and vibrant and very, very highly active and excited in the field of diabetes. So his contribution to the diabetes is immense, laudable, and it is always have a pleasure with him to talk, and always a very, very fantastic association with him. So he is going to deliver the Professor R.J. Dash gold medal oration, and all the best to him. And I invite him to initiate the process.
Thank you, Chairperson Professor Anil Bansali. Thank you, Alok, for the great honor bestowed on me. I'm delighted that Anil, the Dayad of Professor R.J. Dash, is here chairing over this meeting. Can I start my first slide, please? Dear friend, the oration is centered around our tribute, the Odisha's tribute, the national tribute to Professor R.J. Dash, followed by on a scientific theme. Dear friend, can I have the first slide, please? Dear friends, the Professor R.J. Dash was a phenomenon. He is the legend and the towering figure of Indian endocrinology. Born in Matia, a small village in Cuttack, district of Odisha, despite his humble beginning and the innumerable hardships, he pursued his higher education from the famous Ravenshaw College. His journey in medicine began at the SV Medical College, Cuttack, following which he did his MD Medicine and DM Endocrinology from PGI Chandigarh, and incidentally becoming the first DM in endocrinology in the country. Dear friends, Professor Dash served institute tirelessly, offering 37 years of service to PGI, starting as a resident in medicine, later registrar, then lecturer, and ending up as the professor and head Department of Endocrinology in that institute. During the last leg of his period of service, he also held the post of Dean Research, and also carried out the research in the institute to the highest level. His glorious years of service at PGI, he has trained more than 70, to count exactly 73 DM residents, who are currently, as Madam said, are holding prestigious and head of the department positions in various parts of the country, headed by Dr. Anil, who was one of his most deserving and most brilliant students. Dear friends, following his superannuation from PGI, he remained academically active. He expressed his gratitude in fulfilling the vision of Professor Chutani in developing the Department of Endocrinology in PGI with contribution from other specialists. His professional contribution was rewarded in the form of many awards. I'll just cite a few. Here you see the Honorable President of India, Sri Shankar Dayal Sharmaji, awarding Viceroy Award to Professor Jiban Das. He also got the fellowship of the Royal College of Physicians, London. And at the award ceremony, the president of the college said that college is honored by bestowing this fellowship on Professor R.J. Dash, who is a legend in endocrinology. Dear friends, he has served the Endocrine Society in various positions. He has been a governing body member of both API and RSSDI. Professor Dash achieved what he was supposed to achieve. And his life is a life of an institution. It is said the life is given to us by the nature. And this life given to us by nature is short. But the memory of a life well spent is eternal. And such was the life of Professor Radharaman Jiban Das, called very lovingly R.J. Dash, who was an institution, as a family man, as a teacher, as a lover of humanity, as a clinician. and as a researcher, he has contributed immensely. And he has been regarded as the legend and patriarch of the Indian endocrinology. He was a visionary, intending to create and nurture the department both in the clinical and research laboratory aspects. His gesture of generous donations to the local newspapers, Samaja, etc., on various occasions is the proof of his gratitude and love for Odisha. He had an extraordinary existence in the medical fraternity. Dear friends, his presence was extraordinary in medical fraternity. Hailing from Cuttack, Odisha, Professor Das did proud to Odisha by holding position of eminence not only in this country but also overseas, having been the chosen one to be visiting professor to nearly 30 universities in US, in UK, Australia, New Zealand, and Bahrain. Dear friends, the picture shows he survived by his wife, Dr. Sumitra Das. Madam, we are immensely grateful you are here amidst us today. The renowned hematologist of the country, his children, Goldie, now in USA, and his son Rajiv, now in UK, and many grandchildren, and above all, by his students who are at every nook and corner of the country and also abroad. Dear friend, he was an astute clinician, avid reader, researcher, and is regarded as a teacher of teachers. Dear friend, in the memory lane, he is here is Professor R.J. Dash with Gani Jail Singh, recognizing his outstanding contribution to the public of India, to Dr. Shankar, with Dr. Shankar Dayal Sharma, with Mrs. Pratibha Patil, the President of India, receiving the award for its contribution to endocrinology in 1911. With all the Honorable Health Minister of India, I have only chosen 3. Here with Dr. Karan Singh. Next one is with Dr. Sushma Swaraj, and the next one is with Dr. Shankaranand. Dear friends, he was also great friend to many people in the country and abroad. Here is with the Prime Minister, Dr. V.P. Singh, again with Dr. Sushma Swaraj. Dear friend, he had been an ambassador of the country, but his love for Odisha was great. Here he is with his teacher, Professor B.B. Tripathi. We all bow down to you, sir. You are amidst us today with Professor Shyamji P. Moses. And he has been in the company of the best of endocrinologists who are internationally famous. He developed the radioimmunoassay in endocrinology in our country, and he had many friends, attended many conferences, and brought glory to our country. Dear friends, he has never forgotten to give his share back to the country. Dear friends, here is the company of Pochu, Dr. Pochu Pillai from AIMS, and many others. I will not be having time to show all the catalog of photographs, His Eminence. I will just say in Odisha, you can see his association with the celebrities. And sir, to make a long story short, we miss you very, our dear sir, we miss you very much. But sir, you are present amongst us through Madam and through your spiritual and subtle presence. Please accept our heartfelt gratitude from all over Odisha, from all over India, from all over the world for your immense contribution. Thank you, sir. Professor Anil, the scientific part of my presentation is of a study which I chair along with people present here today, like Dr. Prasanna Kumar, Shashank, Abdul, Jargar, and everybody in the country, the names you can take. This is called the landmark study, and I will show a few data from the study. This is the India's first nationwide longitudinal real-world study on the type 2 diabetes, nicknamed Landmark. And I just present today the first year data which has been published and the trends in the complications and the management. What is in this presentation? What was known prior to Landmark study? What did this one-year result of Landmark reveal? And what are the evidences emerging out of this 1 year data for the first time in India? And what are the clinical implications of these findings? Dear friend, this is our first paper published in diabetic medicine in UK. And here we said our first year, why the study, the rationality of the study design and the methodology of the landmark study is a 3-year pan-India prospective longitudinal study, one of its kind. And we are making all the publications out of this as a compendium of type 2 diabetes in India in the real world study. It is to assess the management and the real world outcomes in the diabetes mellitus. Dear friends, this has been the milestones or the landmark of the landmark study. We had the study design presented at EASD and RSSDI subsequently published as the study was initiated. Recruitment completed in 2018. In the IDF, we presented the baseline data. Also, another part of the baseline data and the rationale in the ADA in 2019. In the EASD, we had the American Diabetic Association, both the places. We had 6-month data in two different presentations. In diabetic medicine, published the study design. In endocrinology, metabolism, diabetes, we published the baseline data and also 1-year data subsequently. I'll be alluding to it shortly. What was known prior to landmark study? To make a long story short, I must tell you that the many of the patients of type 2 diabetes of our country, or for that matter, any other country, are not represented in the RCTs. Now, just imagine how many of the real world patients with type 2 diabetes would be eligible for the landmark diabetes RCTs. I have taken 5 landmark studies: ACCORD, ADVANCE, PROACTIVE, RECORD, and BADT study. You see, if you take the entire type 2 diabetes population with the RCT strict criteria, 11% to 3.5% to 9.2% to 18, sometimes 35% people will be eligible to be studied. This is the total Scottish Care information for the diabetes collaborative population. If you take the Royal College of General Practitioners of the United Kingdom, in the EMPIRIC study, they found only 15.7% could be eligible for the RCT. In contradistinction, type 2 diabetes patients are plenty in the real world, and patients seen in the real world and the real world practice are diverse and complex. So this real world evidence is studied for 3 years as an observational study, no intervention, no influencing of the study, as an observational study. The pragmatic randomized trial and there's a long-term phase 3 trial are not the part of this presentation. Dear friends, the study design was the RWI, real world investigations, free and constant, confirmed diagnosis, and managed. And we can see that. Now we'll see that clinical trial outcomes and actual clinical outcomes are different stories. Real world evidence helps to answer questions that RCTs cannot answer. Unlike real world evidence studies, the RCTs are typically highly selective and not to exclude people like more than 65 years, etc., which is not a badge here, is a real world study. We'll just come to the baseline characteristics of the participant in the study in the endocrinology, metabolism, diabetes. We found that the type 2 diabetes in India were different. Age at diagnosis, they were at least 10 years younger. The BMI was at least 4 kg less than the type 2 diabetes elsewhere in males and 6 kg less in females. And the median circumference was 20% less. But in contradistinction, the visceral obesity, the waist hip ratio was 5% more. The subscapular thickness and the tricep skin fold ratio was 20% higher. The fat percentage was 30% higher, and the waist hip ratio was at least 1.5 times more, and the insulin resistance was 1.5 times more in the study population. Most of the large-scale Indian studies are cross-sectional. The prevalence of the diabetes in India in the I7-INDAB study, which has been published in many papers, we find that the take-up of the type 2 diabetes occurs at about 29 to 31 years of age. Now, why this landmark study and what the gap in the data that it has breached? Now, the objective was to understand the macrovascular complications, number 1. Number 2, see the glycemic control. Time to treatment adaptation, that was one of the greatest investigational objective to time we take to treatment adaptation with subjects of type 2 diabetes over a 3 years period. We had type 2 diabetes more than 2 years duration, age at diagnosis more than 25, 60 years below. Anti-diabetic agents must be more than 2. Exclusion criteria is type 1 diabetes, secondary diabetes, and people with limited life expectancy. There are very few misses, as you see here, that we had total deaths in 3 years, CV death about 19, voluntary withdrawal of 26. But see the numbers. We had screened about 6,279 across the country in 600 centers and evaluated the baseline about 6,236. And at the end year, we had 5,654, a great retention of this study. Now, what did the 1 year results of Landmark reveal? To make a long story short, I must tell you that the average age of diagnosis of type 2 diabetes in India, according to this study, was 43 years. And we found in this study, when you took cross-sectional analysis, the duration was 8.6 years as the median mean duration, and the age of the population in this study was 52.1. And I've given the various things, the gender, the males and females, 3,500 males, 2,700 females, the BMIs and the body mass index. The other important issue was that more than 80% of the population recruited in this real-world evidence study were either overweight or obese. Majority were overweight, few were obese in the study. Now, we had looked at the demographics and the metro and non-metro. Delhi, Mumbai, Calcutta, Chennai, Bangalore, and Hyderabad were the metros. All others we classified as non-metros. And we found the parameters of the age at recruitment, age at diagnosis, and duration of diabetes, very surprisingly, were almost similar. 52.4, the age at recruitment, diagnosis, 43.8, and the duration of type 2 diabetes was about 8 years, 8.5 to 8.6 years. Now, what happened to glycemic status at the end of 1 year of recruitment to the Landmark study? This has been published again in Endocrine Metabology and Diabetes, and you will find here that the majority of the patients in this study at the recruitment had uncontrolled hyperglycemia, 3 out of 4. And we have no intervention as is, where is basis, whatever treatment they are getting. A baseline of 8.1 years, 8.1%. There was a fall of 0.5% at 1 year. It came down to 7.6. And at 1 year, both participants from metro and non-metro cities showed improvement in the glycemic status. You see metropolis from 8.1 to 7.6, and in the non-metros from 8 to 7.6. So there's improvement of 0.4, 0.5 to 0.6. Similar improvement was also observed in the impact study at the end of 1 year. How the diabetes management evolves over time and which drug classes are becoming more widely used. It's very important data. We found that OADs continued to be the main type of treatment in routine practice. In 70%, to be exact, 77% OADs were the mainstay. Biguanides, sulfonylureas were the most commonly used OADs in our country still. DPP-4 is followed by SGLT2 inhibitors, and it showed this increase. That SGLT2 use is increasing in our country rightly, and we found that increasing at the end of 1 year. So this treatment profile. Now, majority of the guideline mentioned not to go beyond 3 OADs. In spite of that, we found that about 10% participants were more than 3 OADs. Thus, adding another OAD beyond 2 to 3, does it help reduction real life? We found that that the people who are not controlled with 3 OADs, if you add another OADs, they usually degrow. That the HbA1c did not improve, rather went up. So addition of OADs beyond 3 may not yield any additional substantial benefit. So we have to stop with maximum and change over to insulin. When we added insulin, we found that the people who added insulin both in the NABE group and those who are on the insulin group, insulin OAD group, we found that there was a great improvement. We found the HbA1c came down by in the NABE group by 0.3 and by 0.7 in the insulin group. Contents of 0.3 in the non-insulin taking group, and both basal and premix were the way that people practice insulin in our country. Glycemic improved more in the insulin group, and use of basal insulin and premix insulin was associated, both were associated with glycemic improvements. Now, which are the CV risk factors most important and mostly reported in this study? Which diabetes complications are most reported real life practice? Amongst urban setting, is there a difference with metro and non-metro? Hypertension is the most reported CV risk factor in type 2 diabetes in this study at 42.606%, dyslipidemia for about 27%, albumin in 2.57%. This cardiovascular risk. And if you look at the complications in this study, neuropathy was the most important complication. Baseline 11.8, at the end 13.1. Nephropathy was the close next with 2.5 and 2.9. Retinopathy was 2.3 and 2.4. The macrovascular complications, we had maximum acute coronary syndromes, myocardial infarction, peripheral vascular disease, and stroke. This is only 1 year data. And participants from the non-metro cities had higher microvascular complications versus metro cities. We do not know the region. We're looking into the investigating the regions. Neuropathy was the most important complication both in metro and non-metro. Dear friend, just to summarize the data at the end of 1 year, is the first of its kind prospective longitudinal real-world study being conducted nationwide in 636 centers. Average age at diagnosis, type 2 diagnosis was 43 years. 80% were overweight. Few of them are obese. There's a fall of 0.5% from a baseline A1C at the end of 1 year, when the baseline was 8.1. Biguanides and sulfonylurea are the most common OADs used. There's an increase in the DPP-4I and the SGLT2I at the end of 1 year. Basal analogs and human premix are the common injectables used. There's no additional benefit of adding more than 3 OADs. Neuropathy was the most reported complications. Participants from non-metro cities have higher microvascular complications than metro cities. Dear friends, this is the landmark study. This is a study with Dr. Hemant Thakur and Dr. Prasanna Kumar have written therapy trends at the initial 6 months, presented ESD in awaiting publication. We have a few other publications like the therapy trends at 1 year, complication at 1 year, and then and various other studies which are awaiting publications. Dear friends, it's my great pleasure and honor to present this short presentation. I will again end with my tribute to Dr. R.J. Dash, and I must say that his was a life of teaching, of sharing, of building the nation and building the national endocrine force. There are few endocrinologists who can match his caliber in the country, and he investigated the usual aspects and the unusual aspect. Remember, he visited Pondicherry twice. First time he presented the gonads in the Hansen's disease, because Hansen's disease was quite high in southern India at that time. You know, his investigations, his study has left great footprints in our country. And I'm extremely happy that I have with me Anil today. Anil has compiled 2 volumes on the rounds of Professor R.J. Dash. And those 2 volumes are monumental work and has gone for the 2nd edition. And I really extremely happy that Anil's presence here proves that we are on the right track. I would like to congratulate all the students who send me messages of their happiness for having this oration first time in NUCD. Of course, we'll be having many more orations in RSDI. Of course, Anil is there in the Endocrine Society, in the various forums. But I must congratulate Anil, Arpandev, S. Murthy, and his myriads of students across the country who have sent me NUCD congratulatory notes. Thank you very, very much. Again, offering my tribute to this great teacher of teachers, and who never forgot Odisha and was very, very kind to all of us. I remain. Thank you. Thank you very much.
Thank you, Professor Ashok Das, for talking from your heart about Professor R.J. Das, a monumental figure in the field of diabetes and endocrinology in India. I'll request Professor Anil Bhansali to say a few lines about Professor Das, because he is the person who carried the baton.
Absolutely. He carried
Professor
the
Anil Bhansali, please.
Anil, are you there?
Yes, it's there.
Sir, unmute. Anil sir, unmute. Alok sir, somebody need to call Anil sir.
Professor Anil Bhansali.
He is little inattentive, so somebody has to call.
Hello.
Sir, give me just a second. I'll call him.
Yes, Tuti.
Okay.
And Jan, later when all the big people are inattentive. We remember Louis Pasteur forgot his marriage wedding day. I don't know what you forgot, but you know all the big people.
It is live. Now it is we are live.
Anil.
So on behalf of NUCD, before Dr. Anil Bhansali comes, we remember for every session, sir and ma'am, they come, they stay with us for 3 days and participate in every session. And his best session was do's and do nots in diabetes.
Exactly,
practice.
exactly.
And that was so excellent. So we are really grateful. We are missing him.
Anil?
Yes, sir. Anil ji.
Anil, please speak few words. And Alok said you are the right person who has the right to speak on about Professor R.J. Das. Very, very brief. And in advance, we have to block your time for the next years.
ये तो पुराना है, ये तो बिना पोस्ट कर ये 2021 में तो लेटेस्ट होगा ना, मेकअप में उसके बाद हॉस्पिटल में भी so ये इसी
you can unmute and speak.
2021
Let all other mute them except Anil.
Can we go ahead, sir?
Stuti, any technical problem?
Sir, he's not reachable on the phone and he's not attentive. I'm calling him again.
Actually,
we
should go ahead, sir. We are 7 minutes late.
Yeah, we should go ahead.
I think we'll go ahead, Jan.
Okay.
Alok, please come to the first session. It is to be context setting by you. Alok?
You invite both the chairpersons. Okay. Dear friends, we are starting the first technical session on diabetes and nutrition. With me, Dr. Bijay Misra, senior clinician, is there as the chairperson, and myself and Dr. J.B. Conwar, the famous endocrinologist, will moderate the session. So this is a very important thing in day-to-day practice, diet. It is very difficult to satisfy a hungry man with a limited food. So to deliver this session, we have 3 speakers, Dr. Dharini Krishnan, Dr. Sarma, and Dr. Cyril Salis. They are the speakers for this event. And with us, there is Silpa Joshi and Monica Behra, along with the speakers as panelists. So I request Dr. Misra to say 2 lines and then we start. Please introduce Dharini Krishnan.
Thank you, Dr. Kanungo. Our first speaker is Dr. Dharini Krishnan, and a leading consultant dietitian in Chennai, breaking new grounds in the diet counseling, consultant dietitian in her own clinic in Mylapore, Chennai. Her thesis was effect of diet counseling and exercise on the subject with type 2 diabetes mellitus. Dharini conceptualized and created personalized diet software, Digest, a tailor-made software for dietitians. She had also her own app, NutriTax, and it was used
for research purposes. She used to run free clinic for Hinge and giving articles and comments in the print media such as newspapers and magazines. As you know that the nutrition management is very, very important, and she is going to tell us on the latest advances in nutrition management is simplified about that. So, Madam Dharini Krishnan, please.
So let's look at what is the definition of nutrition. Nutrition is the process of providing or obtaining the food necessary for health and growth. Management is the way something is handled, careful treatment, supervising skills. Nutrition management is an approach to healthcare delivery that focuses on complex needs of the patient and emphasizes the coordination and prioritization of all needs. So let's just take a look at some of the data that we have, recent data related to diet. So the first is dietary fiber and gut microbiota. There is evidence that diets that are high in fat and low in fiber may promote gut microbiota dysbiosis. That is basically it interferes with the type of bacteria, the good bacteria that exists in our gut. But what does a high fiber do? It actually brings back the good bacteria and eubiosis happens. That is, it promotes the right type of bacteria in the gut. Now, dietary fiber has been reported to be a major energy source of the intestinal bacteria and thus can be significantly affect the diversity of the gut microflora. The recent trend is towards plant-based diets. We dietitians have always been saying vegetables and fruits you need to take more, and India is taking very less of both of these types of food groups. The 2021 was made the International Year of Fruits and Vegetables. See how important it is even worldwide to make people realize the importance of fruits and vegetables and through that dietary fiber for health. So this is a new name with dietary without dairy. Is it for the larger population? Is it going to work? Because India is already lower in the protein that we take. But what are the advantages? If you take a lot of vegetables and fruits, there is weight control, there is blood pressure control, the lipid profile comes back to normalcy, and there is glucose control. So let's go through a meta-analysis of fiber and diabetes. There's the effect of dietary fiber on gut microbiota, increases in the abundance of bifidobacterium. The role of the dietary fiber is to increase the short-chain fatty acids. And what does this do? It actually reduces the inflammation and also reduces the insulin resistance. So glycemic control happens due to fiber intake. The A1C gets improved and there is weight reduction. Next is low carbohydrate diet, which is the latest trend too. A low carbohydrate diet significantly improved depression and the 3-month average HbA1c. And also it increased the short chain fatty acids, which we just saw reduces the inflammation and insulin sensitivity. And the bacteria which were produced are Roseburia, Ruminococcus, and Eubacteria. The GLP concentration 1 in the LCD group was higher than the LFD group. But how many clients, because they used an almond-based diet in India, how many people can afford that many almonds a day? is a big question mark. So the next one is a different type of prevention, a lateral thinking, where in a continuous remote care intervention, focus was on reducing hyperglycemia through carbohydrate restricted nutrition therapy for 2 years. And what happened is there was actually the cumulative incidence of normal glycemia was more than 50%, and type 2 diabetes was only 2%. And this population were of 96 people, who 72 of them continued for 2 years, and in that they were impaired glucose tolerance. So only 3% moved to diabetes and the rest were in normal glycemia. So prevalence of metabolic syndrome, class 2 or other obesity were also reduced. So these results demonstrate a potential utility of an alternate approach to type 2 diabetes prevention. Carbohydrate restricted nutrition therapy delivered through continuous remote control to keep hand-holding the client for normalization of glycemia and improvement of related conditions. So I think this has a very important role to play in the Indian scenario. Let's run through the carbohydrate and how the diets have been done through the years. 800 BC Ayurveda classifies diabetes into 2 types, the Avarna and the Daktasya. The first type is caused when the channels in the body are blocked and aggravated by kapha dosha. This is the usual cause of adult onset diabetes. The next one affects the tissues and was classified later as juvenile diabetes. But the main problem is the digestion fire, or Agni as they call, is affected, and hence digestion is affected, and this can lead to the problem. So they spoke about having a larger meal at noon and a light breakfast and dinner, and also to avoid sweet and sour taste, which increase the kapha dosha. 15,000 BC, the Egyptians gave a high carbohydrate diet because they found that urine had sugar, so they thought they had to replace that. In 1780s, the French brought lower carbohydrate foods. In 1939, the Lawrence line diet, where carb counting and the amount of carbohydrate foods was done. In the 50s, 20 to 40% of the diet was carbohydrate. In the 1980s, Professor M. Vishwanathan brought out the high complex carbohydrate, high fiber diet, which is basically whole grains and whole pulses, and with a lot of vegetables and fruits, which can control the glycemia. By the end of 1990, we moved back to the keto diet, a high-fat, low-carbohydrate diet. Now we are at low carbohydrate and a very low carbohydrate diet. Are these sustainable? This is a big question mark. Even as low as 30 grams carbohydrates a day, there are people who are making people follow these diets. 120 calories of carbs and the rest from protein and fat? And is it sustainable? Will digestion happen? These are very big question marks. So what is the way forward? A detailed diet history should be taken by a professional so that all the nuances are there and the details are in place related to the measurement of the diet. Customize the diet to the individual. Reduce the carbs per meal and use complex carbohydrates. Increase the protein and include it at least in 2 meals, if not all the 3, because India is very, very less in the amount of protein that we take every day. Lot of vegetables and fruits and the right type of fruits. Less snacks, have nuts for snacks. Now the EAR and RDA, which came out in the year 2020, we saw that the EAR, which prescribes a little less of protein, is more doable for the Indian scenario. So 0.6 grams per kg ideal body weight versus 1 gram per kg ideal body weight. So let's do a little bit of calculation in the very low carbohydrate diets. If a person's height is 158 centimeters, his weight is 65 kilos, the ideal weight should be 56 to 60 kilos. So if I put 0.6 per kg ideal body weight, the amount of protein to be taken is 36 grams. And if they are following a very low carbohydrate diet, 30 to 40 grams of carbohydrate. So let's take it as 40. So let's average it out to 40 grams of protein and 40 grams of carbohydrate. You would get only about 300 odd calories from these two. And what would you do for the rest of the calories? Are you going to get it from fat? Are we not the cardiac capital of the world? Can we digest it? These are all questions to be answered. So what are the complex carbohydrates you can include in the diet? Wheat, millets, roast, fermented and sprouted millets, because on roasting or sprouting or fermenting, the goitrogenic effect is lost. Red rice, semi-polished rice, fruits also have carbohydrates. So choose the low carbohydrate ones like musambi, or you can use papaya and think guava and so on. Complex carbohydrates from vegetable, banana stem, banana flour, green leafy vegetable. We have the highest biodiversity in our country and a lot of beans. We have almost 5 to 6 types of beans variety, all our traditional vegetables. Protein, whole pulses whenever possible, dal every day for vegetarians, as dal sambar, or you can use it in other items like a dosa made out of dal, or an adai, which is a different type of dosa made out of dal, or a vegetable which includes dal also. Soybean, mushroom, milk paneer and curd. So kuch jyada karo is the mantra because everybody is taking less. In the non-vegetarian kingdom, eggs, fish and seafood and chicken are safe, but definitely grill them, use less oil in cooking. Fats, 15 ml of oil per day, half a liter per person per month. 10 ml can come from traditional oils and 5 ml can come from ghee or sunflower oil. Current scenario, the 4-member family would require 2 liters of oil per month, whereas they are taking 4 liters or even more sometimes. So what are the 5 food groups? Grains, proteins, vegetables, fruits, and dairy. All are important. You cannot drop, and all are important on a daily basis. So grains shift to whole grains. Proteins increase because we are doing very less. Vegetables increase the same. We are using 2 tablespoons when we have to use a cup or a cup and a half in each meal. Fresh fruits increase the same with the right type of fruits. And dairy around 400 ml per day in the coffee, tea, and the curd that you use. And it should be 2% milk. Indian spices, turmeric. We can use it in our regular. We don't need a turmeric latte. Cinnamon is anti-diabetic. Pepper, use a little in soup or rasam. Cumin for better digestion. Tulsi is good, and citron leaves is high antioxidants. There are superfoods such as moringa, which we have forgotten. Start using them. Curry leaves, please use it. Don't throw it out, but bite into it or grind it and put it into your food. Buy less of packaged foods. Even chips has trans fats and sugar, so let's be careful. Learn to cook a healthy meal. Don't look at the shows and learn, because too much oil and traditional food is not the home way of doing it. They add too much oil or they add sweet corn to everything, which is not good. Is there one diet that is good for all? Absolutely no. We have to do it, customize it, and customize the carbohydrate, protein, and fat. And this should be done according to the person's requirement. So this is a typical thali that one could use according to the my plate, an 8-inch plate where quarter is grain, quarter is protein, and quarter is fruit and quarter is vegetable. And you can add an amla there too with a little dairy to add to the total food groups. But when you come to cups, it's about a cup of rice or millet, a cup of cooked dal, and 2 cups of vegetable, or 1 cup of vegetable and 1 cup of fruit. This is how it should be done. Let me give you an example of a patient who was 128 kg and actually went for a gynecology appointment, but was wheeled into the bariatric unit. So she was just 30 years and has 3 children, did not want surgery and came for help. Options available, meal replacements. It's affordable to her, but she's tried earlier, did not like it, and dropped it and gained weight from 98 to 128. Regular diet, but weight gain was huge and was not ready to wait for a loss of 1.5 to 2 kgs per month. Was ready to do intermittent fasting, vegetarian, with no other health issues at that point. So she lost in 10 months 47% to 30% body fat. Her weight dropped from 128.8 kgs to 77.9 kg, almost 3.7 kg loss per month. She was so thrilled that she started fitting into dresses which she could never even imagine. And in 365 days, she had lost about 50.7 kgs and her BMI had come down to near normal, which was not there before. Her blood parameters, her fasting moved from 109 to 94 and her cholesterol moved from 239 to 217, and the VLDL, which was at 53, came down to 26, and she was moving towards the impaired glucose tolerance of A1C of 5.9, which came down to 5.6. Diet followed. Between 8 a.m. and 2 p.m., she did the 16-hour fasting, and she did pumpkin juice to start with, 2 cups of fruits, the right type of fruits, and she was vegetarian, so dal either as whole pulses or sprouts. Mid-morning, she had a coffee, no sugar. Lunch, she had 100 ml of curd, 200 grams of vegetable, and 100 grams of dal, either as dal or chila or adai or pesar, which is dosas made from dal. 2 p.m., she had her coffee. She did extremely good exercise, the balanced diet. She reached almost the right proportions of carbohydrate, protein, and fat. No special foods, home-cooked foods, tweak for extra protein, pulses in different forms, vegetarian with dairy, no eggs, no protein supplements. Here's how to prevent muscle mass. Eat protein foods, because usually in weight loss, people lose muscle, which is not good. But eat protein foods and your muscle will be there. Do resistance exercise. And the client did 1 hour exercise with a professional trainer to make her muscles be intact, and slept for 7 hours. She got enough vitamin D too. So how does 1.2 kg increase in muscle mass help in type 2 diabetes? No difference in insulin sensitivity, but definitely A1C comes down and medication comes down. How does 10% increase in skeletal muscle index help in pre-diabetes? It also 11% insulin resistance is reduced and 12% pre-diabetes is reduced. So intermittent fasting for diabetes, you can even do a 14-hour fast with 10-hour feeds, and in 10 hours, only 2 meals and 1 snack. All 3 need protein to get the required quantity. Diet that can be followed 8 a.m. to 6 p.m. You can't sleep till 12 noon and eat from 12 to 8 p.m. Not done. You have to get up early. Breakfast, 1 cup of fruits, the ripe fruits. It can be followed by 1 grain item, either idli or roti or upma or poha. And then
I think it's time. We can wait for 2 minutes.
Lunch can be 200 ml of curd with vegetables and 100 grams of dal in whatever way possible. 6 p.m. could be milk, coffee or curd, 200 ml and 100 grams of dal in whatever form. So what decides what type of diet you follow? It's not one fix for all. It is the body type that is very important. Eating habits, that is where Ayurveda, according to Prakriti, can analyze your body type, and the eating habits has to be taken into detail. Type of exercise should be prescribed. And here Ayurveda helps because recently I have been doing integrated dietetics for the past 3-4 years very seriously with most patients who are ready to follow it. And we are able to crack the nut because we are able to give foods which are digestible to them according to their body type, the Prakriti, and according to that, they are actually digesting their food. So eating food is one thing, but digesting and assimilating food is another. And this works real wonders. So what is the way forward? It is integrated dietetics, where you actually can make the modern dietetics and you can analyze and work with the Ayurveda or Siddha Unani person and make them know the body type of the person, what are the foods they are able to digest and not digest, and tweak your diet according to that. So this is the way forward because we need to digest our food to sustain the diet. It has to be comfortable. We as dietitians may give a lot of dal, but they have to be able to digest it. So we have to give it in forms and ways and include the spices to make it easy to digest. And this way, we can handhold our patients and help them to maintain their diabetes. Thank you very much.
I now request Dr. Sarma to carry on the interview, and I am doing the interview. Dr. Sarma, S.K. Sarma from Jaipur. Dr. Bijay Misra kindly introduce Dr. Sarma.
Welcome, Dr. Sarma. And his interview will be on a reversal of diabetes through lifestyle modification. And Dr. Sarma is DM endocrinology. This is DM endocrinology from Chandigarh, and is a consultant endocrinologist at Galaxy Specialty Center, Jaipur, and past ex-professor of medicine, Mahatma Gandhi Institute of Medical Sciences, and 26 research publication in index journals, chairperson of Diabetic Welfare Society, and chairman Diabetic Thyroid Endocrine Conference. And there are a lot of publication to his credit. And Dr. Sarma, we invite you for the interview with Dr. Alok Kanungo on reversal of diabetes through lifestyle interventions. Dr. Sarma and Dr. Kanungo.
Welcome to NUCD 2022. In today's session, our theme is nutrition and diabetes. You have already heard to some important talks. I have now very important duty to interview one of the finest endocrinologists of the country and with huge clinical experience, Dr. S.K. Sharma from Jaipur. Welcome to this interview, Dr. Sharma.
Thank you, sir. Thank you, Dr. Kanungo.
You know, Dr. Sharma, now there is a lot of discussion. Everybody, more patients are discussing than doctors that diabetes can be reversed.
Yeah.
What is your take on that? Can it be reversed?
I think it is a very important question, Dr. Kanungo. Earlier, we used to say that diabetes is a chronic disease and it is a constant and permanent disease. And once a patient is diabetic, he will remain diabetic. But recently, for the last 10 years or so, we have got significant data and studies telling us that we can reverse diabetes, we can revert diabetes. So now our emphasis is particularly on newly diagnosed type 2 diabetic patients where they are slightly obese or obese, they have short duration of diabetes, and they have milder hyperglycemia. These type of patients are given a very intensified lifestyle measures, particularly as you rightly highlighted, lifestyle measures, particularly in the field of caloric restriction. And once they lose weight, a weight loss of something like 10 to 15 kg within a short period of 2 or 3 months, many of these patients revert back to normal. Their fasting postprandial glucose profile as well as 3 months of average HbA1c also revert to normal. So now we have started using this term of reversal of diabetes.
But do you think reversal is genetic also? Can patients, those who are genetically predisposed, immunologically predisposed, autoimmune predisposed, can they be reversed?
Yeah, as we all know that diabetes is of different types as classified like type 2 diabetes, type 1 diabetes, MODY, genetically challenged diabetes. So here you find that those patients who are type 2 diabetes and overweight or obese, they are in this range of to be converted into normal glucose tolerance. People like type 1 diabetic patients, MODY patients, or patients who are suffering from secondary diabetes, or those patients who are having long duration of diabetes and lean and thin, they have really not shown good response in the field of reversal of diabetes.
Then a question comes to my mind that what is reversal? Then what is remission?
Well, reversal, yeah.
We know that when blood sugar comes down and it doesn't come up for some days, for months together, we think diabetes is remission. So is there any difference between remission and reversal of diabetes?
Well, most of the time what happens, we use these two terms, reversal and remission, interchangeably. But if you look carefully, we know we are using this term reversible. Once remission is there or reversal is there, there is a finer difference between them. Remission means after some time, these patients may revert back to hyperglycemia and type 2 diabetes. But reversal means probably they will remain free from diabetes. These are the finer difference. Otherwise, most of the time, literature is interchanging them.
Means that can be one patient can have reversal or remission in different stages of life.
Absolutely.
As one of the speakers recently told that there is a re-reversal, means when the patients are going for reversal, again they are coming back to normal stage.
Absolutely. Yeah. Actually, now a concept of de-differentiation of beta cell is there. What happens because of lipotoxicity and glucotoxicity, the beta cells are not able to cope up with this load and they differentiate into null cell. So earlier we used to thought that probably there is a loss of beta cell, but now this concept of de-differentiation is there. So if the lipotoxicity and glucotoxicity is used, then these cells start behaving like normal cell, not beta cell. So they do not produce insulin. But once you take care of lipotoxicity and glucotoxicity, after some time, they de-differentiate into beta cell and they start producing insulin secretion. So probably genetic genes which are regulating the insulin secretion is inhibited because of lipotoxicity and glucotoxicity.
So these two metabolic things are very important in while discussing remission or reversal. So scientists always discuss that there is a twin cycle hypothesis.
Absolutely.
So this is a little intricate. Can you throw some light on that?
Absolutely. This is a new concept of why the diabetes is developing. And once you revert it, you may bring the patient back to normal glucose. So they say that because of nutritional overload, there is increase in nutrition, increase in lipogenesis, and liver is also having huge amount of you can say adiposity and lipogenesis there, and de novo lipogenesis is also occurring in the liver, and because of this the hepatic glucose output is continuously there. We all know that insulin inhibits hepatic glucose output, but once the patient is having de novo lipogenesis and fatty liver and fatty infiltration, then you find that insulin is unable to produce inhibition of hepatic glucose output. So because of excess glucose output from liver, there is a continuous stimulation of beta cell and there is a fasting hyperinsulinemia. And in the presence of insulin and excess of nutrition, liver keep on producing excess of de novo lipogenesis. And once liver is full of lipid, then it starts secreting VLDL1 triglycerides. So VLDL is going from the liver and going to the periphery. Once the peripheral adipose tissues are saturated, then this VLDL is deposited into ectopic sites. And one of the important ectopic site is pancreas. So you find that pancreatic beta cells are also having huge amount of lipid. Particularly, they say if the patient liver is producing de novo adipogenesis, then palmitic acid is secreted in large amount. And this palmitic acid as a triglyceride is inhibiting beta cell. So now what happens? Beta cell is not able to respond to glucose. And there is a continuous declining beta cell insulin secretion. And this is twin cycle. One is hepatic cycle and the other is pancreatic cycle. So it starts with excess nutrition. Lipids are deposited in the liver. This is lipid cycle. Then lipids are going from lipid to the periphery, ectopic adiposity, and then pancreatic beta cells are damaged and they are de-differentiated into null cell and they do not produce insulin. And now what happens? You have a diabetes. And now you can reverse the process. How come? You start reducing significant amount of calories. So once you have significant decrease in caloric input, within a short period, the liver will start showing a decrease in fat. So the liver fat will rapidly decrease. Once liver fat will decrease, the VLDL from the liver will decrease and the ectopic sites are now, you can say, removed from the deposition of fatty acids. So you find that first there is a recovery of liver followed by ectopic sites like pancreas. So now pancreas also started de-differentiating and showing increase in insulin secretion. So you have better liver and better pancreatic function.
So that means once the calorie intake is reduced, weight reduction is there, and together there is a metabolic change, and this hepatic cycle is also controlled, and ectopic sites starts relieving the fat content and they start operating normally.
Absolutely.
This is the basic pathophysiology or mechanism of this change.
Yeah.
So, do everybody respond to this?
No, not all the patients will respond. I can just throw some light. Those patients who are having shorter duration of diabetes, those who are type 2 diabetic patient and younger patients, and those who are overweight and obese, these are the patients where you find very good results. So most of the time we see good results once the patient is having shorter duration, like less than 4 years of diabetes, and their HbA1c is not very high, and they are younger in comparison to other patients. And once you give them this diet restriction, and they have some 10 to 15 kilogram of weight loss within a short period of 2 to 3 months or so, then they will revert back to normal glycemia.
And to maintain that normal glycemia, what do they have to do?
In studies, what they have done, they have started increasing their diet, but still they provide them a very tight dietary schedule and physical activity. And as we all know that it is very difficult to maintain the lower weight. Most of the time, what happens? You have gradually increasing weight after some time. So that is again a very big problem in these patients. Till now, we have seen a documentation of 2 years of reversal of diabetes in direct study. So that is, we hope that if the patient maintain his weight, then he may have normal glycemia for a longer time. But at present, we don't have much data more than 2 years.
So this is not a general recommendation to all diabetics.
Yes, absolutely.
It has to be chosen by the physician or the treating doctor, and he has a choice to select the typical patients.
Absolutely.
So, what evidence does the reversal creates so that a physician can tell now you are on the reversal of diabetes? What are the evidence for the clinicians?
For the definition of reversal, we say that fasting should be less than 126 milligram%. The HbA1c should be less than 6.5%, and patient has lost something like 10 to 15 kg of weight, and they have stopped using their drugs. And you can repeat the HbA1c after let's say 6 months, and it is maintained there. Then we say that it is reversal. So you have to wait for 6 months or more. Fasting and HbA1c remains low, normal in normal range, and they are not taking any oral anti-diabetic drugs. Again, one important point is it is seen in those patients who are on oral drugs. Those patients who are on insulin, type 2 diabetic patient, we all know that they have longer duration of diabetes and very severe diabetes, very high HbA1c. The chances of them reversal is very, very low.
Yes. So, Dr. Sarma, you have highlighted that low calorie diet is the key to reversal of diabetes. So there are, as you know, very low calorie diet and low calorie diet.
Absolutely.
What is the difference and how do you recommend that?
Well, people have divided this low calorie diet like very low calorie diet where 20 to 50 gram of carbohydrate is given. Then low calorie diet 50 to 130 gram per day. And then normal diet means where we say that it is 130 to 230 gram of carbohydrate, and high carbohydrate means more than 230 gram per day. So depending upon the amount of energy derived from this carbohydrate, we say that it is very low or normal or very high carbohydrate. So now people are looking into whether it is only the caloric restriction or carbohydrate restriction. So at present, we have evidences for both. But in diabetic patient, people are arguing that probably carbohydrate restriction is showing better results as compared to caloric restrictions.
Carbohydrate restriction will not cause hypoglycemia.
Well, you have stopped giving oral anti-diabetic drugs to them. So you stop the drugs right from the beginning of this, you can say, trial where you want to revert the diabetes. So once you are not giving any oral anti-diabetic drug, patient will not develop hypoglycemia.
But if you do not give any drugs, there will be increase in blood glucose maybe in some cases.
Well, absolutely.
So how do you handle it?
Yeah, that's why what happens, we usually select these patients like they have milder hyperglycemia, short duration, they are not on multiple oral antidiabetic drugs, and they do not have insulin on board. And even if they have, you can say hyperglycemia, you can use a drug like metformin. So you can use metformin for some days and weeks, and after let's say 7 to 14 days, because within a period of 7 days, liver fat is reduced by 30%. So that twin cycle is now started reverting back. So you find that improvement starts occurring within a period of 7 days in these patients.
Very nice. Talking to you has been a great pleasure. And very quickly, role of insulin resistance, adipose tissue dysfunction, and metabolic syndrome. 1 minute, please.
Absolutely. So this is a newer concept where adiposity related chronic diseases model are now coming in, where excess of nutrition, excess of adiposity leads to development of insulin resistance. And this is then further progresses to metabolic syndrome, and many of our patients further progress to type 2 diabetes. So this is a continuum. And if you further go, you find that complications of diabetes and complication in the form of cardiovascular diseases are also higher in these patients. So insulin resistance, metabolic syndrome is now very closely linked, and they are also important cause of cardiovascular diseases and risk factors like hypertension, dyslipidemia, and type 2 diabetes. Thank you.
Dr. Sarma, there are a lot of advertisements that come to us will reverse your diabetes.
Absolutely.
So
now this is a very
about that popular advertisements by not so qualified people.
Absolutely. So our message to our friends and our patients are that they should be not generalizing it. Look at your profile, go to a qualified doctor, and then try to achieve this reversal. So as we discussed, shorter duration of diabetes, milder diabetes, overweight or obese, not on multiple oral drugs or insulin, and then of course you may have reversal of diabetes. Thank you.
Thank you, Dr. Sarma, for your excellent interview, and we will be meeting again in the panel discussion.
Thank you, sir. Thank you. It's always it's always a pleasure to be with you. Thank you.
Thank you so much.
Good day.
Good day.
ये स्पॉन्सर मैंने मुझे थैंक कर दो.
Thank you.
And we can invite Miss Cyril Salis.
Thank you, Doctor. We have a lecture again by Dr. Shirley Salis, and she will be talking how to plan a low carbohydrate diet in the Indian setting. This is to introduce Madam, and she is a registered dietitian, certified diabetic educator, insulin pump specialist, and a certified sports nutritional and low food map dietitian, certified onco nutritionist, and founder director of Nurture Health Solutions, author of Diet in Diabetes Simplified. She has very rich experience over 22 years in the field of dietetics and diabetic education, and a recipient of many awards. And she has authored the award-winning book that is Diet in Diabetes Simplified. And with this, actually, we invite Dr. Salis for how to plan a low carbohydrate diet in Indian setting. That all of us, we know that Indians have carbohydrate-centric diet, and naturally a low carbohydrate diet is the order of the day. So users to our delegates, you can tell us how to plan it.
Thank you so much, Dr. Mishra, and thank you, Dr. Kanungo, Dr. Panda, Dr. A.K. Das, and all the organizing team for inviting me. It's always a pleasure to be a part of NUCD, and we definitely...
Congratulations for the Sadhana Award 2022.
Thank you, Dr. Panda. Thank you so much, sir. And Excuse me for my voice. I've got a bad throat and I have a bad cough. So please pardon me for that. And on that note, I'm going to speak about how to plan a low carbohydrate diet in the Indian scenario. And we all know, I think this is something that we've seen time and again. We keep talking about it, and we have enough evidence to show that yes, India eats a lot of carbs. We are protein deficient. Also, the quality of carbs is a concern in our country. So, we are a carb loving country, like Dr. Mishra said. And we know that a high carbohydrate diet from the Pure study has clearly shown its association with mortality risk. And where fat was considered a villain in the past, today, people are wondering whether is carb the villain, and should we go on a carb-free diet, especially in a person with diabetes. Now, in spite of all the education and everything else that we are doing to spread awareness about nutrition, about lifestyle modification, about diabetes education, we still have a large number of people in our country who are uncontrolled. In fact, the ICMR India study has clearly shown that our population has an HbA1c between 8 to 9%, which is much higher than the desired target range. And if you see that the contribution of the HbA1c is mostly from your postprandial blood glucose levels, and we are constantly in a postprandial blood glucose state because we are constantly eating, and our meals, including our snacks, are very high in carbohydrates, which are increasing the post-meal blood glucose values. And therefore, the high carbohydrate consumption is definitely associated with high postprandial values. And here is where nutrition and lifestyle modification plays a very, very key role. And planning, or designing a meal plan which is moderate in carbs will definitely help. Now, the biggest challenge, even when we take dietary recalls of our patients, especially even children, and today, in fact, in the pandemic, we have seen a large number of children with type 2 diabetes and obesity and insulin resistance, PCOS, hypothyroidism. All these numbers are definitely on the rise. And therefore, if you look at the kind of snacks that we eat, even our dinners have been replaced by snacks, especially from the part of the country that I am in, the western part of India. The dinners are usually a snacky meal, like it could be a pav bhaji, or it could be a sev puri, or it can be a sandwich. And if you see that they are very high in, one is refined carbs, secondly is the amount of fat content, the sodium content, and also the snacks, mid-meal snacks, whether it is between breakfast and lunch or between lunch and dinner, typically is a packet of biscuits, or it could be some, packaged item like a chuda, or, they think that diet food means it is carbohydrate free, not realizing that even ragi chips are going to be high in carbohydrate as well as high in, sodium, even though if it is roasted. And therefore, very important is to look at what is the diet that needs to be given. Initially, some years back, especially when I started my practice 22 years back, we had a general diabetic diet. Everybody was given the same meal plan, no matter from which part of the country they came from. So it was a 1200, 1400, 1600, 1800 calorie plan, and we just put the numbers in the plan. It was cyclostyle sheets. The list of no's was more than the list of allowed foods. And therefore, people used to ask us, Madam, should we eat this before food or after food? Because there's a very small list of what to eat. And usually everything went in the avoid or the restricted food items. There were no follow-ups. People really didn't come to us for a follow-up. And therefore, we did not know whether are they following the diet, what is happening to them, how is their HbA1c improving. They did go to the doctor, that also not on a regular basis, but a follow-up to the dietitian was very poor, and it was a one-size-fits-all. Today, it's no longer a diabetic diet. Everybody in the family is encouraged to eat a healthy eating plan. Therefore, otherwise it becomes a big problem for the woman of the family to cook separately for in-laws, separately for the spouse, and separately for the children. And if she has diabetes, it becomes even more challenging because she's not able to follow anything, because it's becoming too much for her to anyway satisfy the, the demands in terms of food of everybody else in the family. It's not a one size fits all, because today you have people on different medication, different kinds of insulins, and therefore it has to be a customized. And when I say designer meal plan, it does not mean including a lot of exotic, expensive foods. It has to be also affordable, especially in today's scenario. It has to be flexible, because you have to plan, and even the ADA guidelines clearly state that there is no fixed or there is no fixed ratio of carbohydrate, protein, and fat, and you decide what is best for your patient. It definitely has to be personalized. Again, India is very diverse in our food habits. North eats very different to South, East eats very different to West, and therefore a person from East India has to be given a meal plan which he's used to eating, because that is easily implementable as well as it is sustainable in the long run. Because that is a basic challenge that we encounter: compliance to following the meal plan, and therefore sustainability is a big issue in our country. And this study by Sarah Siddleman has clearly showed that a very high carbohydrate diet as well as a very low carbohydrate diet, both are not desirable, and therefore achieving a good moderate carbohydrate amount of, say, 45 to 50%, or as per the study shows that 50 to 55% is associated with the lowest mortality risk. And even in our clinical practice, we have seen that moderating carbs to around 50%, improving the quality of carbs, including protein in the diet, definitely helps. And therefore, today, the new concept of culinary science has come, because people are fearing food. They are looking at food as with fear, and we don't want them to do that. We want them to enjoy food, enjoy a good quality of life of living with diabetes and living well with diabetes while they are enjoying different varieties of food, especially what they are brought up eating or what they're grown eating. Bring back the joy of eating and living with diabetes. Definitely focus on quality and quantity. Sometimes people tell us that noodles, if I'm eating a noodle packet, which is going to give me, say, 200 to 300 calories, versus eating my chapati bhaji, which gives me 200 calories, what is the difference? I can still eat noodles because at this time I'm controlling my caloric intake. But what is the quality of calories I'm consuming? Here I'm eating something which is from whole wheat, which has got fiber, it's got the essential nutrients. Whereas when I'm eating a noodle made out of, maida or refined flour, my quality of carbs is definitely lower and it does not have any fiber. Reinforcing Indian traditional dietary practices. And we just recently had a paper published in the Nutrients on this, where even if you look at East India, whether it's panta bhat or pakala, which is a very commonly consumed item in eastern part of India, it itself offers a lot of nutritional benefits, especially when we're talking about improving gut health and prebiotics and probiotics in the diet. Now, definitely we need to look at lowering the carbs, so therefore reduce the carbs, where the START study has shown that Indians consume around 65 to 70% of calories coming from carbs. Even if we are able to moderate it to around 45 to 50%, we can achieve a good glycemic control. Improve the quality of carbs, definitely increase the fiber to 20 grams per 1,000 calories, include lentil carbs, resistant starch rich foods, reduce the calories if the person is overweight, and reduce the consumption of processed and packaged foods. While we are doing that, improve the quality as well as quantity of protein, because the protein definitely is a concern in our country. Even if we are non-vegetarian population, we have seen that protein, the amount of protein that we consume is definitely lower. And where fat was vilified in the past, today we are talking about including good quality fats in the diet, which is going to help in improving the heart health as well as improve the glycemic index of the meal. Now, this is the exchange list that we follow, and this is from the IFCT 2017 data. And if you look, 30 grams of cereals gives you roughly around 15 grams of carbs. Now, why I'm saying this is, a lot of people think that ragi or bajra or jawar is very good for people with diabetes. But what they need to understand is, if I'm going to take 30 grams of any cereal or millet, it is going to give me around 22.5 grams of carbs. Whereas for the same amount of pulses, I get 15 grams of carbs. So the carbs is lower, whereas the protein content goes up. Soya bean is very, very good in terms of, having low amount of carbs, but having good amount of protein. But very important is the way we cook soya bean, because it also has got certain goitrogenic compounds. And similarly, if you look at vegetables, especially when we tell them to eat a vegetable, they will eat a starchy vegetable. Like it could be potato, or it could be arbi, or it could be yam, which is going to have far more higher amount of carbohydrate compared to your green leafy vegetables and your gourd vegetables. And therefore, it's very important to specify that when we are talking about making 1/4 of our plate cereals, that also includes millets as well as starchy vegetables, because they will give or they will contribute to carbs. Now, nuts are a good inclusion in a person with diabetes because they have good MUFA fats. Some of them have good omega-3 fats, as well as they have essential micronutrients. And if you look at the carbohydrate content, 15 grams of nuts gives me only 0.4 grams of carbohydrate. And therefore, we can replace our snacks, especially, the biscuits that people eat. And people buy oats biscuits or ragi biscuits because they think it is diabetes friendly. But if you look at the food label, there is only 6 to 10% of oats, or it could be 6 to 10% of ragi, and the remaining is all your refined flour, sodium, it's got preservatives, and people end up eating the entire packet of biscuits because they feel that biscuits, if it is a diet biscuit, it is very good for health, and then their blood glucose levels are all hitting the roof. Sugar and jaggery has the same amount of carbs. A lot of people think that jaggery or honey has got lesser amount of carbs compared to sugar, but in terms of the carbs, for the amount, it has the similar amount of your carbs. Now, fats are definitely having no carbs, and as well as your non-veg foods. So if you include chicken, fish, or eggs, it has got zero carbs. But also very important is to look at the amount of saturated fat in the diet, and therefore everything in moderation is recommended. Definitely, when we're looking at carbs, you also have to look at the glycemic index as well as the glycemic load, because foods with low glycemic index and glycemic load have shown to improve your metabolic risk profile. And just following the plate method, I think this has made it very simple for us dietitians to improve our counseling skills, especially, and get compliance from patients, because you take a 9-inch plate, you fill half your plate with non-starchy vegetables, 1/4 of your plate with protein, and 1/4 of your plate with cereal, millets, and starchy vegetables. It becomes very simple to implement, and this is the best way of moderating carbs in the diet. Also about including fiber as well as protein in the diet, and this should be replicated at each meal, whether it is your breakfast, whether it is your lunch, whether it is your dinner. And it is very possible with our Indian traditional meals. You do not have to cook something very exotic or elaborate. Very simple, our Indian meals are able to, we are able to achieve the moderation in terms of carbs, improve the quality and quantity of protein as well as fiber in the diet. Now, when we're looking at chapati, okay, and this is from a study done by Dr. V. Mohan's team, where they've taken 2 kg whole wheat flour and added roasted Bengal gram flour. And as I showed you, the 30 grams of roasted Bengal gram flour will give you 15 grams of carbs. They've added isabgol husk and bittered methi powder. And by just doing this, one is you moderate the amount of carbs, you improve the quality of protein and quantity of protein, you add fiber, as well as you reduce the glycemic index of the roti. And this is something that can be done by the entire family, not necessary by only somebody who's having diabetes. And there is no necessity of buying a diabetic atta, which is going to be more expensive to your regular flour. This is something that can be done in the house. Food order is another very important study, and this is a beautiful study done by Dr. Alpana Shukla, who's been a very good friend of mine, and we worked together 20 years back. And where you start the meal with salad and protein. So you start your meal with salad, and then you add, either curd or paneer or egg, depending on whatever protein is in the plate. And you start your meal with that, and then follow up with your roti or your rice and your vegetables. And by doing this, you improve the postprandial blood glucose response. There's better satiety achieved, as well as including protein and fiber in the meal. And this is something which is very easy for us to explain to the patients and get compliance. Now, we're all doing everything virtually, so put on your mask. I'm going to take you on a virtual tour of India and talk about certain foods, which we eat in our daily practice. So while chura dahi is a very popularly consumed item, especially in eastern part of India, and people love it, and we know that beaten rice flakes has got a higher glycemic index, and we do see an increase in blood glucose. But that doesn't mean we tell people do not eat it. What we do is you take more amount of your curd, you take lesser amount of your beaten rice, you add some nuts to it, you add some seeds to it. Automatically, you're improving the protein. You're adding fresh fruits, as well as you're adding some amount of nuts, which is going to give you the healthy carbs, and you're reducing the amount of carbs in the diet. Now, this is from, especially it's eaten, I think poha or beaten rice is eaten in all parts of India in different forms. Now, this is your poha. Usually in the part of India that I am from, they add potato to it. So automatically the carb content goes up, as well as the GI also goes up. Now, there is a very popular item in the western part of India, and especially in Maharashtrians that we eat, is called your dhadpe pohe, where you take the poha, you add a lot of vegetables, you can add some roasted peanuts, and you squeeze lime. Automatically, the GI goes down. You've reduced the carbs, you've improved the amount of fiber as well as protein, along with healthy fats. So where people used to get scared of having roasted peanuts, today we are including roasted peanuts, because one is it is economical, secondly it's a good source of MUFA fats, as well as it is also lower in carbs. But everything in moderation. Even when we're increasing the amount of fat, it has to be as per the recommended amounts. Now, aloo paratha, especially if I'm from the northern part of India, and paratha as of say that you have to moderate even your breakfast and please control the amount of carbs as well as the quality of carbs that you're consuming at breakfast. So aloo paratha, you can actually make it into a vegetable paratha, add some paneer stuffing, you can add some dal to the paratha. Automatically you improve the protein and you have it with curd. So one is you will eat lesser, as well as you've added fiber and you've added protein to the meal. So this becomes very simple because you're still giving them a paratha, you're just modifying it to suit their requirement. And the person is also very happy. The family is happy because everybody can still continue eating the same thing. You're not introducing them to oats or muesli or something which they're not used to eating from childhood. Now, South India, when you're looking at idli, and typically we'll see people will eat 4 idlis or they'll have 2 dosas, which will be very high in carbs, as well as the GI is very high because they're fermented foods. So what I do here is I take 2 idlis, I add sambar with lot of vegetables, and I have it with the coconut chutney. So one is it will give me good satiety, the carb content definitely goes down, my protein quantity goes up, and I'm adding vegetables, and I'm also increasing the amount of fiber in the diet. So this will give more satiety to the person, as well as he's still going to enjoy his idli, which he loves. Now, when we look at dosa, the same thing. You can convert your rice-based dosa to a pulse-based dosa. So you can have like a pesarattu, which is very commonly consumed in Hyderabad or Telangana. This is something that they eat on a regular basis. So you make a pulse-based dosa, or you can make a chilla or a pudla. It's known by different names in different parts of India, but it means the same thing. One is you get the carbs, you get the protein, as well as you get the healthy fats. And remember, this is something that is important because people think dals are only protein and they don't have carbs. And they do not actually bolus for it, especially if they are on insulin. They have to know that dals will also give you carbohydrate. Rajma rice, this is my last slide. Again, the same thing. People, I think all over, including children, love Rajma with rice. So instead of taking the rice first and heaping it, with rice, your plate with rice and taking less amount of Rajma, and then, having your postprandial blood glucose go up, you take Rajma, you take a small portion of rice and you add salad to it. Automatically, you will achieve the satiety. You moderated the carbs, you've included lentil carbs, and you've included fiber in the diet. So it's very, very simple and it's important. Like Dr. Sharma said that you have to consult a qualified doctor. Similarly, for the diet, you have to consult a qualified dietitian because she's not going to starve you. She's not going to give you expensive, exotic foods, but give you your traditional foods and make it more diabetes friendly. And therefore, if you look at different parts of India, wherever you come from, you can achieve a good diabetes friendly meal by just doing some amount of moderation in the meal. And this is all of India, most of the meals that are there, whether it's a sambar rice or your dal dhokli, pakala bhat, that's something which is my favorite. And they can all become diabetes friendly. So very important to summarize, it has to be supervised, it has to be simple, sustainable. I think most important is affordable. And our traditional Indian diets with slight modification can become diabetes friendly. And it's not a one size fits all. It has to be personalized. So thank you so much for your patient hearing. All that I've spoken is in my book, Diet and Diabetes Simplified. Thank you.
Thank you, Cyril. Thank you for stimulating our appetite.
And thank you, Dr. Panda. Your medication really worked. Thank you.
So many tasty dishes that you have projected. Thank you, Professor Misra. Dr. Misra, thank you for chairing these 3 sessions. Now I invite Dr. J.B. Kanwar, our young endocrinologist, to moderate the panel discussion. We have with us Mrs. Silpa Joshi, one of the famous dietitians of the country, and Miss Monica Behra. She is also a dietitian from Dr. Kanungo's Diabetes Center. So our panelists are Dr. Monica Behra, Dr. Cyril Salis, Mrs. Silpa Joshi, and Dr. Sharma. And I request Dr. J.B. Kanwar to moderate it, please.
Very good afternoon to all of you. Thank you, Alok sir. We all of us know that the first thing in our prescription we do is always write a diabetic diet of 1600 or 1800 kilocalorie diet. But we do not put lots of emphasis on actually explaining the patient what diets he or she should take. And I am actually thankful to Alok sir, Dr. Jayant Panda sir, Dr. Asuk sir, that they have rightly chosen this topic, nutrition in diabetes, and we should be discussing more about diet. And we all know that that's a very important aspect of glycemic control. So today we had very good discussion, presentation by Dr. Cyril and Dr. Dharini, and also as a good interview with Dr. Sarma. Today I'll start with this panel discussion with some of the common questions. If you look at the presentation by the different dietitian, or if you look at the presentation by the doctors, they speak about the 50%, 60% carbohydrate, 20 to 30% protein, and 15 to 20% fat. These are not very something like not very take-home kind of message. So I plan to ask few of the commonly asked questions, and people actually, the caregiver, the physician, and everybody wants to, even the patients wants to know regarding those questions. So my first question to Dr. Shilpa Joshi, what is the best kind of oil you should use or prescribe in diabetes? I know this has been asked too many of the times to you. And what are the oils the diabetics should be taking, and what are the oils they should absolutely be avoiding?
Okay, so first of all, thank you, Dr. Alok, for inviting me here. So using dietary fat is a very sort of $1 million question. I think it comes to you from every patient. It comes to you from even people who are not patients. So the first and foremost thing is, in diabetes, it's very important, whichever fat you use, you have to use it in a prescribed amount. So I want to make that very clear that most of the studies you will see talk about 30% calories coming from fat, and therefore try to use limited amount of fat what you're using. I'll come to the quality first. Let me talk about the quantity. So 20 grams of fat, that is 4 teaspoons of oil, ghee together. Whatever fat you're using, 4 teaspoons per person per day. That's the first thing. Second thing is the choice of oil. So which oil to buy? Typically, according to AHA recommendation, most of your fat calories should come from monounsaturated fats. So which are those oils which are rich in monounsaturated fat? So peanut oil, rice bran oil, mustard oil, canola oil, sesame oil. These are oils which are rich in monounsaturated fat, and hence you can consume them as cooking fats. As far as pardon me, fats which are rich in polyunsaturated fats like corn oil, curdy oil, sunflower oil, safflower oil, all these oils go because if you look at their data is very robust for prevention of heart disease. But what happens is, Indian cooking methods utilize heating of oil. We give a tadka to everything that we cook, where the oil is taken to very high temperature. And at that point, polyunsaturated fats are not stable. And therefore, cooking oil should ideally not be polyunsaturated fat, which is corn, sunflower, safflower, and so on. It should be a monounsaturated fat because it's more stable to be heated. So that's answering both the questions.
Yeah, very well answered. What are the oils we should avoid? What's your comment on the coconut oils?
So again, there are a couple of studies on coconut oil and the data is conflicting. It is not very clear whether you should or you should not. My understanding is there are certain cultures across India, for example, Kerala, for example, certain parts of Karnataka, where they use coconut oil primarily as a cooking fat, and they do not use as much ghee like it's eaten in North India. So that portion of ghee, which is about 1 teaspoon, they can replace it with coconut oil in certain kinds of foods, not everything. So it shouldn't be the primary cooking medium. That's what I'm trying to tell you.
Correct. So I think the take-home message is you have to mix different kind of oil.
But not physically mix it.
Obviously. Yeah. Differently.
No, people physically mix it. And that is why people will physically mix it. So the suggestion is make different things in different oils.
Correct.
Keeping the quantity constant.
Correct. I appreciate your answer. And second most important questions being commonly asked by the people or the diabetics. is what kind of sweetener we should use. Many sucralose, aspartame, stevia, so many things are available in market. Which is the best sweetener for use for a diabetic patient, and how much we should use?
So
What is
like
the recommended amount? Yeah.
Like I said, like you said, there are many sweeteners in the market, and about most of the sweeteners which are in the market are all approved under FDA, under the category of GRAS, generally recognized as safe. So they all have a ADIs, that is acceptable daily intake amount. And as long as you are below the ADIs, you are fine. After saying so, one has to remember a very important thing, that sweetener should be ideally used as a tabletop sweetener. What does that mean? You can sweeten your teas and coffees and milk and sharbat with it. But if you start making mithai out of it, that is not good, not because you reach ADIs. That's not the problem. The problem is mithai, one component is sugar. Maximum component is fat. Laddu banana hai to ghee hai, kuch bhi banana hai to ghee hai. Correct? So I think that's a big problem, and therefore that is something that you have to keep in mind while you are using a sweetener. So use sweetener as tabletop sweetener. All sweeteners at minimum amount are acceptable. We really do not have long-term studies. This is all anecdotal, that sweeteners cause whether memory loss or cancer or whatever. That is not, that it's not proven. There are no long-term studies to prove it, and therefore whatever sweetener you want to use, just use it as tabletop sweetener rather than using it to create recipes.
Correct. What would you choose? Sucralose, aspartame, stevia? What would you choose one?
So
if you
also,
want to
what are you doing with it depends. So for example, because aspartame is a dipeptide, it is heat sensitive. So suppose you are going to say, put it in something hot on the flame, it's going to denature and there won't be sweetness. So if you're using it when it's being cooked, then you want to use sucralose. When you're using it in something, for example, ठंडा दूध है उसमें डाल रहे हैं, या चाय गैस पे मतलब कप में चाय है उसमें डाल रहे हैं, then you can use aspartame unless there is a problem of phenylketonuria. Then you can't use aspartame. Otherwise, you can use stevia. The only problem with stevia is it has a very strong licorice flavor. So a lot of times it's not acceptable to people who consume it. They say aftertaste bahut zyada hai.
Correct.
Thank you. I'd like to ask Dr. Ms. Sari that do you think a MNT for diabetes is different from diabesity?
No, I think it is. I think it is the same. As I said, it's not a one size fits all. We would definitely take the diet recall, look at the anthropometrics, look at the body composition, look at the blood investigations, and then plan the diet. I think it's very important to personalize. It's all about tailor making. Like my outfit may not fit somebody, and therefore it has to be tailor made. And similarly, even the diet has to be tailor made. And the same principles apply. It's about moderating carbs, improving the protein, and adding fiber and good fats to the diet.
So, what are good fats?
I think Shilpa has already spoken about it, but I would say nuts and seeds are good fats to add into the diet. And, especially like I said, that evening snack of people think that biscuits, usually they wake up to biscuits. They need that morning chai also. They need to dip something crisp into it and then have. So one is we have to give them healthier options. Shilpa has already spoken about the different kinds of oils. And in addition to that, the nuts and seeds, especially when we are moderating carbs and we do not have our target is not weight loss, because not necessarily every person with diabetes is having a high BMI. We do have lean people with diabetes as well. And therefore, important to look at the body composition. And if you want to still meet the calories, the best thing to do is nuts and seeds. Again, looking at the pocket of the person, you can choose what is best. Somebody who cannot afford your, almonds and walnuts and pistas, peanuts become a good option. And again, we've done the maths. One almond is 1 rupee. So, you can replace that cutting chai, which is maybe 10 rupees, or a samosa, which is 15 rupees, with 15 almonds. It'll give you a lot of health benefits, as well as you've moderated carbs, you've added the important nutrients to the diet, as well as added good fats.
Dr. Kamar, please.
Yeah, Monica, I do. Usually, people say you should use fried chicken, or you should not use fried chicken or fried fish. You should mostly use grilled chicken or grilled fish. Why is that? What is the advantage of grilled chicken and grilled fish over the fried one?
Good evening, all respected dignitaries. Thank you, Dr. Alok Kanungo sir, for giving me this opportunity. Basically, like roasted or grilled chicken or fish preferred over fried one is just because due to its fat content, as fried chicken has higher calories count to high volume, and as well as like the grilled chicken tends to be slightly healthier fat content just because it doesn't use into a deep frying process.
Okay. Is Dr. Dharini is there? Still there?
No.
She's not there. Okay. My next question is to Cyril. What is the advantage of brown rice over the polished or white rice?
The fiber content as well as the glycemic index. So brown rice, there is a lot of studies, especially done by Dr. V. Mohan's team, that the GI is lower, the amount of the fiber content is higher, and it gives faster satiety. So that would be an advantageous thing to do. And the only thing is the cooking time is slightly longer, especially if you're using the brown rice. The cooking time would be a little longer. So that is something that they need to factor in. Unpolished rice, that is absolutely, the fiber content is low and it would spike up the blood glucose levels. Again, it depends on the variety of rice. We have so many different kinds of rice available in the market, and therefore brown rice would be a healthier option. Nowadays you get red rice or you get parboiled rice, that could also be eaten, but again, everything has a similar amount of calories and carbs. So even if you're eating brown rice, you still need to moderate the amount that you are eating.
Yeah, there are places in India where they usually take white or polished rice. They do not take this brown rice, or traditionally they take polished or white rice. So, what are the measures you should suggest so that can reduce the glycemic index of this white or polished rice?
One is definitely adding a lot of protein and fiber, and I think your diet is extremely healthy, especially if you look at the East Indian diet. I'm a big fan of their diet because you all use the healthy fats, you all use mustard oil, you all use vegetables. Even in fact, even your non-veg items have got vegetables in it. A lot of greens, etc. So it's a very, very good nutritious diet, and if you follow the food order, I think that really helps. And we've seen it in our own clinical practice, it helps. Also about resistant starch, where you cook the rice one day prior, keep it in the fridge, and then just warm it slightly, not make it very hot. The RS content goes up, and that could also add to the benefits.
Monica.
But otherwise, I think your diet, especially even panta bhat, is something that I advise all my people, especially from East India, and they feel so happy. Or pakala. It is so good, and today we're talking about its gut-friendly benefits, and they feel so happy that we're advising them to eat it. So that is why it's very important. I think even if I am sitting in western part of India, I should know the diets of different parts of the country so that I can then make it customized to what they are eating. I remember having a South Indian patient who reached out to me and said, should I eat a khakra every day, because I've not been brought up eating it and I don't like the taste of it. But just because the nutritionist was in a part of a country where that was her, daily thing. She used to have khakra every day. So automatically it goes into the meal plan. And therefore it has to be customized. And I think regional preferences definitely have to be taken into account. And
thank you. Our next question to
suggestion for Dr. Kanungo to keep pakhala bhata as a menu in the next physical NUCD meeting.
I would love it.
We'll make it. Both non-veg pakhala and veg pakhala.
Pakhala with sukwa, sir.
My next question to Miss Monica Behra, that whether milk or dairy products are allowed in diabetes patients, and if allowed, how much amount is allowed per day?
Yes, sir, it is definitely allowed it. Like in current evidence, this indicates the higher consumption of milk products, which is associated reducing risk in developing type 2 diabetes. Both lower fat and higher fat both plays a major and beneficial role in preventing or protective way in pre-diabetic stage. Basically, it is very useful to consume milk or milk products, especially yogurt and cheese, which appears to be very protective against type 2 diabetes. Yes, sir. Then it is daily recommended. Okay, so it is recommended to consume half liters of 500 grams of milk and milk products per day for every diabetes and non-diabetic patients.
So out of that, you will have yogurt, cheese, and everything out of 500 ml.
Yes, sir, including every milk and milk products, both.
In renal cases, we will have to restrict it or not?
Yes, sir, definitely we have to restrict, because in milk and dairy products, we get much amount of protein, and in renal cases, we have to reduce the protein content. So basically, we can, like, depending on the parameters, we can give them the supplement of milk or not.
Yeah. If Dr. Silpa is still there, I don't see.
I'm there.
Yeah. People always ask whether to take the whole fruit or to make a juice out of it without adding any sugar. What would you recommend?
No, always a fruit, never juice. Always a fruit.
People say we are not adding sugar. So
it is not about sugar. It is about loss of fiber.
Correct.
And it is about increasing the portion size. So if you eat an orange, you eat 1 orange. To make a glass of orange juice, you need 3 oranges at least.
Correct.
If they come from Nagpur, if they are growing somewhere else, you may need 4 or 5. So therefore calories increase.
Absolutely. And what about the nuts or almonds, using nuts and almonds?
So like Cheryl said, it's very important that in any diet for any metabolic issue or even for good health, there should be liberal consumption of nuts and oil seeds, because they give you very quality fat and very good quality of antioxidants and some amount of protein, and they're very low in very low in carbohydrates. And hence, it is very important that they are consumed, but because they are high in calories, are again restricted to 20 to 25 nuts in total. They can be a mixture of many nuts. So some almonds, some walnuts, some pistachios. Now we have study from Dr. Mohan's group to show that even cashew nuts are good. So there can be some cashew nuts. But I want to say one thing. In India, when we talk about nuts to our patients, they are called as dry fruits, right?
Yeah.
Remember, dry fruits are fruits which are dried. That is raisins, apricots, figs. They increase blood glucose. So they should not be consumed. Only nuts should be consumed, because for patient, everything is dry fruit because it is sold in same shop. But they are two different things.
Dr. Kanwar, I have a question to ask to Silpa, taking cue from what you had asked.
Yes, sir.
You rightly said that juice is better, is worse than the full fruit. And you also said, you educate the audience regarding the same thing. Say potato. Potato is bad, but smashed potato is worse than a full potato. So that the form in which we take the food matters. Am I correct, Silpa? The form in which we take the food. So would you dilate upon that? People take in various forms the same food. So it's a very good question Dr. Kanwar had asked about the full fruit and versus juices. Similarly, you give some other example of the same fruit which is good in taking as a whole and not as cut into various form, like a smashed potato is worse form of carbohydrate. Am I correct?
Yes. So very important point, sir. We talk about processed foods. And it is so much of it is spoken about eating whole and not eating processed. And every time we talk about processed, we only think of pre-packaged food. But fruit is processed, right? You're cutting a fruit, you're processing it to produce juice. Okay? You're taking a potato, you're boiling it, mashing it to make into a mashed potato. So processing need not always be in a factory. Processing can be right in your kitchen. And that is why eating certain amount of whole foods, like that is why salads, whole pulses, they are so important. Millets, because you are processing them minimally. And I think that is something which should be understood. namkeen jo ghar mein banta hai, matri and laddu, this is all processed food. You don't have to go anywhere to buy it. It is made at home. So I think that is something that has to be understood.
I have one more question at Convar, since Dr. He's not here, Dr. Sharma is possibly not here. I want to ask that he discussed about...
He's there, sir.
I am here, sir.
I didn't see you have made your this thing of Dr. Professor Sharma. So I just wanted to ask you, sir, you said 3 ways of reversing diabetes. One, you said about the bariatric surgery, other you said about the very low carbohydrate diet, and also something regarding the carbohydrate-free diet. Now, which one? I mean,
2 minutes more.
2 minutes. I'll take only half a minute. Which one of these 3 is most affordable in Indian population?
So the most effective and in long term, the most economical will be bariatric surgery in a morbidly obese patient. But what we see in our day-to-day practice, these are the patients who are having, let's say, weight which is overweight or lower range of obesity. In that, we usually prefer to have dietary modification, as our dietitians here highlighted, that you have to modify the diet and then you reduce the weight. And the effect of exercise is not highlighted in this weight reduction and reversal of diabetes. What they say is that you first reduce the calories. Once you reduce it and your weight is reduced by 10 to 15 kg, then to maintain that weight, which is again a very difficult scenario, you should have reduction in calories as well as exercise. But in these studies, exercise was not given much importance. Thank you.
Yeah.
Yeah,
Thank you. Dr. Convert to final word, and we have 2 minutes left.
Yeah. Everybody presented very well, and the most important aspect of nutrition in diabetes has not been discussed many of the in forum, and we discussed, and as Dr. Bharat Pandya was also posted in the chat box, very nice discussion. Everybody enjoyed the session. Thank you all of you, particularly Ashok sir also participating in the discussion, and I hand over this session to the organizer.
Thank you, JB. Excellent.
Very informative and useful session.
Of panelists are with us. We can continue this for hours together. But Jayant has already started pointing that you are 12 minutes over the time, but it is not only hours.
From this session onwards, we are putting a timer.
Okay.
Yeah, you are fortunate to finish a session.
Conduct the next session.
Yeah.
Ask for the next session.
Thank you. I think wonderful session, Professor Sharma. SK, I call you SK, Shilpa, Sherpal, and Dharini.
Thank you.
And Dr. Conwar, very effective moderation and good questions.
Yeah, excellent session, very informative, and I'm sure our attendees have gained a lot. And very good moderation by Dr. Kanwar and Alok sir. As usual, the interview and the moderation is very good. And all, Dharini ma'am, Dr. Sharma, Dr. Saril and Dr. Shilpa, all have done very good. Dr. Monica. And this is in the YouTube, and I'm sure many people will watch, because nutrition is the focus now. And when I was going through, the agenda is so interesting and so informative and so updated. I'm sure this will be most visited panel discussion of the conference. So congratulations, team. We'll move forward. And I see my good friend, Dr. Rajiv Kovil here, the Bollywood man. And then Devasis is already there, our team member. So I hand over the session to Dr. Rajiv and Dr. Devasis for a very interesting leveraging technology for diabetes care. And as you know, the COVID has taught us a lot of technology, and now nobody wants to do anything without technology, whatever it may be. So in the diabetes treatment, similarly, the technology has entered much earlier. Say it be a glucometer, say it be a glucose monitoring, say it be a monitoring of the complications. Every step now, it is very interesting. So not that you are suffering the disease, you can take the modern science into the monitoring and enjoy the whole process of treatment, starting from the patients to the caregivers to the consultants. So I hand over the session to Dr. Rajiv Kovil, the renowned diabetologist who puts always things in a different form and makes it very interesting. He doesn't need any introduction to this NUCD group. He has attended many times physically. We are waiting for the day when we'll call him again physically to Odisha. And Devasis, the pomp man, and he is representing the country and always for the advancement of the technology here. So I hand it over to the chairpersons to set the context and invite our speakers and the panel, and I'm sure it will be another successful panel discussion of the conference. Dr. Rajiv and Dr. Devashish.
Thank you, Dr. Kanungo, Dr. Panda, Dr. Das, the whole team. I love the concept. The whole innovation in this particular way itself in the web shows that technology has made us rethink on how to communicate. Fantastic, Dr. Kanungo and Dr. Panda, for this innovative concept that you have. Fortunately or unfortunately, healthcare gets technology at the very end of the spectrum. We all are doctors because we were not good in maths, and but healthcare adopts technology very slowly. If you look at the other sectors, technology is grasped very fast, and though glucose meters came in so early, our adoption of technology is not only about sensing glucose, but in every format. There are very few hospitals in India which have a paperless communication. I know of a few, but it's time that we get into that. And today we have a fantastic panel of speakers, interviewer, and then a panel discussion to follow. I would ask Dr. Das to invite the speakers and invite Bansi. I don't think anybody requires to introduce Bansi, but still you need to introduce the speaker. Yeah.
First of all, it's my pleasure to invite Dr. Bansi Sabu. To introduce him will be an insult to him. Bansi, please carry on.
Yes, sir. I will just introduce a topic. Dr. Bansi, welcome to this forum. We are not new. And as Dr. Rajiv and Dr. Jain said, you don't need an introduction, not in India, or not in Odisha, not in globally also. And welcome to you. And Dr. Bansi will be speaking on glucose monitoring technologies, focusing on the continuous glucose monitoring and the flash glucose monitoring. Over to you, Dr. Bansi.
Thank you, Dr. Devashish. Thanks, Dr. Rajiv, for kind words. Thank you, Dr. Shokumar Das, Dr. Kanungo, and Dr. Jain Panda for inviting me for NUCD. I'm just sharing my screen. And I believe I am visible and audible also.
Yes.
Yes.
Control, Alt, So I'm going to talk on glucose monitoring technology and focusing mainly on CGM and FGM. No financial disclosure to make for this talk. This is in 2013. Somebody had talked and published a paper in Critical Care. Quite simply, intermittent monitoring is not up to the task. We will be asking our nurses to target a discrete blood glucose range by using insulin, avoiding hypoglycemia, and minimizing glucose variability. This is what the task which we give to our ICU nurse or ICU resident doctor, that by intermittently monitoring the sugar, we should try to achieve a target glucose range without getting hypoglycemia and no glycemic variability. But we now have abundant data demonstrating that this cannot be accomplished safely or effectively by using meters, strips, or blood gas analyzer. Am I right? I'm sure all of you will agree that just by monitoring, even by doing it 2 hourly or 4 hourly, it's extremely difficult for us to achieve a tight glucose control. Moreover, we can be certain that these intermittent monitoring frequency do not detect every episode of dysglycemia that occurs in our patient. Successful management of all 3 domains of glucose control will require the use of continuous or nearly a nearly a continuous technology which can monitor glucose continuously. Now, we know that whatever the technology which is available to us, at present, we can't use it in critical care, but this is a data, and as I told you in 2013, this paper was published in a critical care. Now, if we do the self-monitoring of blood glucose, most of our type 1 diabetic patients, they might be doing even 3 or 4 times in a day. And some patients who are put on insulin, type 2 diabetic patients, or intensively we want to control them, we are trying to do them on a self-monitoring of blood glucose. They may be on multiple daily insulin injection. And here you can see some patient who is monitoring the sugar maybe 4 times in a day, and almost every time you are seeing most of the sugar reports are normal, or we can say out of 4, at least 3 of them are normal. But if you do the continuous glucose monitoring, what you will find? You will find that in between, before the lunch, person is actually getting hypoglycemia. Midnight also, the person is getting hypoglycemia. And as it was shown that post-lunch or pre-dinner, there was hyperglycemia also. So this is what a difference when we are doing a self-monitoring of blood glucose and somebody is doing it.
Audio drive update kiya to ho gaya. I can hear it now.
The difference will be between continuous glucose monitoring and self-monitoring. Manoj, I think you have to mute. Now, the difference between a continuous glucose monitoring or by a random glucose monitoring is like taking a photograph or a videograph. Like taking a videograph and photograph, you can see here the difference. It looks like a straight road, but actually there is a multiple zigzag, or it is actually a roller coaster type of sugar. The similar way, when you are taking one report on a random blood glucose level on a glucose meter, and when you do a continuous glucose monitoring, you will find a lot of glucose variation, or a lot of time the difference in the sugar reports also. It's like monitoring a ECG, which is a taking a photograph at that point of time. But if you do the Holter monitoring, maybe for another 3 days and 7 days, you may pick up many more things also. But how do we monitor our glycemic control? At this point of time, it is A1C. And before few years, it was only A1C. Rather, now we have many more devices to monitor our patients, but the A1C is the only. But is it enough for managing diabetes? You may have 2 different type of patients with a similar A1C, but these glycemic fluctuations have more problematic. They have more deleterious effect on endothelial dysfunction, endothelial function, oxidative stress, compared to a person who have less glycemic variability or less glycemic excursion. So focusing only on A1C may not reveal the complete spectrum of risk for people with diabetes. If you can have 3 different type of patient with the same A1C, one patient may have a time in range between 70 to 180, maybe 100% of the time, and other side of a patient who may have also A1C of 7, but still the time in range may be very little. He may have multiple hypo and hyperglycemia, still he may can achieve the HbA1c of 7, and other patient who have less hypoglycemia and less hyperglycemia peak, but still he is achieving also the A1C of 7 with 63% of the time is actually remaining in time in range. So I mean, there is a possibility that you may have A1C of persons same, but still the glycemic variability in all these 3 different patients on the same patients maybe at 3 different times in a year may have a different glycemic variability achieving the same A1C also. So the rationale for CGM is that CGM is especially beneficial for people who are not meeting their A1C goal. They have frequent low glucose level. They are unaware of their low blood sugar level. They want to reduce their A1C target without increasing the further hypoglycemic events, have widely variable blood sugar levels, and children or adolescents who are willing to use the device every day. And there this technology should be useful, and it will be very, very beneficial also. So the limitation of current monitoring method is at present we have A1C, that's a standard of care, but the impact of hypoglycemia and hyperglycemia are unknown because it is going to give you the average of last 3 months and it will not be giving you any idea about the glucose variability of last 3 months. The self-monitoring of blood glucose will provide you glucose information only points in time, and at that point of time the sugar level is what? Most of the hypoglycemia unawareness or hyperglycemia peaks are often missed because they are asymptomatic. Overnight data is almost impractical, and logbooks, when the persons come with the self-monitoring of blood glucose, occasional glucose reports which are written on a rough paper, and it's really very difficult to interpret too. The continuous glucose monitoring is an advanced way of people living with diabetes to check the glucose reading in a real time or monitoring the glucose reading over a period of time. So we have two variety of continuous glucose monitoring system which is available with us. Professional CGM, which is giving you the monitoring system, is a glucose monitoring device which is indicated for detecting trends and tracking patterns in persons with diabetes. It does not give you the real time. The persons come after 7 days or 5 days or 14 days and we get the report of last 14 days or 5 days or 7 days. While real-time continuous glucose monitoring, it facilitates the persons with diabetes to be empowered to make much informed decision of managing their diabetes. They can see their sugar report continuously and they can also take action. And if they are empowered to take the action for managing their diabetes too. Now, if we classify the CGM, actually, it's not just two types. One, I already talked about the real-time continuous glucose monitoring. There is an intermittently scanned CGM. They say measure glucose level continuously, but it only display values when it is swiped by a reader or a smartphone. So that is what intermittently scanned CGM. That is what we have. Flash glucose monitoring. Again, as I talked about the professional CGM or a blinded CGM, when patient come back and we can see it. There is an integrated CGM. iCGM can be used as a part of an integrated system with other compatible medical devices and electronic interfaces, and which may include automated insulin dosing systems, insulin pumps, blood glucose meters, or other electronic devices used for diabetes management. Now, these are different CGM systems which are available to our country also. We have Libre, we have Dexcom, we have Medtronic systems. So we have almost all devices which are available, but there are many more devices which are available in the world. If you see the evolution of continuous glucose monitoring, the first generation, we never used it. It was not for the clinical use. The second generation, which had come from the Medtronic, which we had used in some of the patients, most of the places in the world now they are using the third generation, which have either wireless connectivity with the pump or on your phone. We have also the Dexcom, which is also on the phone, and we have Abbott now. Abbott is with Libre, Libre Pro, Libre 1, Libre 2, and now with Libre 3 also. The fourth generation are trying with the implantable sensors, which can be implants, can give you the continuous glucose monitoring. One sensor will give you the for 3, 6, or 12 months in the use in time, and that is getting. And some of the some parts of the world it is already available. And the future of this will be a continuous monitoring. That will be fifth generation, a small CGM like a penny with a non-invasive monitoring, or an eye wearable, single use, fully disposable for intermittent use, and something like that will come in future. So probably that will be the future of this continuous glucose monitoring. But one thing is very clear, that whatever the continuous glucose monitoring technology which is available to us with just now, it is very much giving us a personalized care for our patients. It's a, whether we use the professional CGM or a personal CGM, the patients who are can check their real-time sugar, but at the same time, they should be empowered for their action, and then we can have a very good control of the diabetes. Even with professional CGM, and patient come back to you after 5 days or 7 days or 14 days, you can make some changes and make the personalized care for that particular patient. The challenges with the CGM data, it was there with the Medtronic, which we had used in some of our patients before 10 years, but it was giving you this type of reports, while now the newer devices, which is ambulatory glucose profile or the Libre, which give you the report like this in a graphical form, which is much easier to interpret in compared to the previous report. Like this was really very difficult to interpret. Now it is much easy, because this is a software which is constructed from a model plot which collapses glucose data over several days or weeks. The data is plotted according to time as they have occurred over 24 hours. So all these data of 14 days is in this particular graphical form. Here you can see the dark line, which is like 50% of the time, or the median value is like this, and the light blue, and then there is a dotted line which is showing that even the 10% of the time the patient was either going here or here. So this is much easier to interpret. And now the other system of continuous glucose monitoring system, they have also started using this profile or this software too. Now the utility of continuous glucose monitoring diabetic patients. If you see this paper in DCCT trial, which was completed in 1983, and it had shown the patient who were achieving the tighter glycemic control. The A1C of these patients, median A1C of these patients was 9, and they were achieving the median was around 7.2. But the severe hypoglycemia rate was 62 per 100 patients here. At that point of time, yes, definitely the NPH and regular insulin was available. They started for some of the patients even continue the pump also. For JDRF CGM, which was done in 2008, almost after 25 years, when they had used continuous glucose monitoring, yes, definitely newer insulin was used, but the mean A1C of these patients was 7.6. And they could reduce from 7.6 to mean A1C of 7.1. But you can see by using continuous glucose monitoring, the incidence of hypoglycemia is reduced from 62, which was there in DCCT trial, to 20 per 100 patients here. And while they were achieving the target of 7.1, and that too only from the mean A1C from 7.6 to 7.1, it was they were already well-controlled diabetes were getting further well-controlled diabetes, more controlled diabetes with the risk of hypoglycemia very less after 25 years. And it was all because of this continuous glucose monitoring device which they could use in this. There are a few studies which show that how CGM is better than SMBG. This is a gold 3 study. The aim was to increase the understanding of continuous glucose monitoring, effect on hypoglycemia in person with type 1 diabetes who were treated with multiple daily insulin injection, and to improve the understanding of CGM effect on hypoglycemia confidence in daily life in this population. And what was the conclusion? The CGM reduced the time in hypoglycemia. It improved the hypoglycemia related confidence, and it improved well-being and quality of life also with these patients. There was one more study, silver study, which is talking about the beneficial long-term HbA1c control and treatment satisfaction. Again, it was compared with CGM versus SMBG. The aim was to evaluate the effect of CGM in adults with type 1 diabetes. They were managed with multiple daily insulin injection, guideline-based clinical support over 1 year. And what they could see, there was a significant HbA1c reduction of 0.35 just by changing the monitoring system with a significant p-value, along with reduction in time spent in hypoglycemia and hypoglycemia fear, and increase in overall well-being, treatment satisfaction, and hypoglycemia confidence also. The Diamond study, the better glycemic efficacy and safety with CGM versus usual care, and what they had seen, that 18% of the CGM group had 4% of the usual care group had HbA1c level below 7%. So in compared to usual group, those patients who are on CGM were having better control and less than 7 with the significant p-value. The average duration of hypoglycemia was 43 minutes a day in patients who were on continuous glucose monitoring arm in compared to 80 minutes in a day who were on a control group. So there is a significant reduction in A1C with a lesser duration of hypoglycemia in patients with continuous glucose monitoring. And we know that this is one paper which is talked about the real-time continuous glucose monitoring is better than FGM for patients who are type 1 diabetes. This is one of the trial, which is corridor randomized control trial, which is talked that real-time is better in compared to FGM. So now we have a abundant grade A evidence, which is published as far as type 1 diabetes is concerned. CGM is a standalone or in a sensor augmented pump. It had shown improved in glycemic control and less risk of hypoglycemia. Significantly, it improves pregnancy outcome in type 1, and it significantly increases the quality of life. So we have ample evidence to put it as a grade A evidence in type 1 diabetes patients by using CGM. CGM used in type 2 diabetes, yes. It also have the evidence to show that it significantly improves the time in range in type 2. There is a very significant additional impact on disease burden and very significant additional impact on cost saving on a long term too. This is one of the paper which is published from India in JAPI on a consensus statement. Can we use this FGM or CGM, use of ambulatory glucose profile in patients on type 2 diabetes? And these patients were not on insulin. These were the patients who are receiving oral anti-diabetic agent. Still, we had that these are the patients to whom we should put the patients on a continuous glucose monitoring. One more paper, which is published from Dr. B. Mohan. And again, he was talking that in optimizing managing type 2 diabetic patients, on a retrospective, which is again like what we are using Libre Pro, which is a professional on a retrospective continuous glucose monitoring, how it can help and optimizing the therapy for type 2 diabetes patients also. Recently, we published one more article with the time in range is a target in type 2 diabetes, and that's an urgent need. We need that for our patients or type 2 diabetic patients also to achieve a time in range, whether they are on oral anti-diabetic agents, they are on insulin, they are on sulfonylurea. To achieve that, a better is to have a CGM or FGM or a AGP profile for these patients to achieve a better time in range. CGM is an additional asset in this current pandemic. This is one paper which is published in Diabetologia in 2020, and they are talking those patients who are not in ICU. They can be continuously monitored with the help of continuous glucose monitoring, and remotely they can monitor, and they can be monitored remotely by their healthcare provider also. So they need not to meet the doctor, and still the monitoring can be done, and continuous glucose monitoring is really helpful for these patients too. And this is the real-time CGM can be used successfully in a community-based hospital, non-ICU setting to improve the glucose management, and continuously streaming glucose readings may truly be fifth vital sign. So in compared to patient who is not monitoring or getting sugar many times low and high, it's better that these patients can be monitored real-time, and they can be also monitored remotely too. Let's look some of the guidelines also. This is the international consensus in 2017, which is talked about the use of continuous glucose monitoring for type 1 diabetes, for type 2 diabetic patients, how frequently, whether they can be intermittently monitored or whether they should be continuously monitored. This has been guideline which is published in 2017, and that was endorsed by multiple associations, organizations like American Association of Clinical Endocrinology is talking that endorsement of CGM, that use of personal CGM devices should be considered for those patients who are on intensive insulin therapy. It means all type 1 diabetic patients, as well as all type 2 diabetic patients who are on multiple daily insulin injection. For those with a history of hypoglycemia unawareness, which could be a type 1 or type 2 diabetic patients, or the patients who have recurrent hypoglycemia, this is what ACE guideline is talking about in 2020. The ACE is also talking the CGM should be considered as one of the principles for comprehensive management of type 2 diabetes patients. So even not for just type 1 diabetic patient, use CGM whenever it is indicated to assist patient in reaching glycemic goals safely. So what they are talking that yes, in type 1 diabetes, yes, for those patients on multiple daily insulin injection, but it should be also used in patients with type 2 diabetes whenever it is indicated in assisting the patients to reach the glycemic goal. It could be intermittently using continuous glucose monitoring, that what we are using FGM every 3 monthly also. The S has talked about using the CGM in their guideline in this tabular form. Also, you can see here the lifestyle therapy and ongoing glucose monitoring, where they have written very clear cut that CGM is preferred whenever it is indicated. So in their guideline, they had put very categorically that CGM should be preferred as a glucose monitoring device. Use of ambulatory glucose profile for improving monitoring and management of type 2 diabetes. One of the paper which we have written with some of the clinical cases in this, and before 2 or 3 years, before in 2015, we had come out with a consensus guideline for glycemic monitoring in type 1 and type 2 diabetes, along with GDM patients. It was with the Jyoti Dev and Shaukat Sadikot in Diabetes India before 5 years. And then again, in 2018, one more statement, consensus statement was done on continuous glucose monitoring in India with Manoj was the first author, where we have done the recommendation for continuous glucose monitoring. The patient should be, for those who are on multiple daily insulin injection or continuous subcutaneous insulin infusion, to avoid severe hypoglycemia or repeated hypoglycemia, reduce the risk of asymptomatic hypoglycemia or nocturnal hypoglycemia, to treat refractory hyperglycemia, especially when they are fasting, and to tackle large blood glucose excursion in patient with GDM, understand blood glucose fluctuation caused by factors such as exercise, meals, stress, and hypoglycemic treatment, increase compliance of the treatment, promote more effective communication between patient and doctor, diabetic gastroparesis, fulminant type 1 diabetic patients, other special type of diabetic patients who can use CGM to understand the characteristics and fluctuation patterns of their blood glucose profile. And CGM can also be applied to other endocrine and metabolic disorders, including insulinoma. So where the CGM should be used, and this was the guideline which we published in 2018. Recently, from Southeast Asia, the recommendation is been published by Dr. Jyoti Dev, Anup Mishra. I was also the part of it, again by Diabetes India. The time in range and frequency of continuous glucose monitoring, the recommendation from South Asia. We talked about the same recommendation, some of the experts from the other parts of the other countries of South Asia. So we know there are three core glucose technology, and CGM at present we can consider it as complementary but essential for many of our patients. We know that finger stick testing, which is self-monitoring of blood glucose, A1C every 3 monthly, and CGM as and when required for type 1 diabetes, for the patients who are on multiple daily insulin injection, and some of the indication which I talked, if they can afford continuous glucose monitoring will really benefit them. But those who can't afford continuously, even intermittent, using continuous glucose monitoring is also helpful for those patients. Just to give an example, one of our patients who was on triple drug already, and he had come with the HbA1c of more than 9, you can see all his sugar reports are uncontrolled. Patient was to be started on insulin therapy as A1c was more than 9 with triple drug. He was already on sulfonylurea, metformin, and on DPP-4. We explained the patient that let us start you on insulin, but patient was not ready. So we explained the patient, let us do your continuous glucose monitoring. After 5 days, we call back the patient and we can see that all the reports are high. We changed from DPP-4 to GLP-1 and we put the patient on SGLT2. So now it was a triple oral anti-diabetic agent with one injectable therapy of GLP-1. And you can see on next 5 days, the patient was like this, sugar was getting down. On alternate day, we were calling the patient to reduce the glimepiride dose of from 3 milligram to 0.5 milligram. So on 6th day, patient every alternate day, we reduce from 3 to 2 to 1 and then 0.5 milligram. On 10th day, when patient had come to us, the patient sugar was 99% control with the patients of 9.9 A1C with all sugar reports are uncontrolled. Here patient was glimepiride was off. Now this patient is only on metformin with SGLT2 and GLP injection, which is once in a week. It's a once in a day, which was increased to 1.2 and 1.8. And then later on, we change it to the once in a week. So you can see how useful a continuous glucose monitoring in a type 2 diabetic patient for deciding the therapy. The patient who was supposed to go on insulin therapy with a 9.5 A1C with already on quadruple therapy or triple therapy to be started on insulin, the patient was not ready. Now only on 2 medication and with GLP-1. And after 6 months, significant weight reduction and patient sugar is getting almost 100% control, no hypoglycemia, and A1C was getting less than 6.5. So this is the advantage of continuous glucose monitoring in our patients with type 2 diabetes also. So to summarize my talk, continuous glucose monitoring assists in discovering unknown hyper and hypoglycemia. In observation of glycemic variability, it assesses the percent of time in range or time out of range, which is below or above, severity of hypo and hyperglycemia during day and night. It provides actionable information which is derived by CGM report. It highlights impact of behavioral variances. It analyzes glycemic effects of new intervention effectively and efficiently. And CGM assists in care for diabetes, which is getting digitalized. CGM enhances patient self-management, adherence, and confidence in management of diabetes. With this, I once again thank you, Dr. Das, Dr. Kanugo sir, and Dr. Jain Panda. Thank you very much.
Thank you, Dr. Batsi, for a very elucidate and nice presentation on CGM. We would request you to be there for the panel discussion. We will take the questions at that time. Now, we have the next session by Dr. Jyoti Dev. And I think, again, everyone knows him in and out. He is the technology man of India who has been using technology in diabetes care, I think, for last at least 2 to 3 decades or more. And I think he started using insulin pump. I think he installed first pump in 2004. And not only pumps, he uses connected device, he uses Internet of Things, he does a lot of telemedicine and teleconsultation and tele things in the management of diabetes for so many years, and he has published numerable peer-reviewed in journals publications on the technology use. So without taking much of time, I would like to invite Dr. Jyotidev. Is he there, Dr. Jyotidev?
Yes, he's recorded it.
Recorded. Okay. So he will be speaking on the topic, My Tryst with Diabetes Technology. What can we practice in the real world?
Thank you. Thank you very much for this kind opportunity. Thank you very much, Dr. Alok Kanungo and the entire NUCD group. So let me start sharing my slides without wasting any time. And this is a topic, the title which is given to me, and I'll be discussing my past experiences, and also I will share with you how the experiences have taught me how to better use the technologies. I have nothing to disclose in this lecture. So these are the broad topics I'll be discussing today. I started using some of these devices when I was a school kid. And that was when my father was diagnosed with diabetes and its complications. And this is clinic sticks, still vivid in my memory. And before that, it was the Benrick solution. And this was the glucose meter I procured, and that too for my mother long ago. Both these are historically now very, very important. So this is the AIMS reflectance glucose meter, and this is the clinic sticks. Both of them very, very important. And AIMS, both these from AIMS, and AIMS is now Bayer, and the Bayer, the glucose monitoring division has been acquired by Condor, which is now owned by Panasonic. So that is a long history of glucose monitoring. Let me start sharing with you a real life story. And this is when I started practicing. This was in late 1990s, and I had very good practice in diabetes. And this was a famous guy, a poet, who visited me in my clinic at home, where I practiced along with my nurse. And he approached us with uncontrolled diabetes. There was only one report available with him, no other laboratory reports, only a glucose value of 425 and a foot ulcer. And he is getting treated by a surgeon and also a family physician. We spent more than an hour. We spent more than 1 hour discussing with him what is diabetes, what are the complications of diabetes, what is the necessity for controlling the glucose, for evaluating the cholesterol, why you need to do the lab investigations to find out where you stand. But he was not even aware of a normal glucose value. Not at all aware of anything, despite 10 years history of diabetes. And he went back, and when I contacted him 3 days later, because there was no response from him, we were actually very sad. He was agitated. He was agitated, and he was telling us that when he discussed with his family, friends, and other close doctors, they told that these investigations are absolutely unnecessary. And the glucose meter, the device that we have advised him to procure, that is not at all required for the management of diabetes. And this is how the sad story goes. Even though I forget about this, I later on came to know that his foot was amputated and he died of diabetes-related multiple complications. Very, very fortunate. Why is it this story is important? This story is important because this is still happening. This is still happening all over our country. Glucose monitoring has advanced a lot from the earlier day devices, when, of course, they were very good even in the beginning, but some of them were inaccurate. It was extremely difficult to convince the physicians and the patients. And we used to have a calculation to convert to the plasma value, and a large drop of blood was required. And in between, we used to even lose waste strips. So over the years, the glucose meters have become much, much more reliable and accurate. And there is absolutely no wastage of steps. And if you go by the new ISO 151972013 recommendations, you can see the criterion A and criterion B. So this is to make sure that if you're using the newer glucose meters and strips, remember all the glucose meters, all the strips are not the same. They are not the same. In India, we have more than a dozen popular devices, but go by the branded glucose meters. And these are the ones where almost 100% of these numbers will be there in zone A itself, in the Clark Yarragal zone. And some of these meters, they're even capable of a second chance sample if the first sample is not sufficient or insufficient. And almost all of these are capable of generating a digital diary, replacing the conventional paper diaries, and that too with color coding. Capable of remote monitoring, unlimited possibilities with MySugar, the most commonly used mHealth mobile application for diabetes across the world. More than 3 million patients are currently using it. And I say it again, the possibilities are incredible. And this connects via Bluetooth to some of these meters such as AccuCheck Instant. So we were also over the years trying to generate more data, evidence-based data on glucose monitoring and telemedicine. And this is to convince the patients. And this is ADA in 2022, when the ADA is recommending that the providers should be aware of the differences in the accuracy. So now the ADA is recommending that we should be recommending to our patients only those glucose meters with a proven efficiency and accuracy. Let me now move on to the insulin pump therapy. Another major area, probably my strongest romance is with insulin pumps among all the available technologies in diabetes. And this is how it all started. My first meeting with her happened when I was at Mayo Clinic way back in 2003, when I was undergoing my endocrinology training, when I got first exposed to the external insulin pumps. Back in India in 2004, we initiated insulin pump therapy in our patients. Only to remember the year 2006, this was the year when real-time glucose monitoring was available, was started in our country. It is not in 2019 or 2020. From 2006 onwards, the insulin pumps were capable of generating the interstitial glucose numbers on the pump screen, displaying on the pump screen. And these were the beginning of SAP or sensor augmented pump therapy. From the beginning onwards, multiple challenges were existing for use of insulin pumps, for the successful use of insulin pumps. It was very hard to convince, especially the doctors, the senior experts in endo, in diabetes, and in allied specialties such as nephrology, cardiology, neurology, and so on. Insulin pumps are definitely superior, far, far superior as an advanced delivery gadget when compared to syringes, when compared to insulin pumps, when compared to insulin pens, I meant. And it was difficult, very, very difficult to convince the peer group. And hence we started publishing the data. And this is the first insulin pump guidelines we published. And these are from all over India. You have Dr. A.K. Das sir, who is also supported, Dr. Mohan, Dr. Ramachandran sir, Dr. Shashank ji. So all of them supported in the publication of this guideline. This was actually a necessity. It was a legal requirement for all the doctors and even the patients to appreciate what are the indications, what are the contraindications to the use of insulin pump therapy. Because it is very essential that you had to go by the available evidence from all over the world and from India. So this is on the dramatic response to intractable, painful peripheral neuropathy within weeks, within 10 to 14 days of initiating a continuous subcutaneous insulin infusion. Yes, insulin pump therapy is well known to bring down the pain of peripheral neuropathy, and almost all these symptoms will subside. And the same is true with erectile dysfunction. Reduction of HbA1c following 6 months of insulin pump therapy, and this is the data that we have generated in type 2 diabetes, again published in Diabetes Technology and Therapeutics. If insulin pump is successful, almost all the patients are going to have a feedback, and this is on robust improvements in the quality of life. What is the next big thing which is happening in diabetes in India? The long-awaited 780G is already available. We have started in 3 of our patients 3 days ago, and this is the most advanced FDA-regulated device for automated insulin delivery. And this is the advanced hybrid closed-loop system, which will be discussed in detail by the subsequent speaker, Dr. Debasis. It automatically adjusts the delivery of basal insulin once in every 5 minutes, and that is in response to the continuous glucose sensor. So when the glucose is trending high, it will increase the dose of insulin. When the glucose is trending low, it will either lower or it can even automatically stop the delivery of insulin. And this is all thanks to, number 1, advanced sensors, and number 2, advanced algorithms. So algorithms are the most important component contributing to all these innovations. And in the rare instance of the patient or the caretaker forgetting the bolus, the device is capable of even delivering a bolus. And this is all determined by the algorithm. So when you compare with the earlier devices, I would say that this device is capable of reaching a time in target of even up to 79%, very close to 80% if you are manipulating with the active insulin time as well. So what are the factors determining the success of a technology such as insulin pump therapy in our country? To be successful, it should be much more user-friendly. It should be easy for the patient to troubleshoot. It should be recognized by the insurance companies and by the government as a gadget, as an advanced delivery system, which can bring down the cost of treating the avoidable complications of diabetes. When does insulin pump therapy fail? That is also very common. Insulin pump therapy fails when the candidate selection is wrong. So this is on the experiences with using telemedicine in diabetes when we started way back in 1997. And we were successful in generating a lot of publications related to the use of telemedicine along with a structured self-monitoring of blood glucose, in reducing the A1C, in eliminating hypoglycemia, and in reaching the targets, in reaching customized targets in specific populations. We are still active during these COVID times. And during the last 2 years, ever since the COVID started, we have implemented the virtual COVID IP care, remotely monitoring the patients. We are providing this support only to our patients who are diagnosed of COVID. And we are even administering corticosteroids whenever necessary at their own houses. And we were able to publish the data on reaching and sustaining more than 95% time in target in almost all these patients who are on remote monitoring with either connected glucose meters or with connected continuous glucose monitoring devices. Yes, the CGM devices are also growing. They are also advancing. We started in the year 2004 in India with the first ever CGMS Gold. And the CGMS also has transformed, has gone through the same history, similar to the glucose meters. The earlier ones were less accurate. The earlier ones were very difficult to use, but now they are much more accurate. The cost has come down and it is user friendly. It is user friendly. And the Guardian Connect, the Libre, they are all extremely popular in our country. Guardian Connect is the only real-time glucose, continuous glucose monitoring device available in our country. And Libre is the intermittently scanned device. Both of them can generate the data on TIR. So this is my concluding slide. More than 90% of the physicians are currently recommending the use of newer technologies only after waiting for more than a decade. But you know, technologies, if need to be useful, they need to be used and recommended immediately, soon after it is launched in the world. But remember, nowadays, if we doctors are not recommending the technologies, the patients will themselves search for their available and user-friendly technologies. They will not wait for the doctors anymore. And that is a take-home message from me. Thank you very much, NUCD and the group, for inviting me and giving me this opportunity.
Can I now invite Dr. Debashish Das for his presentation?
Thank you, Dr. Raji. I'll just share my slide. I hope my slide is visible.
Yes, sir.
Yeah, thank you. Once again, first of all, I want to thank Dr. Alok sir, Dr. Ashok Das sir, and Dr. Jayant Panda sir, and the entire NUCD team to giving me this opportunity to speak on this interesting topic, artificial pancreas. Where are we now? I think Dr. Jyotidev has already touched a bit of that in his presentation. I will be taking it a little further on that. This is my disclaimer. But for this presentation, this is not a industry-sponsored presentation. So just I would like to that this is all of us know this is the 100 years of insulin, which has started with 1921 identified, and 2021 became 100 years. Because this is relevant, because I'm going to speak on the insulin delivery systems. So from when it was started, the discovery, and now so many things has changed, and the way insulin was founded and delivered, and how it is delivering being now. Yeah. So coming to what exactly is the artificial pancreas? The artificial pancreas is a device for automated modulation of insulin infusion that aims to maintain blood glucose in a nearly normal range. The core of the artificial pancreas is the control algorithm, which is in charge of computing an effective insulin dose on the basis of continuous glucose monitoring readings. And in the last decade, the artificial pancreas prototypes based on subcutaneous glucose sensing and subcutaneous insulin delivery have been extensively studied in clinical trials, and presently few of them are already available in the market. Now, this is the picture-wise presentation. If you see how a artificial pancreas works, or we call a closed-the-loop system. So this is the insulin pump, which does the subcutaneous insulin delivery into the subcutaneous space, whether in the abdomen, or it can be in the upper part of the arm, or it can be in the upper part of the thigh. And then you have the continuous sensing from the glucose monitoring system, that is the CGMS. And then both the CGMS data comes to the system, which is exactly is the algorithm or the controller. And this algorithm, based on the readings from CGM, it gives command to the insulin pump to deliver the insulin. That's how the whole system works. So the key brainer or the brain is the algorithm or the controller. And there are different kinds of algorithm. We have PID model globally, we have MPC, and also we have a fuzzy logic. Now, if you see the stages of artificial pancreas development, this is from the JDRF slide. Now, when it started some time back, I think this was launched in the early 2000. So, which was the very low glucose insulin off pump, which just shuts off the insulin with a low glucose alarm. Then there was a hypoglycemia minimizer. Then the next level was both hypo and hyper minimizer. And then the fourth stage is the automated basal, or we call hybrid closed loop system. And then we'll have a fully automated, and which will automatically include the mealtime insulin delivery. And then the last one, it will be a fully automated multi-hormone closed loop system. That will be the third generation. And these two are second generation. And currently we are here globally. So this is the artificial pancreas or closed loop system, which can deliver basal insulin and also the correction delivery, but it has a limitation that it cannot deliver the mealtime bolus. Still, the patient has to take it manually. Now, this is Medtronic has been pioneer in this for a long time. So from 2006 now, coming a long way from VO, then 640G, 670, 770G. Now this is the latest one currently available globally, and also it came to India. Now, this is a picture I have just taken from the social media by Dr. Mohan on LinkedIn. So 780G is available in India, and Dr. Mohan Center has already used 2 of his patients on 780G. And you heard Dr. Jyoti Dev, he has also posted this on Facebook. He is a pioneer in technology, and he has already put 3 patients on this artificial pancreas system already, which was just launched early this month. Now, this is how this artificial pancreas or closed loop system works. This is the pump. This is the transmitter with the sensor. Then this is the link meter. Then this is the mobile, whatever smartphone you have. You have an app. Then this is the system if you want to use to download the report with this Blow USB. So these 5 people or these 5 gadgets don't need internet. They just talk to each other via Bluetooth. Once the data comes to your mobile, then through internet, it can transfer it to the CareLink server. And once the data goes to the CareLink server, then through internet, it can be shared through the CareLink Connect app with doctors, his or her physician, parents, friends, or other caretakers. So the best thing about this automated system or closed loop system is automatically delivers basal insulin. You can see here. The pink part is the basal. Automatically, depending on the sensor glucose reading, it does auto basal delivery. And you can set a target of 100, 110, or 120. So the basal insulin delivery adjusts itself every 5 minutes based on the sensor glucose readings. And this device also does an auto correction. That means there is a target of 120 already fixed in this closed loop system. When the sensor glucose values go beyond this, you can see when it crosses 120, automatically the auto corrections happen. Apart from the basal delivery, means so that the patient does not land up in a very high glucose. Before the patient reaches, the system gives a small bolus and checks the sugar. And this whole system works on this algorithm. We call it PID with IFB, that is proportional integral derivative with insulin feedback. It uses the real-time information on current sensor glucose, how far the sensor glucose is from the set target, how long it has been away from the target, and how fast it is changing, and on the already estimated total insulin, both basal and bolus. One thing to remember, the algorithm does not learn day of time patterns and trends. It does not capture the day and time. So it can be used in shift patients. And depending on the patient profile, sensor glucosing, then it changes automatically the delivery. So these are the targets. For auto basal, this is the default 100, but we can set 110, 120. This is the temp target set. Auto corrections automatically happen when the sugar goes beyond 120. And when you, so from a clinician point of view, what the system wants from a clinician and what this algorithm does. Algorithm automatically delivers automatic basal delivery, auto corrections, and automatically calculates the sensitivity factor. As a clinician, you and me, we have to give the system carb ratio, what should be the auto basal target for that particular patient, and what should be the active insulin time for that particular. If we just give these three to the system automatically delivers the basal and auto corrections. Only one limitation, that the system does not automatically recognize meals. Although auto corrections take some amount of, or can correct some amount of meal rise of sugars, but not fully. So still the patient has to announce or tell the system that I am having a meal and has to take the meal bolus what the system recommends. As I said, this system works on Bluetooth technology. So you can just connect the system by Bluetooth to your hands, to your smartphone, and you can see all the report on the mobile. And you can get all the data, time in range and everything on this report. And it can be both in iOS and can be in your Google Play Store. So this is the latest 780G system globally, which just got launched in India early this month. This is currently available in Europe, Middle East and Africa, some parts, and also in Southeast Asia, India, Singapore and Malaysia. Even US does not have 780G. And I'm going to present some of the data, real world data from the real patients, which was presented recently in EASD and ISPAT 2021. And it shows that patients who are in the real world, they're using the system, around 13,000 patients. They had a mean sensor glucose of 145, GMI of 6.8, and time in range, you can see what Dr. Jyoti Dev said, around 75.8. And time below range also 1.9, and you can see. And there are so many different targets, which you can just see from the slide. And if you see, this slide shows whatever the country, because this data is from Europe, whether it is Italy, Netherlands, or Poland, or Turkey, or Greece, whatever the country may be, most of these countries achieved a TIR, you can see 75, 76, some of them achieved 80 plus, and the GMI 6.8, 6.7. So irrespective of any country, it is giving wonderful results. Again, this is all type 1 diabetes data. And we could also gather the data from the first month. You can see month on month, first, second, third, fourth, fifth, sixth month, month on month, from the first month, it could get the patient's TIR in the range of 75, 77, 76. Time below range is within the target, and also time above the range. And this is this data was present in ISPAT. You can see for children below 15 and above 15, daytime it was 71.1, it was 74.6. But in the night time, whether it is less than 15 or more than 15, it achieved a TIR of 82%. Fantastic, because all of us know whoever treats type 1, teenagers are the most difficult ones to treat type 1 diabetes. And this is the data you get when you download. You get the time in range for last 1 month. You get the whole graph. You get all the detail. What's the average A1C? What's the coefficient of variation? What's the total insulin dosage? You get all the data in one single page. And that's very, very handy. So this was all about the 780G system, which is the latest one, which is also available in India currently. And as you saw, Dr. Mohan and Dr. Jyoti, they've already started few patients. This is some of the other ones which are available globally, but not in India. This is Omnipod Dash, which also kind of a artificial pancreas. Then they have Omnipod Horizon or Omnipod 5, which is also available in the US, but not in India. It also does similarly, but they use either Dexcom sensor or Freestyle Libre, and they're still awaiting FDA approval, not yet approved. Then this is another artificial pancreas or closed loop system from Medtronic, that is 670G and 770G. They are available in the US, but the latest one is 780. So these two can only deliver auto basal. They do not have a auto correction delivery. Then Tandem also has a wonderful system called T-Slim. They have two algorithms. One is basal IQ, which is like a predictive low glucose suspend, and they have a control IQ, which does both basal and correction. Again, this is only available in US and certain other parts of the world. Then even Diable Loop is there in few countries. It uses different components from different manufacturers, you can see, and it also uses in very, very limited countries. And this is from the University of Cambridge. I think it's not yet in the market. They use a smartphone for the algorithm, the transmitter from Dexcom, and the pump from Dana. This is Tide Pool Loop. This is another kind of, again, closed loop system. And this is the either insulin only or bihormonal. Again, it is trials are underway. So we hope to see this maybe in a couple of years. You might see this bihormonal closed loop system. Now, to summarize, so we are here in the second generation of closed loop system or artificial pancreas, which can deliver automatically the basal delivery and also the auto corrections if the sugars go beyond 120. But still for the meals, the patient has to manually take it. Now, in next couple of years, we might have a insulin pump with a closed loop system or artificial pancreas, which automatically does auto basal, auto corrections, and auto meals. So for meals also, it automatically recognizes and then delivers it. And finally, maybe in another 5 years, we might have a fully automated multi-hormone closed loop system or artificial pancreas. With that note, thank you very much for a kind attention. So now I stop my presentation.
Thank you, Debashish. Thank you so much. We are almost there and yet not there. That is how it is, but hopefully we will have a bihormonal pancreas and we will have completely a simulated non-diabetic way of treating type 1 diabetes. Over to Dr. Kanugo, sir.
Nice, very nice presentations. I will now request Devashish to join as a panelist and Dr. Sunil Gupta to join in the program, and Dr. Ritesh Agrawal and Sunil Gupta and Devashish Das to moderate this session. Rajiv will be the panelist, Bansi, Jyotidev, and Dr. Sunil Gupta.
We all are there, sir.
Yes,
waiting
sir,
for.
please.
Very good. Very good, Bansi. Thank you, Rajiv. Wonderful conduction. Thank you.
Thank you, sir.
Let us go to the questions now.
Yeah, Dr. Ritesh, you want to initiate or should I start?
Yeah, you should start, Dr. Devashish.
Okay. Now, is Dr. Jyotidev there? I think he's not there.
Questions, where is the questions are there? Any attendee put the question?
So the first question to Dr. Bansi Sabu, he was the first. So Dr. Bansi, there's always a confusion between a physician where to use a continuous glucose monitoring and where to use a flash glucose monitoring. What's your take as a clinician?
So CGM is a continuous glucose monitoring where you need a real time. Again, CGM is also intermittently scanned, which is what FGM, which is also very popular in our country. One of the reasons for it is becoming more popular, one, that it had come out with a software which I had shown that ambulatory glucose profile was much easier to interpret. But now with the Dexcom and other, they also started using the same software for the interpretation of the continuous glucose monitoring. But I normally advise the continuous glucose monitoring for those patients who are on insulin pump or multiple daily insulin injection. But what is more required for that, the patient should be empowered so much so that they can take care of these peaks also. Because sometimes what happens when patients see their report continuously, suppose they had seen suddenly 80 and they may started feeling that, I may go in hypoglycemia, and they may start taking something sweet or, auto correction unnecessarily they are taking. That may be a problem also. So first I start normally the patients on a flash glucose monitoring, that too also pro. So, they come after 5 or 7 days. And once we see, and once you have educated patient, in that format, and now they are prepared to go for a continuous glucose monitoring, then we advise them for CGM. This is what in our clinical practice what we do. But internationally recommended is for type 1 diabetes, they are saying the CGM is the best. There should be continuous glucose monitoring. The flash glucose monitoring or intermittently scanned glucose monitoring can be for those to whom you are not using continuously, like every 3 monthly, because it gives you prediction for next 3 months. You can think of putting that type of device to them to intermittently monitor.
So if I ask you, Dr. Bansi, the leading question, I think nowadays they have a Libre personal version.
Yes.
Now, if a patient of yours is using, so how often do you tell him to scan? Because you have to scan every, so what's the frequency or how many times you recommend them to scan?
They are saying that it has to be, if it is less than 3, then it will not give you the report also. That's number one. The second is we have to tell the persons that, normally, which I tell them every 3 hourly, that is what minimum. Till not in the night time, but till last at bedtime and early in the morning, which they should do. If 11 p.m. they are sleeping, and early morning 7 o'clock or 6 o'clock, if they are getting up from that time to till late evening, every 3 hourly. And the second is also if they want to use the correction dose, the 3 hourly also, they can use this correction dose with a short acting insulin if they are on MDI or if they are on pump therapy also. So I tell them minimum 3 hourly, but if they can do more, then it is better, because more is always better to know about their glycemic excursion.
Yeah. Thank you, sir.
Ashish, I had a very practical question, very short question. Bansi and of course, Devashish, you can tell us, in our country, what is the take of CGM, FGM, connected meters, and SMBG?
What is take?
I mean, how much people have taken up the
sir, the maximum
CGM
using is the glucose meter, which is, if you see the number of glucose meters which are used by our patients, almost all type 1, they should have the glucose meter. That is what is minimum. And all type diabetic patients. Now, the point is they are monitoring. Are they monitoring frequently? Are they monitoring with the optimum frequency? Are they monitoring minimum 4 times or 3 times? That's a big major challenge for them. Now, regarding
connected? Connected? Are they not connected?
The connected meters are too, because they are using, there are software apps which are available with some of the glucose meter which they can use with them. And again, they are not very frequently monitored, and they are not very frequently also connected.
Coming to FGM in type 2.
Type 2 diabetic patients
FGM use in type 2.
They are using very frequently. I think in most of the diabetologists and endocrinologists started using it, and maybe like any patient who is having hypoglycemia unawareness, to motivate him, to put him on the insulin, to change the therapy, to, for all these reasons, or to monitor the glycemic control also, we use FGM. But again, the frequency is not like every 3 months or every 6 months. Again, it is used like once you had used, and then again, maybe after 2 years you are using it. So it depends on that, very much individualized and very much different.
Sir, the major challenge in our country is, if you compare to the Western world, why they are using 90% of cases? Because it is reimbursed. If you put the Indian patients to US system, they will also use 90%. And if you take the US patients to India, they will also use like us. The major challenge it comes
No, but
to
Dr.
is
Das,
the
there
care.
is a slight clear difference as far as self-monitoring of blood glucose is concerned. Dr. Ashok Das is a chairman of CDIC, which is changing diabetes in children. And where we were giving now this year, since last 2 years, we are not giving them glucose strip, but we're giving them glucose strips like 100 per month. But many of our patients were not monitoring 3 or 4 times. Even these patients were given free glucose meter and free strips. Now RSSDA supported project also. So it is the prick which is also a major challenge. It's not just the cost of the glucose meter or a strip. It is the prick which is a major challenge. Major challenge is the education. We hardly educate the patients for monitoring. We don't have the dedicated diabetic educator who can educate them. And third, when they come back with that logbook, nobody is there to interpret.
Don't look at it. We don't look at it.
So that's a major challenge why they don't want to monitor it.
So I think the major challenge with the CGMS, what I feel, is also the interstitial monitoring by the sensor and the capillary monitoring. So whenever a sensor, I will ask to Devasis sir and to our panelists also, the closed loop system which gives data by the sensor to the monitor, to the machine, which gives the auto correction of the basal insulin. So what I learned, the interstitial fluid hypoglycemia will be sensed and it will be 15 to 30 minutes later, we will give by the capillary glucometer. So how this gap will be managed?
So
in fact, most of the time, our patient come to our clinic by sensing the freestyle Libra, but therefore, sir, it is showing 60 without symptom, the patient running to our clinic. So how to address this issue to our patient?
You have to understand one thing. You don't have to see when you're using, Dr. Bansi and Dr. Sunil and Dr. Raju will agree to me. When you're using a real-time CGM, you don't look for values. You look for trends. You look for the graph. Where the sugar is moving, whether it's going 2 arrows up or going 2 arrows down. You don't look at the same, you don't look at the value. Value will be always different. When they are in stable state, the sensor glucose value and the blood glucose will be close by. But when they will be in hypoglycemic ranges or in hyperglycemic ranges, the difference can be 15 to 30 minutes or sometimes more. I do fully agree with that because that's normal physiology. You can't change it. But when you ask about closed the loop systems, the algorithms have been made like that they understand that there is a lag in that, and the algorithms are working on that pattern only. Otherwise, with the data I showed you, they are real-time data. Real-time. They are not clinical trials. Patients in and out are using this data and they are achieving a TIR of 82%, 75% with the same algorithm and with the sensor glucose being in the interstitial space and giving the sensing data to the algorithm.
You mean to say they are programmed, Debashish? They're programmed to take care of this. That is the answer he gives.
So, Debashish, if I could just add some comment to it, that we have one type 1 diabetic who just delivered a baby 3 months back. And on MDI, she had a bad obstetric history 3 years back when we switched her to a pump. And she was on a sensor augmented pump. I think she was on 640G. And all through the 9 months and the 3 months before, she had a TIR which was almost 75 to 80% with hardly any hypo. So, she's a long-standing type 1, at least 15 years of type 1, 60 kilo lady using almost 80-85 units of insulin. But it is possible. It is possible to use technology to get the best TIR without hypoglycemia if you use the sensor continuously. Yeah. Now, affordability is a huge issue.
Yes.
And, because Medtronic doesn't have competition, the rates are very, very high, I would say. The day we get a good competition to Medtronic, I'm sure Debashish and everyone will have to cut the rates because it is not affording to many people who will benefit with the pump. And that is the reality of the situation. If we could have affordable pumps and if you had affordable CGM devices, a lot of type 1s, a lot of type 2s, a lot of elderlies would have really benefited as such.
I agree, sir. No, I agree. Whenever there is competition, always the benefit is for the customers.
Yes,
I agree.
Absolutely.
But you see, we sometime back did fight for the glucometer price to be down about 11, 12 years back. And the price did come down, Rajiv. It has really come down. We took out on it and all that. Can anything be done about this fear of FGM? I'm focusing on the type 2 1C. Can some such a thing? We are talking about defeating diabetes. But for defeating diabetes, we need this. No, can we have a price of the FGM? I don't know whether it can be cut down further, Bansi.
Already in a very affordable price.
Yeah, it's about 2,300 here.
Now, affordability, as I agree with Rajiv, but again, you know what happens? It's a very relative term.
Absolutely.
For a multi-millionaire persons like Rajiv, maybe 2,000 may not be a very costly thing. But for a poor man like me, maybe a 2,000 may be very costly also. Yeah. So it is, it is very relative term. Yeah. But I really feel that FGM 2,400 rupees is the recent price of the MRP. It's quite affordable for 14 days continuous glucose monitoring. Yeah. In compared to Western world, I think it is at cost effective, but the Libre, which they have introduced at the 5,000 rupees, that sensor, is really relatively costly, because what we were having was only of 2,400, and now suddenly they increase the price of this Libre, which is almost 2 times. It is for their continuous glucose monitoring for the patients. That becomes little costlier, but still I think the Libre or Libre Pro is comparatively cost effective in compared to the Medtronic and Dexcom. Dexcom is very, very costly at present in our country.
Dr. Bansi and Dr. Gupta, one question, and even Dr. Das. The FGM becomes real time using GLIMP or the Ambrosia system. What is your opinion on that? Though it is not approved, can we as doctors tell our patients to use it as a part of treatment? Bansi, Dr. Gupta.
I do it. To be very frank, I do it. I mean, I have a patient with Ambrosia, and both we are using.
I know, but can we?
You and me both can talk, because we are not here giving any sponsor talk or support. So in NUCD, we can tell openly that yes, we are saying our patients to use Ambrosia, Glucon, Mayo. Yes. I mean, all these software, we are telling them to use it. And Jyoti Dev is the first man who told me to use this GLIMP, for your patients. So I'm sure Jyoti is here. So we started using it. For many of our patients, they are using this FGM as a continuous glucose monitoring.
I just had a question, Ritesh, to Sunil. How often have you used this CGM in the GDM and pregnancy? I talked to yesterday about that most difficult patient I had. I told you yesterday. Have you used CGM and FGM extensively for the diabetes pregnancy or most GDM patients?
Sir, to be very honest, I have not used very aggressively, but because it is not being actually approved by even DCGI to be used in pregnancy, neither the AGP, at least in India. Recently, I feel they got approval for Pro in UK. That's what I am aware of. But in India, it was not approved. But still, off-label, we have used it in few number of patients. And just in some of the patients who are non-GDMs, normal pregnancies with the normal glucose OGTT or GCT, we have used to just see how much is and we presented that data in some of the meeting, how much is the normal blood glucose in non-diabetic pregnancy, just to understand that what should be the target, what is being recommended for Indian populations. We have done it in around 7-8 patients, and we have come out with the good data, which we presented it. So that is how we did it. In difficult cases, we have used.
Yes,
so we have used it in few of the type 1, 2 or 3 type 1 patients, and a few of them of GDM. Pre-gestational type 2 diabetes, again, we have used in few, but not very aggressively as far as CGM, this Pro is concerned. Libre, I am not using very often. Somehow I found it, I have done it in one of the non-diabetic person, and it found very erratic readings that time. But again, we have to possibly understand it more, and it is very costly, ultra costly. Vidarbha is a very poor state. It is not like Gujarat, which is really a rich state. But Vidarbha itself is a good small place where people are not very affording. It's not like Mumbai or Ahmedabad. But so we have to be little cautious, and it's very cost sensitive market here.
Rajiv, your experience in neuropathy?
In chronic kidney disease, you said?
Kidney disease, DKD.
So, FGM, actually, the indication comes very high whenever you have hypoglycemia or hypoglycemia unawareness. And CKD seems to be right up there when we look at whether it's variability or nocturnal or fasting hypoglycemia. So whenever our patients develop hypoglycemia and repeated hypoglycemia and unawareness, we need to sense them to see how the sugar fluctuations occur. And chronic kidney disease is one place where there is going to be a lot of variability, because renal gluconeogenesis doesn't occur, and we all know how the fasting can drop in spite of very high sugars in the night. And that's where CGM will help in the management of patients. So I do use it a lot.
So we have used it in type 1 diabetes who had lipohypertrophy. And I feel that data you must have read it. It was in DTT, it got published. That lipohypertrophy, we put 7 days, the insulin has been taken at the lipo site and 7 days in the normal site. It could really differentiate the GV in the first 7 days when the insulin was taken at the lipo site versus and we have documented all Congo, MAGE, mean blood glucose, everything was statistically significantly lower when the insulin was taken in a normal site versus the lipohypertrophy site in type 1 diabetics. So we have done it in around 20 number of patients here.
Wow, nice.
Dr. Jayant, how much time we have?
We have no time.
It's already 5 years.
Okay.
I don't want to disturb when Bansi is there, Sunil is there, Rajiv is there, Ashok sir is there. I don't want to disturb. But
last question before I hand over to Dr. Ashok sir. Sir, last question, sir. To Dr. Rajiv. So what do you think? Which are the new technologies apart from what currently we're using like CGM and insulin pump, which are going to revolutionize the way we are treating diabetes in times to come?
I think apart from what we are looking at in terms of glucose sensing, I think a lot in terms of catching complications early would be where technologies would come in. So you have today AI-based retinal evaluation. Today you also have AI-based foot evaluation. You have a lot of apps which are helping in nudging patients coming to a better control. I think these and a good integrated software along with that will go a long way. So again, I would like to end where I started off, that we are very late in adopting technology, and we have only looked at technology in therapy. We have looked at either sensing glucose or giving insulin, but there is a whole pool of comorbidity and complications and detection of early complications which is being missed. I think that's where technology actually needs to come in.
Debashish, can I just ask you one question about the maintenance or the cost of the therapy of this 780G?
Sir, I'm not very sure because I'm not looking after India, so I'm looking at the Asia Pacific region. I'm not sure at what price they have launched in India. Whatever will be the price, you add if the cost of sensor, if you want to use it continuously, because the sensor works for 7 days. So for 30 days, you need at least 4 sensors. That would cost means around, I think, 3,000 rupees or 3,500 sensor cost. So 5 sensors per month. And apart from that, you have the consumables cost for the month, which is again around, I think, 3,000 or 5,000 rupees. And the cost of insulin. That would be the
is okay, but it's around 20,000 rupees maintenance plus extra apart from the cost.
More than that, Sunil. At least 35 to 40,000 rupees per month.
Jayant is looking at us. I think let us end the session. I have only one message to convey, which me, Jyoti, Bansi, all of us wrote. I think Rajiv, you were also one of the authors, where we said treating diabetes appropriately is cheap. So let the doctor decide if the technology there is necessary. It has to be used. That's my take on it, and I do that. And not treating appropriately, thinking that patient cannot afford. I think sure, the Sunil has patients who can buy anything in the world. It is the affordability is a very heterogeneous thing. So not treating appropriately is costly. Thank you very much. And I think I hand over to Rajiv and Debashish to close the session with their comments, short comments.
So I think I will leave. We are already late. Dr. Rajiv, please.
I think fantastic session, and technology needs to be there at the forefront. Let us all have good technology and good usage and good uptake of technology to help patients. Thank you so much.
Thank you. Thank you. Thank you.
And
we go to the next session then.
Yeah.
Yeah, it was a fantastic session. I'm silently watching, not disturbing anyone. Excellent cheering by Dr. Rajiv and Dr. Devasis. Excellent conducting of the session by Dr. Devasis and Ritesh. And our panelists are just fabulous. And Professor Das was part of the team, so that added to the value of the technology in diabetes. And Dr. Bansi Sabo, Dr. Rajiv Kovil, Dr. Sunil Gupta, Dr. Jyoti Dev, Kashava Dev, all did their best, and their doyens not only in the country, in the world. So with them, we had an enriched session on leveraging technology for diabetes care. I'm sure our delegates have taken maximum benefit out of it. We had a fantastic panel discussion after the presentation, and I'm sure there are many unending issues that will be, the time will ensure. So I thank everyone, especially Professor Ashok Das, Dr. Bansi Sabu, Dr. Rajiv, Dr. Sunil Gupta, and then Jyoti Dev, my good friend, for making it so lively and informative. So we'll move on. We are running a little late. So first thing I want to announce, the tea break which is there, 6:15 to 6:30 is cancelled, and we'll continue to the next session, and so that the yeah, so that the time gap which is there will be covered. And it's a very interesting session to all the practitioners. The oral anti-diabetic drugs, because for insulin, for technology, for nutrition, you need little effort, but you have to give a drug, and everybody wants to know which drug, when, and how. And to chair, we have none other than Dr. Surendra Shwai, our immediate past chairman of RSSDI Odisha, the very senior physician who has worked at all capacity at all offices, and at present is the professor of medicine at IMS Sham Hospital, Bhubaneswar. So I invite Professor Shwai and all our speakers here, Professor Ashok Das, Professor Jubin Jacob, Dr. Manoj Chawla, Dr. Nilanjan Sen Gupta are very senior speakers with befitting topics. And for moderation, I also invite Dr. Lalit Meher, who is part of the team, and both of us will take questions around. It will be a very informative session. First of all, I invite Dr. Surendra Shwai to introduce the first speaker, who is himself is the host of the program, Professor Ashok Das. Professor Shwai.
Thank you, Jayant, for your nice introduction, and I initially salute to Dr. Ashok Das, who is a mentor, and Alok Kanungo for his innovative idea of doing NUCD.
Tuti, please share the CVs. Tuti, please share this.
And Dr. Das is presently Professor of Medicine and Professor and Head of the Endocrinology Pondicherry Institute of Medical Science. He was former Senior Professor of Medicine and Endocrinology, Head Department of Endocrinology, and Dean and Medical Superintendent of Jawaharlal Nehru Institute of Postgraduate Medical Education and Research, Puducherry. Dr. Das has taught the medical undergraduates and postgraduates in medicine and diabetology for more than 33 years. He is member of Physician Research Foundation, Association of Physicians of India, and he is also a patron of RSSDI. Now, Professor Das will tell about the role of dapagliflozin as a first-line therapy in diabetes and beyond.
Esteemed chairpersons and my dear friends, I'm going to speak on a very, very important topic. I call it a bi-directional talk. One is on a molecule which has been hailed as the molecule of the decade. And second, about a concept which is absolutely fresh from the oven. How can we use the DAPA and DAPA plus M, most important DAPA plus M, as the first line drug? Jayant, I assure you, I will not exceed time. So I'll be a little fast in talking, but I'll touch upon all important points. You know, type 2 diabetes, 15 minutes, yes. Type 2 diabetes from its onset to diagnosis to complications gives many windows of opportunity. And one of the windows of opportunity we have today is to reduce BMI, even in the pre-diabetic stage or diabetic stage, to bring it down to green zone from to red. We have ways and window opportunity to reduce the risk of the microvascular complications in kidneys, nerves, and eyes. And we have many other opportunities which I'll discuss in a minute. Now, SGLT2, to a very, very brief summary of them, they are insulin independent. They work without insulin. Number two, they do not care for the insulin resistance. They are beyond insulin and beyond IR. Number two, apart from the hyperglycemia, they also work on hypertension, dyslipidemia, and obesity. That's very important. You know, the diabetes and call it as a polypill because it serves at least 4 to 5 purposes, single pill. But the nephro and cardios call it as a magic bullet. I'll show the presentation or a magic pill. But you know, for the type 2 diabetic patients, it's a polymagic pill. Please remember, for the type 2 diabetes, it's a polymagic pill. I have taken 18 presentations, but only the titles to show that the SGLT2 is the future, it is the star, it is the year or the decade of the SGLT2 inhibitors, and also it's a magic bullet, as nephros and diabetes call it, and the effect is beyond glucose lowering. But most important, today, what is gaining importance is the first-line therapy of type 2 diabetes mellitus. Now, there's a very seminal presentation which says that SGLT inhibitors are the first-line therapy for the diabetics with severity, no doubt about it. We'll come to it. And also, it presents it's effective in the HF-ref, HF-PEF, and the pillar of care for the hypertension and the reducing hospitalization, etc., etc. There are also papers, 6 papers are posted here, which shows the importance of DAPA for the CKD. We cannot forget it. The importance of DAPA for CKD is DAPA CKD, and the other trials have shown very clearly how DAPA works as a renal protector, how it works in every severity of CKD, and how we can have a victory over the CKD with this new drug, etc., etc. I will not time on it. But most important issue that as per the ADA 2022 criteria published 1.5 months back, the therapy recommended should include multiple and concurrent evidence-based approach to take care of the not only glycemic management, BP management, lipid management, and cardiovascular and kidney management. And DAPA foots the bill. Dear friend, across the spectrum, whether monotherapy or add-on to metformin, add-on to SU, add-on to DPP4 plus minus metformin, add-on to insulin plus minus OADs, you see the amount of reduction in HbA1c versus the placebo. So it's a very effective anti-glycemic agent. And about the weight, you see the glipizide and metformin, you see the weight gain is 0.136. In same time, here the weight loss is minus 3.7. So DAPA gives a weight benefit of more than 5 kgs. Now it is not just the glycosuria and the weight. We wrote a paper in JAPI, we called it a vascular euphoric drug. You know, me, Mangesh, we wrote it together. And you know, why it is a vascular euphoric drug? Because it has a lot of vascular benefits. Metformin has a lot of, we call it metformin is a metabolic cum vascular drug. Metabolic cum vascular jada. So similarly, today, the combination of both the dapagliflozin and metformin stands out as a very prominent vascular drug, taking care of the hemodynamics, taking care of the various issues, muscle cells, monocytes, macrophages, endothelium, the PCT, the cardiac fibroblast, adipocytes, cardiomyocytes, and having a very, very beneficial effect on the blood pressure, arterial stiffness, atherosclerosis, endothelial function. So this is a pleiotropic effect on the cardio and vascular system. Dear friends, today DAPA is hailed as a game changer. I'll tell you that DAPA HF is approved by FDA for the HF ref. And you know, in the updation of guideline of 2021 in 2022, of course, in ACE and the NICE, the DAPA CKD has been approved even for the CKD in diabetics, and of course, for the cardiac and the kidney, both diabetics and non-diabetics. But most important, 2019, the European Society of Cardiology gave a clarion call that this should be the first-line therapy. And the generic dapagliflozin, once it came and became very affordable, the guidelines have included, including RSD guideline, that dapagliflozin as a first-line of drug for the type 2 diabetic patients who have, I'm qualifying it, who have atherosclerotic cardiovascular disease or a spectrum of cardiac risk factors. So today, the only affordable SGLT2I for glycemic control, HFrEF, and kidney disease has been DAPA. Dear friends, you see here, in the pre-DAPA generic era, October 22, the DAPA was number 18 drug. Today it has come to 18 drug. Lo and behold, it has been estimated that within 6 months, it will reach top 3 drugs. What does early addiction of DAPA do? Dear friends, I have got 6 slides to show the benefit of the early DAPA. Number 2, we have to bring our clinical inertia in managing the cardiorenal risk. As Jyoti said, if you do not adopt technology eat us up. If you do not tackle cardiorenal risk, this CRM risk will take over us. Now, why we should start? We have got about 5 inertia. We say we don't have personal experience of prescribing this drug alone or with metformin. You start early. Skill comes through practice. Prescribe, practice, skill come to you. Competing priorities like obesities, but you have to address the comorbidities. Therefore, you have to give a drug which takes care of both. You say you have a limited knowledge about this drug, but there's a strong cardiorenal metabolic benefit and evidences which nobody can close eyes to. Lack of interdisciplinary, how can I prescribe a cardiac drug, a renal drug? But dear friends, we have to develop communication with the patient and also with these specialties which take care of it. Treatment re-evaluation, we must evaluate, monitor these parameters to show the benefit and feel ourselves. Now, if you add DAPA metformin or DAPA and DAPA plus M early, you see early versus later use of dapagliflozin was associated with a greater likelihood of adjusted H1C reduction of more than 1% than adding it late. So early addition of dapagliflozin, DAPA plus M is very beneficial, not only for the blood sugar correction. You see, even if you initiate the drug as a second line drug, if the patient does not have the cardiac factors, do not have the ASCVD, metformin number 1, then you add the second line drug as dapagliflozin. You see, among all second line therapy, take all the drugs in second line therapy from metformin to SGLT to all other drug, DPP4 issue, you find that this lowest treatment change or lowest discontinuation, meaning thereby patient accept this therapy very much. If you give early initiate dapagliflozin, there is benefit of lowering of the MACE in patients who have ASCVD and severe risk factors, and impact is more marked in the patients who have more number of severe risk factors. So MACE and severe risk factors are less. Here are 5 benefits of early addition of dapagliflozin. Number 2, early intervention, achievement of glycemic control, reducing the long-term risk of micro and macrovascular complications. Number 2, this has been found in patients with or without diabetes. Early use of DAPA in newly diagnosed type 2 diabetes mellitus reduces the progression of atherosclerosis, improves glycemic control compared to other therapies. It shows benefit of delaying, at least postponing, onset and worsening of renal complications. It by lowering serum creatinine, reducing albuminuria, and decreasing mortality associated with renal kidney disease. This is all over the place in the literature. DAPA is also under evaluation today for the treatment of NAFLD, the non-alcoholic steatohepatitis of the liver. Not final word is not available for the obesity, but we know absolutely clearly minus 3.5 to 4-5 kg weight loss can be there. It's being evaluated for type 1 diabetes, acute MI, dyslipidemia, and insulin resistance. Though dapagliflozin as an early addition makes a suitable first-line drug. What does guidelines say? Very important. You see, ADA 2021 said indicators of if the patient has indicates high risk established ASCVD, CKD, or heart failure, one can consider adding the drug which is meant for them, that dapagliflozin. And if you see ADA 2022, again it has said they recommended independently of baseline blood sugar. If the patient has ASCVD, heart failure, has got CKD, this becomes the first line drug. Otherwise, metformin plus the metformin plus this drug. Now, these are the few recommendations of ADA 2022. First line therapy depends on the comorbidities, patient-centered treatment factors, and management needs, and generally includes metformin and comprehensive lifestyle modification. Other medications, the point focus here, SGLT2I, mostly the DAPA, the generic one, with or without metformin based on glycemic needs, are appropriate initial therapy for individuals with type 2 diabetes at high risk of atherosclerosis, cardiovascular disease, heart failure, or CKD. Early combination therapy extends the time to treatment failure. If you start it early, the treatment failure time is extended. Number two, patient-centered choice is the most important thing now. The 2019 European Cardiology Guideline, which says that even the patient on metformin or drug-naive patients, if there is ASCVD, CVD, they said they even did not go to say ASCVD. They are the cardiology guideline. They said ASCVD, CV risk, organ damage, multiple risk factors, start SGLT2 first, then add metformin, or if there is a metformin already there, add this dapagliflozin and continue it. Now, what are the proven cardiovascular benefits of dapagliflozin? Dear friends, I have no time. The DECLARE TIMI is the trial for prevention of the cardiac onslaught. The CANVAS program, the DAPA-CKD program, and DAPA-HF program all have showed there's a great benefit on the atherosclerosis, for the myocardial infarction, on the diabetic cardiomyopathy, heart failure, and cardiovascular death. So much so that the heart failure benefit 1 in 21, the mortality benefit 1 in 46, and 1 in 19 the benefits, overall cardiovascular benefits. Now, I'll not go to the patient because of lack of time, but there's a patient who had STEMI, also had a percutaneous implantation. He had referred 3 weeks later for a follow-up examination. History of diabetes 6 years, dyslipidemia 4 years, the blood sugar in hospital 160 to 180, along with other OAD. He's on cardiac medication. He's obese, BMI is 26.8, and the fasting glucose 121 and 160. Now, if you see any patient, we see every day in our clinic who have got type 2 diabetes mellitus with heart disease, because heart disease is very closely related to diabetes. Diabetes itself is, in 2004, they declared diabetes as heart disease. So it's a very closely related. So if a patient has type 2 diabetes, high risk of MACE or CV death or heart failure, the drug of choice is definitely dapagliflozin. The SGLT2 inhibitors, and we are talking here the most affordable one. And here is shown the effect of dapagliflozin for 10 milligram versus placebo. You see the effect on the MACE, CVD, heart failure, and the renal benefits. So therefore, the risk factors, without established CVD, if the risk factors are more, it has been also said that DAPA is the drug of choice. In DECLARE TIMI, patients with prior MI experienced a significant 16% RRR, relative risk reduction in MACE, and absolute risk reduction in 2.6 to 3% cases. Now, only concentrated on this dapagliflozin reducing the risk of HHF, hospitalization because of heart failure, and adverse renal outcome is independent whether patient is old or young, male or female, obese or non-obese, early diabetes or duration of diabetes longer, but if you give towards the late, the benefits are less and you are losing the window of opportunity, irrespective of HbA1c, irrespective of eGFR, irrespective of the previous history of heart failure and number of risk factors. So dear friends, the dapagliflozin has been used as a primary preventing drug in the primary cardiovascular prevention cohort in DECLARE TIMI 58 trial, only one trial of its kind across the board to reduce to produce primary prevention of the heart disease and diabetes mellitus. Now, in DAPA-HF to preventing heart failure, I've just shown one slide, not beyond this, you will find that the 26% relative risk reduction of the heart failure and number needed to treat is 21. See the immense benefit of this. Next, we'll pass on to the mechanism. The mechanisms are not clear. We do not know whether it is because of the augmentin diuresis, because of the excitation contraction coupling, whether it is because of the keto pathway of the metabolism, nephroprotection, whether it is improving autophagy, decreased inflammation, decreasing fibrosis, whether decreasing epicardial fat. All these are being investigated, and most of them are shown to be true. But there's also mitochondrial aberrations, which are also set right by the dapagliflozin. But the truth of the pudding in eating it, we know for certainty, whatever the mechanism, SGLT2 has great benefit on the heart failure and these risk factors. Dear friend, you take any type of diabetic patients, any type of patients having heart failure, whether type 2 diabetes, even non-type 2 diabetes, background heart failure therapy, they're on any therapy or devices or not. Baseline LV ejection fraction, whether it's 35 or 25 or it's only 55. Renal function, eGFR is more than 60 or even less than 60. Diuretic therapy is there or not there. The heart failure etiology, whether ischemic etiology, non-ischemic etiology, systolic blood pressure high or low, whether patient already on neffrolizine like sacubitril and valsartan, whether baseline NT and pro-BNP are high or not so high, across the presence of heart failure, dapagliflozin produces consistent benefit in all varieties of patients. Dear friends, about the kidney, DAPA has cut the incidence of worsening kidney failure by 40% with a number needed to treat of 19. I was referring to this to prevent one primary outcome. Even after a median of 2.4 years, we need 19 patients to produce the benefit, a great benefit. So this graph shows the primary outcome benefit, 39% I told you just now. And also I showed you the various secondary outcome benefit of the kidney failure. In the DECLARE TIMI 58, they also looked after the kidney problem and they found that they had a slower kidney disease progression and reduced the event on the kidney disease. The U1 microalbuminuria came down by 46%, albuminuria by 21%, and albumin category reduction by 27%. Now, amongst all dapagliflozin, generic dapagliflozin is an ideal for the SGLT2 Indian setting. You know, we have a saying in the government of India, Indians are brand conscious, more than brand, they're the price conscious. So therefore, the Indian patients who have higher abdominal adiposity, who have higher waist circumference, low level of adipokine, high plasma leptin, low rate of glucose disposal, impaired insulin secretion, the SGLT2 can reduce body weight, reduce waist circumference, reduce triglycerides, and the leptin, and increases the rate of glucose disposal, improves beta cell function, not yet totally proved, and improves insulin resistance. This is a beautiful concept. You know, the least cost effectiveness is in this quadrant. Best cost effectiveness in this quadrant. What is the least cost effectiveness? Is the best cost effectiveness is the Indian generic dapagliflozin, because at a price of 10 rupees average, we can get maximum benefit of all the SGLT2. And no, least assured utility, other events do not produce assured utility in all these renal, stroke, quality of life and life years. And remo also become more costly because of giving drug twice a day. Therefore, dear friends, before I close, I must tell you that for decades, good glycemic outcome control was the only way to reduce CV and renal risk in diabetic patients. DAPA can prevent, the generic DAPA and more so generic DAPA plus metformin can prevent CRM risk, cardio-renal metabolic risk, independent of the H1C travel. And in the beginning, we said it reduces A1C across the board. DAPA and DAPA-HEM have impacted type 2 diabetes treatment, heart failure treatment, and CKD guideline across the globe to define a new standard of care to use it at the first line treatment. The treatment naive patients with type 2 diabetes mellitus, DAPA plus M is well tolerated and effective in reducing H1C, FPG, and weight. And much before this drug, this was become generation came, we had cut down the price by giving combination of DAPA plus metformin, and we have used it plenty and found great benefit. Low cost DAPA and DAPA plus metformin is an effective, safe, and reasonable choice for the treatment of type 2 diabetes patient with multiple risk factors and multiple comorbidities. So therefore, DAPA should be initiated as first-line therapy. Before I close, I'll just tell a story of 2 American presidents. Now, it is one president died because of tuberculosis, because anti-TB drug was not available. But one other American president, Roosevelt, he died of hypertension. When Pickering and Platt were debating whether hypertension is somebody's personal property, whether hypertension treated or not treated, he died of brain hemorrhage. Dear friends, I personally believe having a generic dapagliflozin, which is affordable, which is appropriate, which is available and easily accessible, the generic DAPA, not to use it is no more acceptable. Thank you very much for the time you gave me and also for a very patient hearing. Over to the chairpersons.
Thank you, Professor Das, for your eloquent and excellent presentation on dapagliflozin. The generic dapagliflozin is available everywhere, cheap and not costly, can be affordable by all Indians, and it has so much advantageous cardio-renal metabolic effect And also ADA 2021-22 has approved it as the first-line drug. And with metformin, it can create miracles. And in all cardiovascular diseases, it gives a benefit and renal benefit like DAPA heart failure study and DAPA CKD studies. And other previous studies I declared TIMI and empiric trials also have showed it. So all these things has proved dapagliflozin as the number one drug along with metformin if it is initiated earlier or can single, and it is now is beneficial in heart failure with or without diabetes in reduced ejection fraction. And in renal benefits is much more also, and therefore it is one of the wonder drug now with diabetes. Now let us go to the second topic, the evergreen modern sulfonylurea by Professor Dr. Juvin Jacob, who is the professor and head of Department of Endocrinology, Christian Medical College, Ludhiana, ex-executive editor in the Journal of EM, and member Institutional Research Board, International Fellowship at JJR MacLeod Center for Diabetes and Endocrinology, Aberdeen, United Kingdom in 2012 to 14, honorary lecturer, School of Medicine and Dentistry, University of Aberdeen. Author of 3 books, Endocrine Disorders in Pregnancy, Diabetes in Women, Clinical Update, Management of Diabetes mellitus and Complications. Now over to Dr. Juvin Jacob for the evergreen modern sulfonylureas. Dr. Jacob.
Address line 1, address line 2, please.
Thank you, Dr. Soin, for that kind introduction. And thank you, Dr. Kanungo, for the invitation for NUCD 2022. I think Dr. Ashok Das has already spoken very eloquently about the new drug. And I have to talk about evergreen modern sulfonylurea. So I had to find out what evergreen actually means. And if you look at Bollywood, evergreen means anybody who's still who can still play a leading role after the age of 50, 60. So for when a hero can play a leading role for 50, 60 years, you consider him an evergreen hero. And there are few people who have, consistently played leading roles for 50, 60 years. One of them is Devanand. And Amitabh Bachchan also, most of you would have seen, has been around now for 50, 60 years. So exactly 50, 60 years is how long sulfonylureas have been around. The first sulfonylurea was marketed in 1956. And it is now very much evergreen. And I'll talk a little bit about the background because I'm sure everyone knows everything about sulfonylurea. What I'm going to talk about is a little bit of history to show you why it is evergreen. My another favorite evergreen set of heroes are from the James Bond movie. And the first James Bond movie was also launched approximately the same time when we had our first sulfonylurea launched in around 1958. That was Sean Connery as Dr. No. So that was the first James Bond movie. And we know recently Daniel Craig has had the last James Bond movie last year, 2021, and he has said that he's not going to be James Bond anymore. And we are on a lookout for a new James Bond. So James Bond movies have been around for 60 years. Sulfonylureas have been around for 60 years. Just to say that long before there were drugs for diabetes, sulfonylureas were worked on as herbicides and subsequently as antibiotics. And it's a French physician who was actually looking for drugs to work against enteric fever who first discovered that the drugs he was using as antibiotics, the sulfonylurea drugs, were actually killing the animals on which he was working on. And then he found out that the cause of death, and most of them, was hypoglycemia. And subsequently, this was around 1942, he contacted a colleague of his in the same university they were working, Auguste Labotre, who was actually the person who started working on sulfonylureas among his patients with what was then known as mild diabetes, or which is now we know is type 2 diabetes. So I think from 1942, we first knew about sulfonylurea, but it took a long time for it to come into the market, which is easy to understand because 1942, within a year, France, where these drugs were being researched on, came under World War II. And for almost 3 years, French were occupied by the Germans, and most of that research work went into German hands. And unfortunately, in 1945, when Germany lost the World War, most of that information went to East Germany, where that information was subsequently almost lost. But some of this research was smuggled back into West Germany, and in 1956, we had the first 2 sulfonylureas marketed in Germany and subsequently to Europe. And then we had sulfonylureas. The Lilly was at that time the biggest diabetes company because it was making the maximum amount of insulins for the world. So both these, Lilly and Upjohn, these were 2 American giants. They were in a race to find the best sulfonylurea, and Lilly bet on what was called carbutamide, and Upjohn bet on a drug called tolbutamide. And unfortunately, carbutamide was found to have a lot of toxicity, and it was withdrawn. The first actual long-term sulfonylurea that came to be marketed all around the world was tolbutamide. And the drug, trade name of the drug was actually, we'll show it later, but I think what is again interesting is this is the same time or the same pathway that metformin took as well. Metformin was also a drug which was discovered in France, went around Europe for many years before it was picked up by America. So both sulfonylurea and metformin, 2 of the most widely prescribed drugs, were discovered by French physicians and subsequently went to Europe, came to India, and later came to America. So it took a longer time for these drugs to reach North America. So with this, just to tell you that the first sulfonylurea was called Orinase, which was tolbutamide by Upjohn Pharmacy. And if I just Googled Orinase, whether it is still available, and very surprisingly, Orinase is a brand of glimepiride in Pakistan. So they are still using the old trade name for tolbutamide. With this in mind, I think you should also remember that the first ban for a drug for diabetes, the first OAD was not rosiglitazone or was not troglitazone. The first FDA ban for an OAD was also for sulfonylurea, which was again tolbutamide. 1956 it was available, and by 1970 it had been banned. And again, this ban is also very similar to what happened with rosiglitazone. This was from a badly conducted study called the UDGP study, which is UGDP study, which is the University Group for Diabetes Program, where they suggested tolbutamide had an increased risk of cardiovascular events. And even before the FDA could ban the tolbutamide, there was a lot of newspaper reports and many patients stopped taking, and there was a lot of pressure on physicians to stop prescribing this. And so that was the first time we had a ban. And then subsequently for almost from 1970, before the second generation of sulfonylurea came about, there was only one sulfonylurea which was available, which was fluorpropamide. And then in 1980s, we had all these second generation sulfonylurea, which came about. A lot of them came about, but 3 of them are still with us, which includes glibenclamide, glipizide, and gliclazide. And then in 1995, we had the third generation or the last sulfonylurea, which was approved, which was glimepiride. So I think the whole 60 years we've not sat on the same sulfonylurea. We've had consequent improvements in sulfonylurea, and what we have is what we call the end product of all these 60 years of development of sulfonylurea. But I think people were still worried about sulfonylurea even in 2012 in this editorial about CV safety, despite the fact many people had very clearly said that UGDP was a poorly conducted randomized control trial. Even 51 years later, people were using that to say that sulfonylureas are not cardiovascular safe. And I think this is despite the fact at that time UKPDS and Advance had already given good indications that there is no concern about CV safety. These were not primarily triggered for CV safety for sulfonylurea, but both the UKPDS and Advance had suggested that there was no increased risk of cardiovascular disease. Even when the older generation in UKPDS, it was glibenclamide which was used, and in Advance, it was gliclazide which was used. But finally, I think sulfonylureas had their day in the sun when we had 2 large randomized control trials, the TOSCA IT in 2017, which actually compared head-to-head sulfonylurea. I mean, it was not just glimepiride, gliclazide, glimepiride versus pioglitazone, which by that time had already been demonstrated as a good drug in terms of cardiovascular safety. In fact, it had already demonstrated cardiovascular benefits in terms of decrease in strokes and decrease in myocardial infarction. So TASCA, IP, and finally, I think in 2019, 2 years back, we've had the Carolina trial where it was directly compared to linagliptin. So I think cardiovascular safety is now very clearly established. We do not have to worry about this. Even after 60 years with the third generation sulfonylurea, we have very reassuring cardiovascular safety. Unlike what Dr. Das was talking about, dapagliflozin protecting you, they do not cause any damage to the heart or cause any increased risk of heart failure or cause any problems with atherosclerotic cardiovascular disease. So with that clearly behind us, I'll just once highlight what the Carolina surprise was. We know that this was not a placebo-controlled trial, a direct head-to-head comparison of about 6,000 patients, who were about 3,000 of them were on 5 milligrams of linagliptin, the other 3,000 on a titrated 1 to 4 milligram dose of glimepiride. And the primary outcome was the standard 3-point MACE. And you can see both of them had similar outcomes, showing that none of them was better or worse than the other. Both of them were equally good or cardiovascular safe. So with that in mind, I'm sure Dr. Das also showed you this picture, and he told you that dapagliflozin is going to help you with blood pressure management. It's probably going to give you some additional cardiovascular kidney benefit, and also help with glycemic control. With sulfonylureas, unfortunately, I'm not going to look at the other three pillars, but I'm going to tell you one thing, that the one single pillar it helps at, that is glycemic management, it is probably the most potent oral anti-diabetic drugs in terms of glycemic management. It does not help you with blood pressure control, does not help you with lipid management. We have to use a statin, we have to use an ARB, we have to use drugs to protect the kidney and the heart. But at least for glucose control, it is the most potent glucose control in terms of an oral anti-diabetic agents. And regardless of all the agents that have come afterwards, including DPP4 and SGLT2, none of them can match the HbA1c lowering capacity of sulfonylurea, which was, and here it is glimepiride. One exception to that may be oral GLP-1 analogs, which we are currently going to see in the, and probably going to come around this year. But from the currently available armamentarium that we have of oral agents, we do not have a drug which is as potent as glimepiride. With this in mind, I think you have to remember that this is both in case when it is used as monotherapy. Here we have the bars with monotherapy, and then also when it is used in combination with metformin as a combination therapy. In both, these are the most potent drugs in its class. And I think this is just a meta-analysis, just showing the same thing that I showed in bar graph, that the sulfonylureas are the most potent oral anti-diabetic agents in trying to bring down HbA1c. So it only helps at one pillar, but it is a very, very strong pillar when you use sulfonylureas for glucose control. Now, Evergreen Hero has been around for 60 years, no new movies coming out, but the main arguments against this are it should not be used for younger patients because we can use better agents for younger patients. It should not be used for long-standing type 2 diabetes because once you have long-standing type 2 diabetes, you have less beta cell function and you are less likely to improve with sulfonylurea, and obviously for cardiovascular disease. And I'm sure I've reassured you about cardiovascular disease. That controversy is over. I'm just going to show you a few data about the use of this drug in newly diagnosed or what we call young diabetes. This is a recent paper from Dr. Yagnik and group, which is looking at patients with young onset type 2 diabetes in India. And what he suggests is the primary driver for glucose or hyperglycemia in these patients is insulin deficiency. And he has, in this particular paper, young diabetes or young Indians has been defined as patients with type 2 diabetes diagnosed before the age of 45. And the results are very clear that it is lack of insulin secretion that is responsible for the hyperglycemia. So it is very easy to understand why sulfonylureas will be the drug of choice for patients who have poor glucose, poor insulin secretion, because these are drugs which are actual secretagogues which are going to improve insulin secretions. The other extreme is patients with long-standing type 2 diabetes. And here again, I think I wanted to show you a paper. This is about an 8-year-old paper where they have added glimepiride to patients with long-standing diabetes. These are patients with at least 10 years of diabetes. They have added insulin, added glimepiride to an insulin metformin combination in type 2 diabetes with more than 10 years duration in a placebo-controlled manner. And what they can see is even in patients with diabetes, which is more than 10 years, who are on insulin, who are on metformin, adding glimepiride gives you benefits in terms of HbA1c compared to placebo. So this is just to highlight again that even long-standing diabetics may not get the same degree of HbA1c reduction, but you still do get lowering effect of these evergreen modern sulfonylureas. And in terms of insulin sparing, this is a small paper in DRCP which suggested that glimepiride is probably the most potent in terms among the current sulfonylureas that we have in terms of sparing effect of insulin of the sulfonylureas itself. So I think I'm ticking all the boxes now in terms of it can be used in newly diagnosed younger patients. It can be used in longer type 2 diabetes. It definitely has no concerns with excess mortality or morbidity with cardiovascular disease. So with all of these things, I think we do have the Daniel Pig, which is the latest modern sulfonylurea, which is glimepiride. And I'm sure for its evergreen and will continue to have a leading role in the management of oral of type 2 diabetes with oral agents in the years to come. 60 years, it has already played a leading role. And I'm sure Dr. Ashok said that dapagliflozin will be the number 3 prescribed drug, but I think metformin and sulfonylurea will continue to occupy a number 1 and 2 spots in terms of oral agents for some more years to come, 60 years and counting. And I think out of the sulfonylureas, glimepiride is the one which is going to play this leading role. And I've shown you that in terms of efficacy at this point among the agents that we have, oral agents that we have, there is nothing that matches glimepiride. And in terms of it's used in all kinds of patients, whether it is younger patients, older patients, long-standing diabetes, cardiovascular disease, I don't think there is any combination. And I think what we have to realize is there is now more than enough data about cardiovascular safety. And I think those issues are now should not be brought up again. So with this, I thank you for the opportunity to speak about evergreen sulfonylureas, and I think I'll stop sharing here. Thank you very much.
Thank you. Thank you, Dr. Jacob, for your excellent and lucid presentation on newer sulfonylureas and glimepiride being the cheapest one. And it's available all over the country, everywhere. All the physicians practice, and it's all practice with glimepiride. And all the glycoside is there, but glimepiride takes over glycoside. And it is very cheap, is a good secretagogue, and also easily available and can be affordable. And also the patient can continue with this drug for long-term benefit of diabetes control. And it can be given in, this Carolina trial has given its comparison with linagliptin, therefore it can be given in cardiovascular problems or long-standing diabetes, and it has a useful measure in diabetes control in India, especially a poor country. Thank you, Dr. Jacob. Then we'll go to the next topic. The role of evergreen metformin in the pre-diabetes epidemic by Dr. Manoj Chawla. Manoj Chawla from Asian Institute of Cardiac Science is MBBS diabetology with fellow of the RSSDI and fellow of RSC, and director and consultant diabetes at Lina Diabetes Care and Mumbai Diabetes Research Center, Andheri West, Mumbai, consultant diabetologist at SL Raheja Fortis, Mohim, Mumbai, BSCS Municipal General Hospital, Andheri West, Mumbai, founder president of United Diabetes Forum, honorary visiting faculty at Patil Medical Sciences, Navi, Mumbai, awarded RSSDI Fellowship for the year 2017 and Fellowship for the Royal College of Physicians of Edinburgh for the year 2019. Principal investigator in various global MNC clinical trials for NCs and devices, technology task force member in RSSDI, more than 20 papers in national international journals, and is the associate editor, International Journal of Diabetes in Developing Countries. Now, Dr. Manoj Chawla for the topic, the role of evergreen metformin in the pre-diabetes epidemic. Dr. Chawla. Welcome.
Welcome to NUCD 2022. And today we have to discuss a very important thing with one of the best frontline practitioner, academician of the country, Dr. Manoj Chawla. And we are going to discuss about pre-diabetes and metformin. As we know, diabetes epidemic with 537 million diabetics between the age of 20 to 79 are there in the world. And for every known case, there is an unknown case. And as we know, there is another group of people whom we say pre-diabetic are almost 541 millions. So Dr. Chawla, what is this pre-diabetes?
Good evening, Dr. Kanungo and everyone here, and pleasure for being again at NUCD. A very, very valid discussion and topic, and I must congratulate you because it's not very often that people are talking about pre-diabetes as much. And to get directly dive into the question that you asked, what is pre-diabetes? So pre-diabetes is nothing but pre-diagnosis of diabetes. It's actually a warning sign of things to come. It is actually a condition which should not be viewed as a clinical entity, but rather as a condition which has increased risk for developing diabetes and cardiovascular disease. We need to understand that by the time a person develops clinical diabetes, almost 50 to 60% of the beta cell to clinical diabetes start several years before one develops diabetes. That entire period of worsening and increasing insulin resistance, declining beta cell function, with some increase in the numbers is what is called as pre-diabetes. So again, I repeat, it is pre-diagnosis of diabetes, what is referred to as pre-diabetes.
So it brings a very important question. How do you diagnose pre-diabetes?
Of course, yes. So a very valid question again, that how do you diagnose pre-diabetes? Now, if you go by the numbers, and there are the criterion laid down, for the ADA criteria for the same would be to look at the fasting sugars, the 2 hours post glucose or 2 hours postprandial, and also the HbA1c values. So there are actually 3 parameters which can help us pick up individuals with pre-diabetes. When we say impaired glucose tolerance, it means those individuals whose postprandial or post-glucose, essentially it is the post 75 grams glucose sugar, which lies between 140 to 199, are individuals who belong to impaired glucose tolerance as long as their fasting sugar is normal and less than 125. However, there is another aspect to pre-diabetes, and that is impaired fasting glucose, wherein the fasting blood sugar lies anywhere between 100 to 125. Those individuals will be labeled as impaired fasting glucose as long as their postprandial glucose lies less than 140. And then HbA1c has also evolved as a wonderful tool to pick up individuals with pre-diabetes, and in fact gaining more popularity worldwide, which is an HbA1c value between 5.7 to 6.4 is looked as pre-diabetes. Less than 5.6 is considered normal, and of course 6.5 and above is considered as diabetes.
This is very important. So once we do the routine glycosylated hemoglobin test, and it is between 5.7 to 6.4, we should strongly suspect that the person is having pre-diabetes. And do people call it in any other name, any terminology for pre-diabetes?
Well, actually, yes. So as I said, there are different terminologies in literature, and interesting that you should ask that, because the ADA calls it pre-diabetes. The WHO actually for the long time has referred to it as intermediate hyperglycemia. And if you look at the IDF literature, the IDF, the International Diabetes Federation, refers to it as impaired glucose tolerance. So pre-diabetes, borderline diabetes will be more colloquial, but pre-diabetes, intermediate hyperglycemia, and impaired glucose tolerance are the terms referring to pre-diabetes.
In India, by your estimate, how many percentage of people or how many numbers will be there with pre-diabetes?
So
because that will be a very major problem for our revenue planning, health planning, and everything.
True, Dr. Kanungo, sir. And actually, rather than me just speculating and thinking, there have been some data which has been looked upon. In fact, the ICMR in-diet population-based study by Dr. Anjana Mohan and others, when they published this paper, they looked at the prevalence of pre-diabetes in about 15 states in India. And they found that the percentage of the prevalence of pre-diabetes was anywhere between 7 to 15% across the different states. In fact, when they looked at the northeastern states also, within the northeast, again, you had some states which were 7% and some going as high to 15%. So in general, we would believe that the prevalence of pre-diabetes is actually as much as the prevalence of diabetes today, and hence a huge scope, a huge window of opportunity for us to pick up these individuals, to screen the population, find out who may be in that susceptible population, in that pre-diabetes population, and try and do whatever is possible to prevent the progression from pre-diabetes to diabetes.
Right. So this here, once we know the situation, we have a scope to prevent diabetes in this group of population, or try for DPP, diabetes prevention programs, and so on. You know, as per your statement, people develop pre-diabetes, then go to diabetes. Is there any risk factor? Who are susceptible to develop from pre-diabetes to diabetes? What are the risk factors?
Right. So again, there have been classical risk factors which have been identified, and honestly, they're not very different from the same risk factors for the metabolic syndrome or risk factors for diabetes. So age, as the age progresses, the chance of pre-diabetes is going to be higher. There is a certain male sex preponderance for developing pre-diabetes. Obesity is a definite contributor again to increased chance of pre-diabetes. Comorbidities like hypertension are again very often predisposing an individual. So those with hypertension clearly should be screened on a routine basis for presence of any glucose intolerance. And then, of course, family history of diabetes. So family history diabetes, hypertension, obesity, male sex, increasing age would be some of the classical risk factors for developing pre-diabetes. And this would be similar whether it's in the urban or the rural areas. Having said that, Dr. Kanungo, I would again like to remind everyone that just as we speak about diabetes, there would be many out there who have no known risk factors and still land up developing diabetes purely because of the changing environment, the lifestyle, the financial prosperity, so to say, and the limited physical activity. And hence, even for pre-diabetes, there may not be risk factors. And that's why the general screening in the population today is so important, to pick up individuals in that zone who may be in pre-diabetes, where we can offer help early in the life of this person's pathological metabolic journey.
Absolutely correct. As Jocelyn told, that we are only observing the tip of the iceberg, and there is a huge lot inside that hidden for us to discover. Now the question comes, is this pre-diabetes is a treatable condition, or only lifestyle will manage it, or what should do? We cannot say that you have pre-diabetes. We must give some solution. How do we treat it?
Of course, and I think that is the idea of picking up these individuals. So clearly today, the insulin resistance is an extremely strong contributor to development of pre-diabetes and diabetes. We also must remember here that pre-diabetes in itself has a link with increased occurrence of cardiovascular disease as compared to individuals with normal glucose tolerance. So the pre-diabetes, individuals with pre-diabetes itself should be treated to improve their glycemia. And of course, a lot needs to be done to prevent the progression from pre-diabetes to diabetes. On an average, about 20 to 30% patients over a period of 2 years would move from pre-diabetes to diabetes. Of course, there would be different epidemiological data from across the world, some putting it at a higher figure, some putting it lesser, but this is the average that I'm speaking. So help needs to be offered here, and that management and help comes in form of both the lifestyle change that we can induce or we can encourage in our pre-diabetes individuals, and then there has been some evidence with the therapies as well when it comes to what has been seen in the studies and what can be done with different drugs where we've seen some success in preventing the progression from pre-diabetes to diabetes.
Which drug do you mean commonly available? Do you mean metformin?
Well, yes. So metformin is the number one drug when it comes to what has been maximum evidence for using in individuals with pre-diabetes. But let me take a step back here and say that when you're talking about the lifestyle change, what exactly are we trying at pre-diabetes? So from the lifestyle modification point of view, we are essentially looking at a 5 to 10%, on an average, a 7% weight loss that individuals with pre-diabetes can achieve, and moderate physical activity, which could be defined as about 150 minutes of walk per week. These two habits, if we are able to achieve, that has an extremely helpful impact in prevention of worsening or progression from pre-diabetes to diabetes. In terms of drugs, there have been some drugs which have been tried in the different trials. To name a few, we've had maximum evidence for metformin, as you rightly mentioned. There has been some data for drugs like the alpha-glucosidase inhibitors, both for acarbose, we had the STOP NIDDM trial, and then there has been some data from voglibose. And then you had liraglutide also used in this segment with some limited success. The one drug which was also tried and didn't show in the Navigator trial, I think, was nataglinide, which did not show much help in the pre-diabetes to diabetes. But coming back to metformin, that is the drug in consideration and clear recommendations for that in the pre-diabetes group.
Do you have any evidence? Our clinicians or diabetologists would like to know, why should they use metformin for pre-diabetics? What is the evidence for metformin in the use of pre-diabetic patients?
Sure. Yes. So I think everything needs to have substantial evidence for it to be accepted and used. So one of the biggest trials, as you also mentioned, for metformin was the diabetes prevention program in the US. So this was a study which was done in individuals with pre-diabetes. This was across, I think, 27 centers in the US. And they used metformin in a reasonably high strength. This was 850 milligram twice a day, which they used in patients across the study for 3 years. And then you had follow-up periods. In fact, you had a follow-up period for these individuals at the end of 10 years and then an extension at the end of 15 years. So the largest study to date, even if you look at the primary period of 2.7 years, has been the diabetes prevention program, which showed that the intensive lifestyle modification was the plan in that trial, scored the best in terms of prevention from pre-diabetes to diabetes. And this was followed by metformin. So metformin was close to 27, 28%, and the lifestyle change was closer to 40%. So, if somebody can pursue intensive lifestyle modification, probably that's the best. But where it cannot be intense, there is, moderate or minimal lifestyle change. Then with metformin, there is great evidence to prevent the progression to diabetes. In fact, there have been some other smaller studies. Amongst the more recognized studies is the Indian Diabetes Prevention Program, which was published way back in 2006, which was by Dr. Ramchandran and group. And they showed that when in the pre-diabetes segment, they use metformin. In fact, they use smaller dose of metformin with moderate lifestyle changes up to 500 milligram per day. Most patients in that trial were on, in fact, 250 mg of metformin twice a day. And they saw reduction in the progression. Of course, the percentage was lesser. They didn't see the high percentage like in the DPP US. They saw somewhere close to 7 to 10% absolute reduction in progression from pre-diabetes to diabetes. But what they could show was this was achieved by smaller dose of metformin. And in the Indian patients, the lifestyle modification was scoring the same as the low dose metformin. So again, good evidence there for that from the Indian data itself.
Patients think, and even clinicians think, that by giving a metformin product, there may be drug, can be hypoglycemia or any other complication, gastritis and all that. What do you think about that?
So, well, first we need to clearly appreciate the fact that metformin is probably the best insulin sensitizer that we have till date. Metformin essentially works by reducing the hepatic glucose output, which is responsible for the fasting hyperglycemia. So the gluconeogenesis, the glycogenolysis, these two aspects is what really metformin is blocking. And besides that, having its impact on improving the insulin sensitivity at the level of muscle and fat. Metformin does not have an impact on the pancreatic beta cell function. Unlike a sulfonylurea or other so-called oral hypoglycemic drugs, metformin is an anti-diabetic drug. It's an insulin sensitizer, but not a hypoglycemic drug. So metformin does not cause hypoglycemia. Yes, there would be those very, very rare couple of cases in literature documented from across the globe of metformin-induced hypoglycemia, but extremely rare. So very safe drug. Today, this is used for individuals with pre-diabetes. It is used for young women with polycystic ovarian syndrome as one of the better drugs for, again, reversing insulin resistance. Extremely safe. These GI side effects are a limitation. The possibility of gastritis, certain diarrhea, certain irritations can be experienced by some individuals, especially in the first few weeks, and then settles down. A higher dose of metformin may again cause some impact for few individuals where we may have to bring down the dose of metformin, but yet remains amongst the safest medication or drug for patients with diabetes and also with pre-diabetes.
So Dr. Chawla, it is a pleasure talking to you. And as you have established that pre-diabetics is rampant and lifestyle modification is one of the primary goal, and metformin has a definite role in treating pre-diabetic cases, those who are between 5.7 to 6.4 glycosylated hemoglobin. What will be your message to our clinicians, those who are hearing us?
So I will just say that, just remember that there are recommendations by the ADA, EST, and by the RSSDI group as well. Metformin to be considered in the use for patients with pre-diabetes. What you have to remember, what they're saying is for those, especially with a BMI of more than 35, I will bring that cutoff down in the Indian subjects to about 32. Those who have an age of less than 60, there's better evidence. So those with the BMI cutoff, those with I'm sorry, I'm losing those with the BMI cutoff, those with the age cutoff. These are the individuals where metformin should be preferred in patients with pre-diabetes. My message is start screening the population, pick up more individuals with pre-diabetes. You can both use intensive lifestyle with or without metformin as you feel necessary, but that's a window of opportunity to prevent long-term complications and delay the progression from pre-diabetes to diabetes. Let's not ignore pre-diabetes. Let's keep it in our minds when we are treating our patients out there.
Thank you so much. It is a pleasure talking to you. See you in the panel discussion.
Sure. Thank you, sir. See you.
Thank you.
Very nice presentation. Congratulations, Dr. Manoj Chawla and Dr. Alok Kanungo for the interview. And rightly pointed out, as it's not a hypoglycemic drug, it's a anti-hyperglycemic drug. And if we add it, it helps weight reduction. It helps the sensitization of the insulin, and we have something to intervene along with lifestyle modification. Very informative discussion, in fact. And we are moving on to the next presenter, the role of vildagliptin in a long-acting manner in type 2 diabetes. I request Dr. Surendra Swain to introduce our next presenter, Dr. Nilanjan Sengupta.
Dr. Nilanjan Sengupta, his topic is role of vildagliptin 100 milligram SR in type 2 diabetes mellitus, and he is the professor and head Department of Endocrinology, NRS Medical College, Kolkata, Honorary General Secretary, Endocrine Society of Bengal, West Bengal, Associate Editor, Indian Journal of Endocrinology and Metabolism, Secretary, Board of Studies in Endocrinology, West Bengal University of Health Sciences, Coordinator, DDCT course, State Medical Faculty of Bengal, more than 75 publications to his credit in national and international journals. Dr. Nilanjan Sengupta for the role of vildagliptin 100 milligram SR in type 2 diabetes. Dr. Sengupta.
Thank you very much, sir. And I thank NUCD and Dr. Alok Kanungo for inviting me to this excellent webinar. Let me allow me to share my slides first. Are my slides visible?
Yes, Nilanjan.
Yeah. So thanks once again, NUCD and Dr. Alok Kanungo, for making me a part of this very interesting webinar. I was listening to the sessions one after another. Now, my brief is a very topical one, the role of sustained release vildagliptin in type 2 diabetes mellitus management. Now, the DPP-4 inhibitors are in the global as well as in the Indian market since about 10 years or so, and they have, by their own right, established themselves to be an inherent component of type 2 diabetes mellitus management. They have the advantage of having carefree prescription, practically no contraindications or no side effects worth it. And now with the availability of various generic versions of DPP-4 inhibitors, the cost of therapy also has become affordable. Among all the DPP-4 inhibitors that are available in the Indian market, of course, vildagliptin, sitagliptin, linagliptin, and teneligliptin are the more commonly used ones, so to say the more popular ones. Probably only vildagliptin in full therapeutic dosage has to be used daily. The others have had the advantage of a single daily dosing on their own. Now let's go back to the history of vildagliptin a little bit. We know vildagliptin is the original research product of Novartis, and when drug development started, Novartis did develop vildagliptin as a single daily dose formulation, 100 milligram single daily dose. But during the initial clinical trials, they faced a peculiar problem of increased liver enzymes in those studies, which was taken care of once the 100 milligram once daily dosing schedule was changed to 50 milligram BD. But peculiarly enough, Novartis did not come up with any hypothesis why changing from 100 milligram once daily to 50 milligram twice daily did circumvent the problem of elevation of liver enzymes, so much so that from the very beginning it appeared to me and many other physicians that the initial findings were probably a play of chance. Then, of course, vildagliptin enjoyed patent protection in the Indian market for around 10 long years, and then subsequently it lost its exclusivity. And once it lost its exclusivity, actually, the big Indian branded generic market tried to experiment with various, permutations and combinations of vildagliptin, notably trying to bring vildagliptin in a once daily schedule. Because we know that this is a study which showed that nearly about half of the patients of type 2 diabetes fail to achieve the adequate glycemic target of, say, 7% glycated hemoglobin. And one of the most important reasons of failing to maintain and adhere to glycemic targets is adherence to therapy, is compliance to therapy. And when it comes to compliance to therapy, of the many reasons like the cost of therapy, drug availability, complex regimen, the dosage frequency of a drug is very important. Now, we were discussing in one of the previous talks about natiglinide and ripaglinide. In theory, they are excellent secretagogues like the sulfonylureas, but actually they are non-sulfonylurea secretagogues. But they never became as popular as glimepiride, probably because they need to be given before each major meal, maybe twice or thrice a day. Therefore, the compliance to such a therapy on a long-term basis may be under question. Similarly, when it comes to DPP-4 inhibitors, we would always love to have one DPP-4 inhibitor which acts throughout 24 hours, thereby making the dosage schedule very convenient for the patient and keeping very less chance for the patients forgetting to take a pill. So this is actually what I've said has been shown by a particular study. The more the dosage frequency, the more is the chance of missing dosage or more the chance of non-compliance to a prescribed medication. Therefore, as I said, once vildagliptin lost exclusivity in the Indian market, both the innovator Novartis and various other branded generic companies now thought of doing something new so as to make vildagliptin more acceptable, more popular among the patients of India, in that they tried to develop a sustained release preparation of vildagliptin. This is the one which is employed by one technology which is employed by the innovator Novartis, that is dry matrix, gel matrix technology, wherefrom the tablet is released on a sustained manner. I won't go into the details of the pharmaceutical chemistry of the formulation because that is not needed. As clinicians, actually, we need to know what are the advantages of this formulation. So that's it with the market opening up for vildagliptin. We have seen many robust sustained release formulations of vildagliptin, and this has raised certain hopes. The major hope is of once daily convenience, leading to better therapeutic adherence and also cutting down the treatment cost a little bit. Already, with the availability of branded generics, the cost of vildagliptin therapy in the Indian market has come down. But then, with all these hopes, certain concerns still remain. What will be the glycemic efficacy or anti-hyperglycemic efficacy of a once daily vildagliptin vis-a-vis vildagliptin 50 milligram given twice daily? Whether this would really be equivalent to the gold standard 50 milligram vildagliptin twice daily, and whether there would be any adverse effects, notably involving the liver. Actually, this was a study undertaken by Novartis to compare 100 milligram modified release vildagliptin tablet given once daily, comparing with the gold standard 50 milligram BD. And this showed that the mean plasma DPP-4 inhibitor with 50 milligram BD and 100 milligram OD was almost similar. There was no significant difference in DPP-4 inhibition over 24 hours. And this graph shows the mean vildagliptin plasma concentration on day 1 and day 6 with 100 milligram sustained release vis-a-vis 50 milligram conventional given twice daily, and there was not much difference between the two. So by and large, in the laboratory, they have shown a proven bioequivalence between 50 milligram BD and 100 milligram OD. So this also shows that both formulations demonstrated similar reductions in glucose area under curve, with suggesting similar DPP-4 inhibition. So, and I think in our clinical experience also, we are seeing the same. I'm pleased to tell you, we in the Department of Endocrinology, along with the Department of Pharmacology at NRS Medical College, have undertaken a study comparing exactly the same thing, 50 milligram conventional vildagliptin twice daily with 100 milligram sustained release vildagliptin given once daily in addition to metformin. And we will be actually looking at the high anti-hyperglycemic efficacy, at the same time any issue of elevation of liver enzymes. But the preliminary unpublished data, I can tell you, it is actually an open label study. There has been not much difference. Now I end with these two hypothetical prescriptions. So you have two patients, Mr. X and Mr. Y. One, Mr. X, has been prescribed a vildagliptin metformin fixed dose combination twice daily after lunch and dinner, and glycoside 40 milligram twice daily before breakfast and before dinner, along with a statin. So this patient needs to take 5 tablets spaced before and after meals. Mr. Y, on the other hand, has been prescribed 1 milligram of glimepiride, as Dr. Jubin Jacob has waxed eloquent about, before breakfast, a sustained release metformin after dinner, and a sustained release vildagliptin after dinner, along with an atorvastatin. So the patient has to take 4 tablets, 3 tablets at one go after dinner, at night, before retiring to bed, and 1 in the morning. Which one is a more smarter prescription? It's for you to decide which will cause greater therapeutic compliance. Therefore, to conclude, sustained release vildagliptin has been a technological innovation in the drug delivery of vildagliptin, as we have seen with metformin. It has the prospect of a better therapeutic compliance on a long-term basis and is cost-effective too. Preliminary experience shows that this formulation is equally efficacious and safe compared to the gold standard twice daily regimen. However, I think further studies are needed, particularly in the area of CKD, because some companies have launched 50 milligram sustained release vildagliptin, also meant for CKD patients, whether that has any benefit for over 50 milligram vildagliptin unmodified given once daily in chronic kidney disease will have to be seen. So thank you once again for giving me this wonderful opportunity.
Thank you. Thank you, Dr. Sengupta, for your very good presentation of the comparating vildagliptin 100 milligram SR with the gold standard of 50 milligram BID. There is no actual difference in prescription, so that you have proved, and this should be followed up also, that 100 milligram SR can be given instead of twice also. to reduce the appeal burden. Thank you, Dr. Sengupta.
Thank you.
Thank you for discussion.
Yeah, actually, instead of questions at the end of session, we have taken the panel. So I thank all the 4 speakers from metformin to sulfonylurea, DPP4, SGLT2, all are included. All prominent OADs we have taken in this session. So very interesting session is the panel discussion. I invite Professor Lalit Meher, my teacher and part of the NUCD team, to join us as a moderator. And I think Dr. Kota is there in other session. Stuti, you just put the OAD session. Yeah. OAD session slides. Yeah, Professor Meher has joined. Sir, welcome, sir. So Professor Meher and me will be moderating this session, and I see Professor Das is there, and all our panelists. Dr. Jubin.
People don't go away. They are.
Yeah, Dr. Jubin and Dr. Manoj, Dr. Nilanjan, all are here, and we'll be trying to save some time. As all of you know, we are running a little late and very interesting sessions. I know Professor Das will support me, and we have to keep time in the
two questions to each. Two questions to each. There is one question already on the chat box. If Lalit there's a question in chat box.
We'll take that, sir. You have seen our preparation, so I request Dr. Shwai also to join the panel. Sir has very nicely chaired and moderated the whole interesting session.
Great job.
Dr. Shwai has done a great job. And let us answer the questions. I request Dr. Kanungo also to stay back so that very quickly we can answer the questions and give a clear message in the field of OAD. I request Professor Meher to start the panel discussion from Professor Das.
So my hearty thanks to Dr. Kanungo, Professor Das, Professor Jan Panda that you have made me a part of this wonderful webinar. So to initiate the discussion, I'll first ask a question to Professor Das, just to a simple one. How to decide to intensify the oral drugs? That means you go from 1 to 2 drugs, then to 3 drugs, and like that.
I think this is a very, very significant question, because initiation and intensification are the bottom line of any diabetic treatment. Now, intensification is decided when, as an optimal dose for 2/3 weeks, there is no desired result. And if it is not there, we intensify the treatment. We do not wait for the 3-monthly HbA1c ordinarily. We wait for the blood sugar estimations at the end of 2 or 3 weeks. And then if the result is not there, we keep on adding the drug. But adding beyond 3 drugs is of no use.
So far as metformin is concerned, actually, at least we need 4 weeks to get some result. Then we have to again intensify the doses also.
Yeah.
So
it is the. I think, Lalit, there is no hard and fast rule. It's by experience. So you must know that how long this drug take to produce the action. So suppose you have started a patient on the glitazone, you have to wait a little longer, because the pioglitazone, etc., used to take about 4 days to produce their first effect. So depending on the drug, the sulfonylurea drugs, you can change over after 1 week. Metformin takes about 3 weeks max to produce its results, depending on that.
Thank you, sir.
Next question is for Dr. Jubin Jacob, and we want to ask a very important aspect. Which group of drug you prefer as a first and second add-on? We know that we ask for the lifestyle modification, we ask for metformin, but as per the present guideline, as the first add-on, second add-on, which group of drug you will prefer?
You've asked me a very difficult question. I don't think the ADA, EASD, anyone has come to any conclusion about this. So I think we will go with what they say. We will individualize for each patient, which is the second drug. So if it is somebody who is overweight, who has a history of heart disease or who has a family history of heart disease, I would definitely keep SGLT2 as the second drug. If it is an older patient who has a risk of hypoglycemia, I mean, who stays alone at home and the hypoglycemic episode may not be well managed by them, I would definitely consider DPP-4 as my second line drug. So I think the ADA-EASD has not been brave enough to tell us that. And I think we have to individualize this decision. But I think sulfonylureas are not going to go anywhere, though they seem to be lower down on the list. But in terms of glycemic efficacy, in terms of the cost, they are going to stay. And among sulfonylureas, glimepiride is going to definitely stay.
I mean, it is customized. I think Jayant, answer to your question is exactly what Jubin has said. The ADA, EASD, even our RSDA guideline has given broad guidance, but we cannot. They are not pinpointed the drug. If as rightly said by Jubin, CVD risk factors or the atherosclerotic risk factors are dominating, one should go for an SGLT2. If the patient has got more of atherosclerosis, less of risk factors, they also say injectable GLP-1 RA, but oral will be coming now. Now, depending on the other drugs, it depends what you have. And as rightly said, the sulfonylureas are going to stay because of their immense benefit at a very, very low cost. I know that's very important. And between the glimepiride, glyclazide, glimepiride is much cheaper.
So very well shared, sir. Depending on the comorbidities, the cardiorenal issues, the atherosclerotic cardiovascular disease, the obesity, we take up the drug, and as you told, we can have oral GLP-1 also, and the list will be broadened. Then we'll go to the next question, Professor Meher.
Question to Dr. Manoj Chawla. Which is the exact indication of starting a DPP-4? That means you initiate with the DPP-4.
Right. So let me just lighten this discussion. And as Dr. Professor Das was speaking for glyphosins and Dr. Jubin was speaking on SUs, I did, of course, speak on metformin in pre-diabetes. And in Jubin's style of presentation, let me remind them that whoever may be James Bond, metformin is still the money penny, and you both are going to require this money penny for all the action out there.
Absolutely.
Coming back to the question here as to where one would use DPP-4, I think the advantage of DPP-4s largely are the fact that they're extremely safe drugs. So post metformin, or besides metformin, if there have been any group of drugs which are very, very safe to use, non-hypoglycemic, predictable response, least side effects, safety in the elderly population, I think that's what DPP-4s are. So DPP-4 kind of fits into multiple positions. Very often today, if the person does not have any cardiac comorbidity or any kidney comorbidity or compulsions, along with metformin, you may consider the use of a DPP-4 right from the beginning. If the HbA1c is not extremely high and you are afraid of hypoglycemia, I think a DPP-4 with metformin would be started right very in the beginning itself, as we saw the data from the initial Virtue and many other studies. So DPP-4 fits into multiple places. It's a drug which, as I said, to its advantage, you have that caption that use it and prescribe it and forget it. It's a least headache drug.
Yeah. And also addressing Manoj, addressing 5 of the ominous octet, at least 5 aspects of the ominous octet.
Yeah, very rightly told. We take it as a very safe drug. Feel it and forget it, Hero Honda style. And with this, I'll go to Nilanjan with a little difficult task. When do you decide not to go for a DPP-4 inhibitor?
Well, that's really difficult. I decide not to go for a DPP-4 inhibitor when there is a history of pancreatitis of any sort.
Absolutely.
Irrespective of the etiology, even if it be a gallstone pancreatitis, which has adequately been taken care of to avoid any legal problems, I do not initiate on a DPP-4 inhibitor. But I may say in my 10, 12 years of experience with DPP-4 inhibitors, I have found at least 5 or 6 patients who had GI intolerance, peculiarly enough, GI intolerance in the form of nausea or diarrhea which probably could be attributed to DPP-4 inhibitors. In those cases, I had to, stop because of some vague GI intolerance. I remember of 2 patients. They had no problems. She had no problems with AGI, metformin. But the moment I gave first vildagliptin, then changed over to sitagliptin, the patient had that problem. That's one thing. And of course, now in the present scenario, if I get a patient who is having diabetes with a cardiovascular risk or an established cardiovascular disease, or who is obese, probably I would be, with the albuminuria, I would be inclined to maybe prefer an SGLT2 inhibitor. Sometimes maybe I co-prescribe an SGLT2 inhibitor or a DPP-4 inhibitor, or sometimes an SGLT2 inhibitor prescription gets my preference over a DPP-4 in addition to metformin, probably.
Yeah, very nicely told. Dr. Chawla.
And I'm actually going back to Professor Sen Gupta, and I also see that Dr. Manas has also asked that question. And I think Professor Sen Gupta was clear in showing the data for vildagliptin once daily, but with a lot of disclaimers and still wanted information. The concern, Dr. Sen Gupta, that remains for many of us is the history with the hepatic enzymes disruption in the 100 milligram once daily. Now, what has happened is a lot of companies trying to show they've done their pharmacokinetic data, as you showed even from the Novartis study, and in terms of side effects, they're just saying no serious side effects and well tolerated. But there is no documentation again of the hepatic enzymes and what's really happening. The question is, where really is a pressing need for once daily vildagliptin as compared to what we saw with twice daily, very often used with metformin. So again, there's no issue about using it in that 100 milligram, especially when this question has remained. And this is only India specific. It's not that Novartis itself has launched the 100 milligram extended release or modified release anywhere outside that. So that remains, somewhere some skepticism, some doubts that still remains about the lack of data and clarity. Your thoughts there?
Yeah. That's what I said. It's basically, it has been launched in India, even by the innovator and as well as by the branded generic companies, simply on market demand and to do something new. So that's it. But having said that, that's what we are also looking in our own departmental study. Of course, it will take 6 months to 8 months for us to acquire the data and then analyze and publish it. But initial results do show that there is not much difference between liver enzymes. Even in my practice, when I prescribe a single daily dose of 100 milligram vildagliptin, I make it a point to repeat a liver function test at the first visit. And I haven't found it as yet one single instance where I had to stop it because of elevation of liver enzymes. That's it, but it's an innovation. We were managing it when it was not available, but always on a long-term basis. That also, if I take myself as a patient, as I'm a busy doctor and like a busy executive, if we have to take 2 tablets, one in the morning before we are going out to work, rather than you take 1 tablet, and if you there would be less chance of missing it. That's, I think, the only advantage in that case.
Yeah. Very nicely told.
Jayant, one more issue is that, some of the drugs, when combined with vildagliptin, had to be given once a day. And their giving twice a day was an issue. Am I correct?
Yeah, absolutely, sir.
So combination therapy, that's why they brought it in. And US FDA did not approve. They did not go back to US FDA after that. It's a good rebuff to them. They are not planning to go there anymore. So I think that is the issue, that we put a combined drug with XYZ product, which is given once a day. 100 milligram becomes handy. That is the only issue, Manoj, which has driven this drug to be 100 milligram.
Yeah, I think
how the PKPD of this 100 milligram, vildagliptin appeals to you, sir, Professor Das?
I think I cannot say the PKPD studies offhand, Lalit, but I'm telling you that, see, I'll give an example. Say remogliflozin. They want to give it once a day along with metformin and vildagliptin, the triple combination. They're looking for a drug where metformin, we have single daily dose, 850,000. And we also have hemoglobin daily dose. And nowadays, it used to be twice. So they wanted to have a drug which can give them a combination therapy with 100 milligram of vildagliptin, so giving it twice a day. That was the type of logic on which they brought it in. The Novartis remains the innovator for the vildagliptin, the Galvus, and they brought Galvus 100 only for that reason. And also the people who are getting Galvus twice a day, if it is given once a day, they found that it is working. I think, Niranjan, you must have gone through the PKPD studies. Can you tell us?
Yeah. Basically, largely speaking, I didn't make it data heavy. We have the detailed slides also at my disposal, which I think Novartis and other companies can provide if interested. They have largely shown to be equivalent. The PKPD studies have largely shown to be equivalent, and so far as the liver enzymes is concerned, but then always proof of the pudding is in eating, means they may not translate in a real life scenario. So that's what some skepticism is there, but initial results are quite encouraging. That's at least from my own very limited clinical practice, I can say the initial results are not at all that discouraging.
Yeah, very, very well told. And because we are just picked up the molecule, I think in due course we'll see the liver function, we'll see the different aspects of the drug and see whether it will stand the test of time or not. So with this, my question again to Dr. Jubin Jacob. From DPP-4 controversies, we are coming to SGLT2, and this is the $1 million question where all of us are waffling around. In your practice, you prefer a biosimilar or originator dapagliflozin?
Again, the question.
And why?
So I have, absolutely no hassles in prescribing generic prescriptions. So usually I write dapagliflozin. If I know the patient can afford, I definitely write. In our hospital, the practice is if you write the generic prescription, they will give the cheapest molecule that is available in the pharmacy. The only time you are allowed to write a brand name is when it is the innovator molecule. So if I do want to write a brand name, I write for Forxiga. So these are for patients who can afford it. So they ask me the same question. These are Punjabi patients. I tell them, are you going to, you need some alcohol in the evening. Are you going to drink Desi Daru? Are you going to drink Royal Stag? Or are you going to buy a Scotch whiskey? If you're the type who's going to buy a Scotch whiskey, you should insist on the brand because that is what the innovator is. So Punjabis are generally brand conscious. So if I give one brother a generic preparation and the other one, I give them the original, the other one will get upset with me. Why did you give me the cheap one? So you have to, both these options are there and you have to decide which patient will get which option.
Yes, sir. Very, very well taken. And what we see practically, the efficacy, I think Dr. Kanungo is worried about time. I understand. Sir, are you on mute, sir? Dr. Kanungo.
In addition to Jubin's opinion, I was also writing a lot of originator dapagliflozin. When the brand came, I have much more opportunity to write dapagliflozin, and I have given more than 10,000 prescriptions, and result is excellent.
Yeah.
There is nothing
like affordable.
If you select brand of the generic, then you get the right result. So there is no comparison. Both are almost same.
Sir, actually, like the affordable DPP-4, the teneligliptin made crores and crores of prescription worldwide, became the most prescribed DPP-4 in the world. Similarly, in India, anything becomes affordable because our people pay from their pocket, and if the efficacy is more or less same, we can go for a generic or more affordable or a biosimilar brand, which can be given to people at large. So
I have a small story to say. When we did not have Teneli, Professor Lele of Bombay fame once told me, Ashok, can we manufacture DPP-4 inhibitor like the Africans manufactured the anti-HIV drugs? The need was so great. Yes. And DPP-4 inhibitors or SGLT2 drugs have become the standard of therapy, no doubt about it. Now, therefore, once it is available, Jayant, I mean, one is free to prescribe the brand conscious people like Juven's, the Sikh gentlemen can take their brand, and the people who cannot afford can take. But the benefits are the same because they have been compared. There are two arguments with the innovators make. Number one is that this brand has not undergone the clinical trial. This particular generation brand is called generation brand. Generication brand has not gone. And number two, they say that we are longer in the field. But the number of prescriptions, as just now Alok said, 10,000 prescriptions in about 2020 October onwards is a great number. So I think there is nothing much to choose, and especially for the oral biosimilars. So they are biosimilars. They may not be bio better, but they are bioequal.
Thank you, sir.
Actually, we have got 3 glyphosins, say EMPA, DAPA, and CANA. How do we choose which drug to use?
This is a very, very intelligent question. I think Lalit, same question Manoranjan also had asked. Manoranjan here.
Yeah. Actually, these questions we had for the panel, and also our delegates and other faculties have asked.
You see, I'll make a very candid presentation. Number one, that whom do you want to love? Jesus Christ, Lord Vishnu, Lord Krishna. You Lord whomever you want, the benefits are the same. It has been said that the effect of SGLT2 are a class effect. I am talking about the opinion of the experts who Sundar Mudaliar and his colleagues, because this question is asked Lalit again and again and again. There is a class effect, but there is some subtle things I'll point out. Number one, the between DAPA and EMPA, it has been said that DAPA has a little bit more effect on the preventing heart failure. EMPA has some effect for production of longer life. CANA has some effect for the renal friendliness. So there are some subtle differences between the three, but more or less, it has been said today that between DAPA and EMPA, there is nothing much to choose, except DAPA has shown the cardiac heart failure benefit little better than the empagliflozin. But EMPA at the same breath has shown survival benefit. And so there is nothing much to choose between the two. And the canagliflozin has shown something to do with the renal benefit. And maybe that they claimed, Credence claimed they can give it up to 25 eGFR, which has been negated by many people, but let us accept as it is. So the bottom line, that is a class effect of all the benefits which is found in all the things. But the drug which comes fast, Rolls Royce, they stay there for a longer time because people start prescribing it. But the second drug, if it becomes cheaper, becomes better, people also take it up.
Yeah, I think Professor Das very nicely covered this topic, and the next topic was also based on the similar theme, which was we intended to ask Nilanjan, which SGLT2 inhibitor has evidence of cardiorenal protection? Because the CANA, DAPA, EMPA, I think it's already covered well. Anything more you will add, Nilanjan?
Between the three, of course, we have the most first and the best data with empiric outcome trial. That's why empagliflozin probably has taken sort of a lead in cardiovascular protection. We have heart failure data to come with dapagliflozin, and we have the Credence data too. So again, over and above, there's little to choose between them. You can do a hair splitting. For secondary prevention, you would choose empagliflozin. For maybe primary prevention with multiple risk factors or not established heart disease, you would think of canagliflozin or dapagliflozin. For heart failure, we would prefer either DAPA or EMPA, since till now, we do not have a dedicated heart failure outcome trial with canagliflozin and so on and so forth. But as Professor Ashok Kumar Das has rightly pointed out, by and large, all these point to the same direction. Maybe artigliflozin didn't show that much of promise. Even that may be a play of chance, statistical chance, we don't know. But all of them, the data with all the SGLT2 inhibitors point towards the same direction, and conceptually you can choose any one of them as who may be your God to save you, as very nicely elucidated by Professor Ashok Kumar Das.
If I add here, we have another SGLT2 inhibitor, remogliflozin, which has been launched, and we don't have much studies associated with that. So what is your opinion regarding?
Yeah, that's a very, very interesting question. Now that generic dapagliflozin is available, I use very little of remogliflozin. But if you have to use remogliflozin for glycemic control, then you can use it because you have the data, whatever little it is. But if you want to give an SGLT2 inhibitor for pleiotropic cardiorenal benefits, choose one that has a data behind them. That is empagliflozin, canagliflozin, or dapagliflozin, and not probably empagliflozin. And now the cost of therapy, cost differential between dapagliflozin generic and empagliflozin is not much. In fact, dapagliflozin 10 milligram may cost less than 2 tablets of empagliflozin daily. So I think for pleiotropic benefits, where that is kept in mind, I think you choose one which has published data behind them.
Fine. It's a very clear note. Thank you, Nilanjan. Professor Meher.
So metformin is widely accepted as one of the important drugs for preventing diabetes, or that means in pre-diabetes.
So we can
given the benefit of SGLT2 inhibitor, has it got any place in the management of pre-diabetes?
Yeah, Manoj Chawla.
Chawla?
Right. So we don't really have data specifically in pre-diabetes, but as we did see some amount of data for DAPA, both in the DAPA CKD and DAPA HF, where you had patients without diabetes also, where this drug was used. And besides the benefits that we saw there in the reduction of renal endpoints as well as the cardiac endpoints, they did show reduced new occurrence of new onset diabetes with dapagliflozin in that subset of non-diabetic patients. So that's the data that we have for DAPA. Having said that, is this a drug which is approved for patients with pre-diabetes? Not yet. In fact, most drugs for pre-diabetes will come with a caution. As I said in that conversation and interview with Dr. Kanungo, that the ADA EST today talks only about metformin in those 3 scenarios of age less than 60, BMI less than 35. And when I say 35, it's for Caucasians. I would say for Indians, it should be probably 32 or even 30. And previous history of GDM. Those are clear indicators where you should use metformin. They've tried liraglutide. They've tried voglibose in some studies, all of them with limited results. One drug which showed failure was nateglinide. So SGLT2s do make sense in terms of the data they have shown, but are they still recommended for use in pre-diabetes? I think that's a bit too early for us to jump to.
Thanks.
Thank you. Thank you, Manoj. And it's time. We have to brief and very quickly we'll sum up. The next question is for Jubin again. You have been using the different drugs. What is your expert opinion on the oral fixed drug combinations?
I think, we have used fixed drug combination for the last 20 years. For as long as practiced diabetology, we have used fixed drug combinations. And I think the world has also come to realize that fixed drug combinations are very useful in terms of improving compliance, in terms of improving outcomes. So I think now you are seeing, there was a time where triple drug combination was considered to be a no-go area. Somebody combining 3 drugs was thought to be something completely unscientific. But now you can see they are going to use triple drug in the FDA has approved triple drug combination. So I think fixed dose combinations are very much part of practicing diabetes, especially to improve compliance and improve outcomes. but I think they should have some background information about pharmacology, bioavailability, and with that, I think we can safely use these drugs.
Yeah. Very rightly told. And the Indian way of combining drugs has gone to now US FDA, and they have started combining fixed dose combinations. And then because the pill burden comes down, as we discussed about the vildagliptin, the compliance definitely increases. I think the last question will take to Professor Ashok Das. Professor Das is here. I don't think so. We can end with the last question to Dr. Manoj Chawla. Beyond how many oral drugs one should change over to insulin?
So I think that's a difficult one.
Because it's an Indian way, 1 drug, 2 drug, 3 drug, 4 drug, 5 drug, we see it goes on increasing. So what is the science?
Well, there's actually nothing wrong if you're going to be using different drugs with different pathophysiological mechanisms today. But having said that, you need to have your targets in mind. If your patient can achieve that target with 3, 4, or even 5 oral drugs, today we know that a lot of evidence for cardiorenal protection is seen more with some of the oral drugs and not necessarily the injectables. So you should have that in mind. If your patient is not reaching the target is the time that you really start conversing about insulin if you haven't spoken about it earlier, or the injectable therapies. But it's important that we don't keep dragging. I think it's important to keep having the conversation for tighter control. If it can be achieved with oral drugs, including multiple ones, it's fair. If you cannot, it's time to use a therapy which is going to have definite response in terms of glycemic reduction, and that's insulin. So having said that, it's not really right for us to kind of shun away or ostracize the multiple drugs today. If somebody is going to be on a combination of sulfonylurea, metformin, and a combination of DPP-4, SGLT2, and maybe a little alpha glucosidase here and there, and that's going to get our patients to 7% and around and below, I think it's absolutely fine.
Yeah, that's the clear message. Different mechanism, different pathologies, we have to titrate, and as soon as indicated, we should not hesitate to go for insulin as well. I request Professor Meher to conclude before we go to next session, because it's time that we should end this panel discussion here.
It was really a wonderful session, and it was a very treat to listen to all these stalwarts. They have done full justice to their topic. It was really wonderfully discussed about the modern sulfonylureas, the dapagliflozin, the 100 milligram vildagliptin sustained release, and the role of metformin. And again, once again, thanks to all the speakers. So we come to conclude this session now.
Thank you, sir.
Thank you.
Excellent session, and Dr. Shwai has chaired and moderated all the presentations very well. Professor Das, Professor Jubin, Dr. Manoj, and Professor Nilanjan has given best suggestions in the oral segment, and Professor Meher has coordinated the whole session very successfully. We had a very informative OAD session. I'm sure this will be of use for all the listeners who have attended. Thank you, everyone.
Thank you so
much. I hand over the session to Dr. Kanungo.
Thank you, Professor Jayant. Very nice, very well moderated, and it is a very learning process for all clinicians and diabetologists. All the talks were really good. I thank Professor Jubin Jacob, Nilanjan, Manoj, and Professor Ashok Das. Thank you very much for joining this session of NUCD. Now we move on to our next session, where Professor Ashok Das will be joining a little late. And let me introduce Dr. Anuj Baliyar Singh, Professor of Endocrinology, Senior Most Professor at the moment. And Professor Baliyar Singh will take up this session, and subsequently will also moderate this session. Professor Anuj Baliyar Singh, please. Do you have Professor Baliyar Singh with us?
I don't see him.
So we have 3 speakers in this session. There is Dr. Mukules Gupta, who will be talking on Indian reality and insulin initiation. Dr. MP Barua, who will be speaking on time in range, need of the day. And Dr. Bijay Viswanathan will be speaking on a very important topic, that is oral semaglutide peptide in a pill. I will like to introduce Professor Mukules Gupta, Senior Physician and Diabetologist from Lucknow. Present affiliations are Director, Udayan Health Care and Specialty Hospital, Secretary, Lucknow Diabetes Study Society, Secretary, Indian Podiatry Society, UP Chapter, Fellow, the Research Society for Study of Diabetes in India, Fellow in Indian Society of Hypertension, Fellow of American College of Physicians, and 30 years of clinical experience. Lot of research publication and a book on clinical epidemiology and participation in many clinical trials. Dr. Mukules, welcome to this session. And your topic is Indian reality and insulin initiation. Welcome,
Thank
sir.
you so much, sir. Thank you so much, sir. Can I share my screen?
Yes, sir. Please share.
So, thank you so much, everyone. And I am supposed to talk on this subject of Indian reality and insulin initiation. So,
can you make it the full screen?
Yeah. Are the slides moving?
No.
There is a problem. So I'll keep it in this mode. Right.
Yeah,
These are my financial disclosures. So
can you make it full screen? Slideshow.
Suppose I make it full screen, they stop moving. So let me keep it in this mode.
Right.
So realities of diabetes management, we are all aware that with passage of time, the management of diabetes has become patient-centric, whether we talk of oral drugs, whether we talk of the lifestyle changes like diet. The recent guidelines, they focus on personalization of the diet changes, or whether we talk of the initiation of insulin. So whenever we talk of initiating insulin in our patient, then certainly we have to think about the patient who is under consideration, especially when we are talking of our context, that is in India. We know that we consume a lot of carbohydrates. We have got high prandial glucose levels, and we initiate insulin quite late. So all these factors, they have to be kept in mind before we try to initiate insulin. And not only these factors, but the factors which are there in the minds of the patients, which are responsible for inertia, or which are there in the minds of the physician, like the incidence of hypoglycemia, the myths around insulin, the cost factors, the interference with the lifestyle of that individual. All these factors have to be considered before we pick and choose the insulin which has to be given to that individual, because we are now having a lot of choices as far as the insulin is concerned. As far as insulin is concerned, we know that it has got the maximum glycemic efficacy if we are comparing it with any other oral drug or even the injectable GLP-1 RA. It comes handy whenever we talk of situations like catabolic situations, tuberculosis, septicemia, GDM, inpatients, perioperative, various sort of situations wherein insulin comes to our mind, and as per the guidelines also, they have to be initiated as the first choice. So with that background, and with the background of the current guidelines, which have got consensus of initiating insulin with basal. Now, most of the guidelines, rather all of the guidelines, they talk of initiating insulin with basal. But with that thing in background, my contention will be, in Indian scenario, should we have only that choice, or can we think of something beyond that? So now with that intention, if we see the response rate of the patients achieving our target as compared to non-Asians, we know that we achieve targets in lesser proportion as compared to our counterparts. Now what we do, so we start with basal insulin, And then in GIL, to achieve HbA1c target, we increase the dose of basal to optimal or maximal dose. And that is done because we know that once we are lowering the fasting blood sugar, the peaks of the prandial will also go down. But in process of doing that, and in trying to achieve that PPG control also through basal, we'll end up in situations where the person will start having hypoglycemia. So with that thing in background, can OD basal insulin is suitable for Indians who consume a lot of carbohydrates? Or can it really control the prandial glycemia? Or is it suitable for patients wherein we delay a lot in initiating insulin? Or can it offer convenience in terms of number of injections to control the prandial glucose as well? So these are the questions which will be obviously asked once we are talking of the basal initiation. Now, with that thing in mind, there is another option which I'll be discussing, and that is a combination of the aspart, the fast-acting insulin, and a very long-acting basal, that is the degludec. And combining these two in one solution, wherein they maintain their individuality, at the same time, they maintain their PK and PD once they are injected into the subcutaneous tissue. So with that sort of phenomena where these two drugs, they try to have a near physiological control of the blood sugar in our patients once injected, can this be one choice? We talk of the phase 3 clinical programs the IWSP has undergone, various sorts of situations, various sorts of countries, and situations like Ramadan, where it has been tried and it has been found at least non-inferior, and the superiority comes in form of the incidence of hypoglycemia, which obviously sits in the driver's seat. We know that it is responsible for the adverse cardiovascular outcomes. So once we compare this initiation with the basal insulin initiation, then we can see there is superiority of the HbA1c reduction. And this is because of the virtue of the presence of aspart. And that is the thing which is also responsible for bringing in the prandial glucose significantly down as compared to basal insulin. And that is an obvious thing. But the thing is that it comes without paying price for nocturnal or any confirmed hypoglycemia. And this is something which is heartening. If we are trying to compare it with the basal plus sort of situation, then once again we can see that there is similar HbA1c, fasting blood sugar, and PPG reduction. But once again, there is significant decline in the nocturnal hypoglycemia, and there is lesser dose of insulin which is required to achieve the same HbA1c goal. So these are the advantages with the use of co-formulation, which can be used in initiating insulin in our patients. So this was about the randomized controlled trial. Now, once we give that liberty of using this co-formulation in the common world situation, so this ARISE trial basically studied the same pattern. It was non-interventional trial, multi-center, multi-country, and that basically was trying to observe the changes in terms of the fasting decline or the HbA1c control, hypoglycemia, and various other aspects, making the physician free to use as per his decision, knowledge, and requirement of the patient to add on the co-formulation in real-world practice. So this was the baseline characteristic, very close to what we really see when we initiate insulin. HbA1c is somewhere around 9.8. And the duration of diabetes somewhere around 13 years, age 58 years. And all these factors, now the patients, they were shifted onto or added on to co-formulation. So what were the percentages wherein this co-formulation was added? 35% of the patients where it was added was OADs. In 21.8% where only basal was in use. In 8.2% patients along with GLP-1 RA, or shifting from basal bolus in 13%, 21.9% patients where the premixes were shifted onto co-formulation. Why this was done? This was done because the physician basically was wanting to improve the patient's glycemic control. That was the highest requirement. And the other requirements were lower rate of risk of hypoglycemia, flexibility in the dosing regimen, fewer injections than basal bolus, no reconstitution as against premixes, changes in coverage status favoring IDEG-ASP, and there were other simple reasons why the physician chose to shift to this co-formulation. Now the choice was to start with 1 or 2 injection, and we can see that it was nearly 50-50% where the physicians, they shifted to twice daily or once daily co-formulation. So then coming to the results, the changes in the HbA1c, we were expecting that in Indian scenario, because of the factors already mentioned, we should be having a good sort of HbA1c decline. And in India, we can see that is 1.6% decline, much more than other countries, excepting for Saudi Arabia. So we were responding much better to the co-formulation. If we talk of the changes in the HbA1c, wherein the different comparison between different groups where the co-formulation was added, maximum decline was seen when it was added to OADs, and specific to mention is basal bolus. We know that basal bolus is a gold standard, and herein, whenever we have RCTs, then twice daily use of co-formulation against basal bolus is found to be equivalent in terms of HbA1c reduction. But here we can see that once the patients are shifted from basal bolus to the twice daily co-formulation, there is a better decline in HbA1c, proving the real world superiority of the use of co-formulation. And this has happened because of lesser chances of hypoglycemia, more confidence and in the hands of the physician, so that he was able to up-titrate the dosages of co-formulation. So that comes as an advantage in real world sort of situation. If we talk of the fasting plasma glucose decline from baseline in various countries, we see a modest decline of nearly 51.9 mg/% from the baseline in Indian context. Coming to the important aspect, that is the non-severe hypoglycemic events prior to the start of treatment as compared to end of study treatment, we can see that excepting for GLP-1 RA, rest of the arms, they were having less of severe, non-severe hypoglycemic events. And now if we compare it with the severe hypoglycemic events, we can see that there is a significant change prior to the end of the study, and probably these values of these numbers were insignificant. That means shifting on to co-formulation basically led to minimalistic severe hypoglycemic events, making it safe to include in the armamentarium. Another important aspect, which is very important as far as the Indian situation is concerned, because most of us pay from our pocket for our expenses for medical treatment. And here we can see that there is significant reduction in the resource utilization, whether it is the self-reported outpatient visits, whether it is self-reported emergency room visits, or whether it is the work days missed by the patients to take care of their medical conditions. Everything was significantly affected. That saved money and obviously led to convenience. So all these factors, they become important in our day-to-day life. So once we are using this co-formulation, probably that is helping patients in more than one ways. So if suppose I conclude the ARISE study, then it was effective in HbA1c reduction, effective in the fasting blood sugar control, it improved the safety, and of course, there was a better resource utilization. Now let us see what really happens on the ground once we use glargine 100, glargine 300 as against co-formulation. So do we have some data here? So I'll be comparing that in the next slide, but before that, I'll mention that IDEG-ASP becomes prudent choice in Indian reality, especially in patients, those who are on multiple OADs and those who are on only basal, because we consume a lot of carbohydrates, we have higher prandial glucose, and both these have to be simultaneously controlled so as to reach to the goal of HbA1c control, at the same time decreasing the glycemic variability and putting the patient's blood sugar values more in time in range. So these are the advantages which we can think of with the initiation and up titration of IDEG-ASP. Now coming on to the question which I was talking about, that in real world situation, if suppose we observe all these three options, then what do we see? We can see that there was the maximum decline of HbA1c with the use of co-formulation, that is the blue line, coming from 9.61 to 8.09. So that led to this significant, statistically significant decline in HbA1c as compared to U100 and U300 arm. If we talk of the changes in the fasting blood sugar and PP blood sugar, once again, we can see that there is significant better fasting blood sugar reduction with IDEG-ASP as compared to IGLAR U100 and 300. At the same time, there is significant better PPG reduction with IDEG-ASP as compared to IGLAR 100 and the glargine U300. Talking of the insulin dose, which is required to control, significant increase in insulin dose requirement in the IGLAR U100 arm and non-significant increase with IGLAR U300 and IDEG-ASP arms. And if we talk of proportion of patients reporting hypoglycemia, no significant difference in hypoglycemia occurrence between all the three groups. So this is what is the real world situation once we are using IDEG-ASP. So to summarize my talk, in tune with the Indian realities of diabetes management, IDEG-ASP is a prudent choice for insulin initiation as it offers total control and can help achieve glycemic goals with safety, especially if we talk of countries, those who consume a lot of carbohydrates. And therein, the plasma, the postprandial glucose, which is an independent factor, which is an important factor, which leads to less control of HbA1c. If suppose we can address to both the fasting and prandial, we can bring more number of patients onto goal. At the same time, the glycemic variability will go down. At the same time, more number of glucose values will be in range. In randomized clinical control trials, OD IDEG-ASP has been shown to be superior as compared to OD basal insulin, while still offering numerical reduction in the risk of hypoglycemia. And OD IDEG-ASP has also shown similar glycemic control as compared to basal plus regimen at significantly lower dosage and while offering significant lower risk of nocturnal hypoglycemia. So when used as per local clinical practice, results with IDEG-ASP use corroborate with those seen in the RCTs. Thank you so much for your patient hearing.
Thank you, Dr. Muklesh Gupta. It was a very appropriate presentation on a relevant topic like Indian reality and insulin initiation, which will help all our beginners to learn. And with this, we'll move on to the next presentation by Dr. MP Barua. And all of you know Dr. Barua. He is the Director, HOD Endocrinology, Apollo Excel Care Hospital, Guwahati. And there are more than 200 publications, original articles, reviews, editorials, and chapters with more than 5,000 citations, and member Research Guidance Committee of Endocrine Society of India, the former member of the Research Committee, RSSDI, and formerly Editor-in-Chief, the Journal of Medical Nutrition and Nutraceuticals, and Associate Editor of the Indian Journal of Endocrinology and Metabolism, and Associate Editor of Thyroid Research and Practice. So all know Dr. Manas as a very frontline endocrinologist in the country. And to discuss this very important topic of time in range, need of the day, we invite Dr. Manas Barua.
It's a privilege to be presenting this important topic today. And I thank the organizer of NUCD, especially Dr. Alok Kanungo, for giving me this opportunity. Today, my topic is time in range, the need of the day. I'll try to show you how we can position time in range, that is shortly called as TIR, in our diabetes management. And this is my financial disclosure. And this is the first topic in my agenda, concept of time in range and its implication in clinical diabetology. You must have seen this slide probably in recent years, especially after the advent of AZ, MS, and CGM. This has been shown to you. So what it tries to tell you is that even if you have a same HbA1c for two different patients, the story behind the glycemic control status is not the same. For example, the first patient has HbA1c of 8, which is a very high glucose variable. You can see the highs and lows, highs with yellow circles and lows with red circles, which is not at all warranted, not at all desired for your patients. At the same time, look at the patient 2. The patient 2 has got the same HbA1c 8.0%, but a very low glucose variability. The glycemic excretions are just staying near the baseline. I mean, the middle line of HbA1c, which is somewhere around 8. Okay, so mean is 8. So all that glitters is not gold, you can see here. The first patient is much more stable diabetic, but the second patient is much more stable in terms of glycemic control, but the first patient has got a lot of problems. And that's where the importance of looking beyond HbA1c and looking at the new concept of time in range in the management of hyperglycemia comes. And this is a topic which I'm going to discuss today. So how do you define time in range? Time in range refers to the time spent in an individual's target glucose range. Usually, it is defined as 70 to 180 milligram per deciliter. That's a broad range. And if you want to narrow it down to a very tight range, that is 70 to 140 milligram per deciliter. And the percentage of time spent below, that is TBR, and the time spent above, that is TAR, range indicates the hypo and hyperglycemia respectively. So we don't want too much time spent in either TBR or a TAR also. TIR may be used as an appropriate endpoint in clinical research, although that has not happened for large clinical trials, but it's probably going to happen in the near future. And it can serve as a measure of glycemic control in patients with diabetes. And there are emerging evidence which is suggesting that time in range is inversely correlated to the risk of developing microvascular as well as macrovascular complications in patients with diabetes mellitus. And I'm going to discuss this in details in my later slides. What is the evolution of this concept? In 2012, a report was published which provided guidelines and recommendations to clinicians and researchers or patients with diabetes mellitus for using, interpreting, and making decisions based on CGM data. CGM was relatively new in those years. And later on, in 2012, the first recommendation by an expert panel on the standardization of the CGM matrix came. In 2017, various publications on CGM matrix and CGM data evaluation also were published. But finally, in 2019, the first international consensus published by Advanced Technologies and Treatment for Diabetes, ATTD, which happened. And later on, ADA incorporated these guidelines into their guidelines. Now, subsequent years, 2019, 2020, even till now, ADA maintains they write one chapter in their standard practice guidelines for this particular concept, this time in range. So it is gaining popularity. And now let us objectively look at what exactly is time in range. As I have already mentioned, if you put a broad range of 70 to 180, that is your time in range, and the green zone indicates the time, that's where your patients should be all the time throughout the year, but it's not practically possible. So it is recommended for type 1 and type 2 diabetes who are common garden variety of cases without much complication, not special groups. They should maintain at least 70% of their entire days at time within the time in range of 70 to 180. So 16 hours and 48 minutes to be precise. There are some allowances. Patients who would have higher blood glucose, that is more than 180 but less than 250, that is a level 1 hyperglycemia, that can be less than 6 hours, and level 2 hyperglycemia is significant hyperglycemia, more than 250 milligram per deciliter, can only be of less than 1 hour or less than 5% of the entire day. If you look at the hypoglycemia, the lower glucose values, so level 1 hypoglycemia is less than 70 milligram per deciliter, and level 2 or severe hypoglycemia is less than 54 milligram per deciliter. So for less than 70, the allowance is less than 4% of the entire day or less than 1 hour. And for level 2 or severe hypoglycemia, it is only less than 15 minutes. So you don't want your patient to be, in that area, because that can have serious health consequences. Now, if you look at special groups, amongst type 1 and type 2 diabetes, and pregnancy with type 1 diabetes, and gestational diabetes mellitus and type 2 diabetes mellitus pregnancy. So there are some other, allowances, you consider guidelines or cutoffs. For elderly people with high risk of comorbidities, you cannot be that stringent. So more than 50% is the desired level for maintenance within 7 to 180 milligram per deciliters. And the patients can have blood glucose level above 180 but less than 250 or less than 12 hours. So there's some kind of allowance which we also make for HbA1c. Like we have got less stringent HbA1c goals for these group of people. Similarly, less stringent glycemic control goals for these people. But for these same people, when we said that we should not have very low HbA1c, target patients to have very low HbA1c. Similarly, hypoglycemic range is less than 70, the allowance is very, very low, less than 15 minutes. So because their propensity to develop the hypoglycemia and the subsequent complications are much more in this group. So they should have less amount of time spent in low glucose range. In pregnancy, type 1 diabetes is almost similar to what we have discussed for common garden variety of type 1 and type 2 diabetes mellitus. So less than 4% in hypoglycemic range, and less than 25% in hyperglycemic range, that is more than 140. Mostly you desire a patient to have more than 70% of time spent in the range between 63 to 140. That is somewhat different from the normal common garden variety of type 1 and type 2 diabetes. This is because of pregnancy. We know that pregnant patients who have a lower, cutoff for SMBG or for CGMS values. So that's what is being reflected here. For pregnancy with GTM and type 2 diabetes mellitus, again, you expect your patient to have maintained at least 90% of time within this narrow range of 63 to 140, because you want to be very strict in controlling hyperglycemia in these patients, and allowance for more than 140 milligram and less than 63 milligram, that is called hypoglycemia range, and this is hyperglycemic range is very low. It's less than 5% for each of them. So most of time of the day, 90% time, your pregnant lady should maintain this glycemic goal 63 to 1. So these are well-defined criteria now, well accepted and endorsed by AD and different other international agencies. So we should understand and remember these cutoffs, because we are increasingly using CGMS and AGMS in our practice. Now there is this inverse correlationship between HbA1c and time in range. So if you maintain your patients in higher time in range, say suppose 100%, HbA1c is pretty low here, and the patient maintains a very low time in range, HbA1c is expectedly is going to be high. So this inverse relationship is beautifully documented in this table, and you can go through this beautiful paper, and it's a very useful paper where you can get all the information regarding the relationship between time in range and HbA1c. And there is also a very strong relationship between retinopathy, which is a part of a microvascular complication, where you can see that when the patient's time in range is very low, like less than 10, there's 58% increase frequency of retinopathy. And if you take a cutoff of less than 70, it is only about 9%. That's why the cutoff of 70 has been incorporated into the guidelines for time in range. So above 70, there is minimal chance of having retinopathy, so that can be considered negligible. So the problem starts just about 70%. So once you try to maintain the patient's glucose levels at least more than 70% time for the day within the target range. Similarly, microalbumin is also quite strongly correlated with time in range. So if it increases, the chance of microalbumin decreases. There is also another very beautiful paper which shows that each 10% increase in time in range was associated with 6.4% lower risk of abnormal carotid intima media thickness, which is a marker of macrovascular complications. So probably in future we will use time in range as another goal for decreasing macrovascular complications. No doubt. Similarly, you consider if a patient spends more than 70% of time within the range of desired range, there is less chance of major adverse cardiovascular event response is less than 31%, but there is not much difference between 50% and 70% time in range. So probably for macrovascular complication, the cutoff would be in future, time in range of 50%, because they are anyway having a comorbidity, which I have shown in one of the previous slides, that you can be less stringent in patients with various comorbidities, elderly population, and also with, known cardiovascular risk, advanced risk factors. The cutoff may not be 70 or 50%. Now, visualizing the benefits of newer analogs through time in range. New analogs are very important tools in our hand or in our armamentarium of treatment of diabetes, which can maintain a good time in range. I'll show you a few slides from a few studies. And this study actually compared the Glargine 100 and Glargine 300. You can see that Glargine 100 cannot maintain the time in range properly because there is a certain peak after the injection. But Glargine U300 maintains it quite well. You can see here, whether you inject it in the morning or in the evening, it maintains throughout the day. But if you inject U100 in the morning, there will be a peak early part of the day. And if you give the Glargine 100 in the evening, then you have a late evening peak. And because of that, the time in range maintenance is rather poor with conventional Glargine injection. So Glargine U300 is better in that. After that, I would like to discuss the comparison between insulin degludec, which has been found to be the best in amongst all the newer analogs, long-acting analogs, or basal analogs, for maintaining a good time in range. And there is a significant difference between degludec and both U100 and U300 in maintenance of time in range. That's because of the fat profile of insulin degludec. So it is somewhat lesser in degludec versus U300, and it's rather more prominent in case of degludec versus U100. But nevertheless, by far, this is the best insulin for maintaining time in range, and that's because of its long action profile, and they were very flat without a single peak throughout the 24 hours period. That's quite obvious. And there are various studies to show that although these studies didn't exactly look at time in range, if you extrapolate from the data of hypoglycemia, you can see that almost all the studies have shown that there is a significant reduction in hypoglycemia. That's the most important message from this slide. Insulin degludec, by causing lesser hypoglycemia, it obviously would cause give you a better chance of maintaining time in range for the patients where it is used. And this very interesting study, which showed degludec versus Glargine when added to oral antidiabetic drug, and it is crossover design because it was open label, so decrease the selection bias. It was crossed over, and the same patient would receive both the insulins, and there are very interesting data coming out of this. First, if you look at the maintenance of time in range between the broad target of 70 to 180 milligram, you can see that there is 1.4% more chance of maintaining it with degludec, or 20.6 minutes more compared to U100. Now, if you or narrower range of 70 to 140, again, the similar things, even better results came out, because 21.9 minutes on an average, or more spend more in time in range with degludec compared to U100 Glargine, and it was statistically significant. And more patients achieved clinically significant improvement in time in range with degludec. So they compared time in range with OAD, then they compared the time in range when a degludec or U100 Glargine was added, and it was shown that more patient maintaining. It's somewhat like more patient maintaining HbA1c below 7% target. So it can be extrapolated to a better glycemic control without variability. So another important message from that study was that time spent in hypoglycemia, level 2 hypoglycemia less than 54, level 1 hypoglycemia less than 70. For both, degludec was better. It was significantly better in reducing the risk of hypoglycemia for either level 1 hypoglycemia or level 2 hypoglycemia, or even level 1+2 nocturnal hypoglycemia, and that's statistically significant for each of them. So that showed the superiority of degludec versus U100 Glargine in reducing nocturnal hypoglycemia. And this came out from CGMS studies with these two molecules. So in summary, time in range provides a complete visualization of person's glycemic status and aids in better glycemic control. Increasing time in range has shown to reduce micro as well as macrovascular complication in people with diabetes, although we need more robust evidence with larger studies to come out and interpret. But then the signals, early signals, are quite favorable to using time in range as a good, as a tool for setting our goals for proper glycemic control along with HbA1c, and probably that is going to bear fruit in future. If we talk about various insulins, degludec is far better than insulin U100 in improving time in range. Superiority confirmed by various studies, and it also improves the tight TI, that is 70 to 140 milligram range, and also lowers the nocturnal hypoglycemia both at level 1 less than 54 and level 1 less than 70 and level 2 less than 54 milligram per deciliter. And more patients achieved a clinically significant improvement in time in range with degludec that was shown in the study. Thank you very much for your patient hearing. In the later part of discussion, we can take up questions. Thank you very much.
Thank you, Dr. Barua. It was a complete presentation on time in range, and we have questions started coming to us. So we'll move on to the next speaker, and next speaker is none other than Dr. Bijay Vishwanathan, and he'll be speaking on oral semaglutide peptide in a pill. The new concept, all of you know, we have first time GLP-1 coming in the oral preparation, and all of you know Dr. Bijay. He needs no introduction. He is the Urdi Shan of the legend, Professor M. Vishwanathan, the father of modern diabetes care of India, and he is the head and chief diabetologist of MV Hospital for Diabetes and Professor M. Vishwanathan Diabetes Research Center at Arayapuram, Chennai. So with this, I present you Dr. M. Vishwanathan for the topic oral semaglutide peptide in a pill. Bijay.
Thank you, Jayant, my close friend Jayant. And I'd like to thank Dr. Kanungo for this talk. My talk will be for about 10 minutes. And this topic is as new to all of you as to me. I have used it for a clinical trial, and that's it. And in the next 10 minutes, let me talk to you on the role of oral GLP-1 receptor agonist in the management of type 2 diabetes. And we know that when you introduce a new drug...
You can share your slides, Bijay.
I'm sharing it actually. You can't see it?
No. It is not shared.
Stop, sir, please stop. Share and share it again.
Stuti, you have met Bijay, co-host?
Yes, sir, you can share the screen.
Can you see now, Jayant?
Yeah, it's visible. Please make it full screen.
So as I said, this topic is as new to me as it is for most of the people in the audience, except the fact that I have taken part in a clinical trial on semaglutide, oral semaglutide. So I'm going to talk in the next 10 minutes on oral GLP-1 receptor agonists. And whenever a new drug is introduced, we know that we expect the drug to produce good control of diabetes. We don't expect any gain. We don't expect any off-target effects, beyond glycemic control. We don't expect hypoglycemia either. And we expect the A1C to be between 6 and 7%. Now, if you take the GLP-1 receptor, GLP-1 hormone in the human body, it addresses 6 out of 8 octane mechanisms which we talk of. It acts on the liver, heart and blood vessels, brain, the pancreas, and in the kidneys, muscles. It acts in all the intestines, So it acts on all the other, the 6 out of 8 octave mechanisms. So it's a wonderful drug. And as somebody who has been using injectable GLP-1 receptor agonist, I quite welcome oral semaglutide. We know that injection has been a problem to patients because they don't like the word injection. And you can see that in this global internet survey of 1,250 physicians, they said that we don't like injections. The patients said they don't like injections. So if you see you have to use a vial or a pen to inject, even then it's painful. It is involving poking, and tablets are preferred any day by patients. So we have the PIONEER study about which I'm going to talk to you. PIONEER stands for Peptide Innovation in Early Diabetes Treatment. Peptide Innovation in Early Diabetes Treatment. And you can see the rationale for oral delivery of peptides. Usually we think that peptides cannot be delivered orally. So that is where the oral semaglutide is going to score over all the other molecules. So it improves the patient compliance. Patients accept treatment with oral drugs, any oral drugs at any point of time. We were talking about metformin in pre-diabetes, so why not oral semaglutide soon after metformin? And it also addresses all the barriers associated with injections. Now, what happens in the GI tract? I'm going straight away to the slide. When you give oral peptides, if you give insulin or GLP-1 hormone, it gets enzymatically degraded in the stomach because of the low pH and proteolytic enzymes which are present in the stomach. There is limited permeability across the gastrointestinal epithelium, and it has got a very low oral bioavailability. So these are 3 problems which we have with any peptide, for that matter, which has been addressed by oral semaglutide. Now, semaglutide, if you see the difference between semaglutide and liraglutide, which is the injectable form, is in this position number 8, where there is an alanine to alpha amino isobutyric acid. It protects against DPP-4 degradation. And this change is probably the only difference between liraglutide. Now, there is also a spacer attached to lysine 26, this 26 position. And in the arginine position, 34 position, is the amino acid substitution. So there is a C18 fatty acid spacer attached to 26 in the 26 position of the GLP-1. And in the position 8, there is a change, and in 34. So 8, 26, and 34 are 3 numbers which we need to remember. Now, there is another unique feature of this oral semaglutide, which is it has been co-formulated with something called an SNAC. SNAC stands, you can read here, sodium N8 2-dihydroxybenzoyl aminocaprylate. Therefore, semaglutide has been attached to this SNAC, and this SNAC actually promotes the good absorption. It's an absorption enhancer, as you can see in this slide. So some oral semaglutide is combined with SNAC, which is the real magic, how the peptides are working in the stomach. Therefore, we have the first in class, which is the oral GLP-1 receptor agonist, or we have the oral semaglutide, which is a new oral route of administration, the GLP-1 receptor agonist. And the problems I told you, the bioavailability is lower. There's a variability in absorption, which is mitigated by adding this SNAC. Now, the oral semaglutide gets absorbed from the stomach very close to the tablet, where the tablet is present. So it doesn't get absorbed from the entire stomach epithelium, gastric epithelium. It gets absorbed mainly from the SNAC. Makes sure that this oral semaglutide is absorbed locally from where the tablet is present in the gastric epithelium. So the absorption doesn't happen all over the gastric epithelium. It happens exactly at the place where the tablet is present. Now, do you have data to show that the oral semaglutide is effective? Yeah, so that's what I was talking to you about, the pioneer studies, the peptide innovation in early diabetes treatment. Pioneer stands for this abbreviation for this particular term. So you have a lot of trials, phase 2 trial, phase 3A trials, plenty of data, and 9,000 patients enrolled in this oral semaglutide. Before that, the injectable semaglutide was there. Now, the pioneer studies had a lot of subclasses. The Pioneer 1 was comparison of this oral semaglutide with placebo. Pioneer 2 was comparison with SGLT2 inhibitor. Pioneer 3, all of them are published. Pioneer 3 was comparing it with DPP4 inhibitor. Pioneer 4 was comparison with placebo. Pioneer 7 was a flexible dose with DPP4. Pioneer 8, interestingly, was a combination with insulin, add-on to insulin. There were some Indian patients. And Pioneer 5 was in patients with kidney disease. And Pioneer 6 is a CVOT trial. And importantly, patients, a very specific cardiac specific trial is going on, which is called the SOUL, Superiority SVOT trial, which is going on with about 788 Indian patients. Now, if you see the A1C, I'm going to talk to you first about A1C reduction. Across all the pioneer studies, you can see the duration of studies which are mentioned here. And you can see the baseline HbA1c which is mentioned here. Now, across all the pioneer studies, you can see semaglutide, oral semaglutide comes in 3 doses, 3, 7, and 14 milligrams. And the comparison with placebo, comparison with empagliflozin, comparison with sitagliptin, comparison with liraglutide in patients with CKD, in the FLEX Pioneer 7 study. Across all these studies, you can see there was a significant reduction in the A1C, and there was a dose-dependent increase in the reduction of HbA1c. Now, this is the 14 milligram dosage comparison compared to all the other agents which are shown in Pioneer, which I told you before. You can see that if you take a 2% reduction in HbA1c, the best response was got from 14 milligrams of semaglutide. Whereas with EMPA, with sitagliptin, with liraglutide, you almost got 2% reduction. So you can see that the reduction of 2% A1C is excellent with this 14 milligrams oral semaglutide. Now, what about weight? So the two cardinal features of oral semaglutide is HbA1c and the body weight, about which we have the data from Pioneer. So you can see the baseline weight, which is mentioned here, and this is the duration of the studies, duration of each study. You can see that the weight reduction was, again, maximal for people who were on the oral semaglutide compared to empagliflozin, consider difference, compared to sitagliptin, compared to liraglutide, and even patients with CKD. And again, you can see the drop in body weight was linearly increasing as the dosage of oral semaglutide increased from 3 to 7 to 14. If you combine both parameters, that is a HbA1c reduction of more than 1% and a body weight loss of 5%. If you combine both the parameters, once again, you can see that the oral semaglutide 14 milligrams compared to EMPA 25, liraglutide 1.8, and sitagliptin 100 or placebo, you can see that if you combine both these parameters, again, the oral semaglutide stands out as something which is beneficial and something which is superior to empagliflozin, liraglutide, and sitagliptin. Now, these are data from the Pioneer, and Pioneer 6 looked at specifically the CVOT, and about 85% of Pioneer 6 patients had established CV disease, 85%. Only 15% had higher cardiovascular risk. And you can see that the HbA1c and body weight reduced significantly, and there was a primary outcome was also established. So that doesn't mean it's got data compared to SGLT2 on heart failure or CKD. Those studies are just coming in another 1 year. You have the flow study looking at the kidney, and we have the SOUL study, which is looking at the cardiovascular benefits. But in the Pioneer, you can see, and even in the LEADER study where liraglutide was used, it was shown that there was a benefit on the heart. But the benefit on the heart, there's no harm from using the drug on the heart. Whether there's benefit compared to SGLT2, only time will tell. And in the last part of my talk, in the last 2 minutes, I'll tell you how to take the drug. You should get up in the early morning, because you should wake up early morning, and take this tablet first thing you get up in the morning with 120 ml. They have shown that if you take higher amount of water, the tablet erosion is much more. If you take 50 ml, it is less, but people generally take 1 tumbler of water. So you can take about 100 and 120 ml of water, and there is no hot liquids allowed. So as soon as you get up, you have to first take the tablet and then wait for 30 minutes before having your coffee or tea or whatever, or taking any other medication. So if you're taking some thyroid tablet, you have to wait for half an hour after taking oral semaglutide. And you start with 3 milligrams in the first month, and then you move on to 7 milligrams. And this is pretty much what we do with liraglutide. We start with 0.6, build it up to 1.2, and then 1.8. So pretty much the same. And one point I said, it's got a long half-life because of its properties, of which I showed you in the GLP-1 chain, attachment to position number 34. It's got a long half-life of 1 week. So you can, even if you skip the dose one day, it doesn't matter. You can take the next dose the next day. You can't take it after food, after lunch, and so on. You should take it early morning. So if you miss a dose, tell the patient not to worry. They can take it the next day. So this is my second last slide. If there are patients taking 1 or more oral anti-hyperglycemic agents, including metformin, and this is probably the best choice as an appropriate agent as a second-line drug, as an add-on to metformin. Patients for whom weight loss would be beneficial, you should definitely consider the oral semaglutide. Patients who have hypoglycemia with insulin, you saw one of the Pioneer studies, 7, add-on to insulin. The insulin doses came down with 7 milligrams and 14 milligrams, not in 3. So you can see that there's an overall low risk of hypoglycemia. And the hypoglycemia is similar to all the other agents, and including liraglutide. If supposing somebody is already taking an injectable GLP-1 receptor agonist and not reaching glycemic target, you can use it, or the patient wants a tablet, you can change it. High CVD risk, we still need more data, but it is definitely cardiac safe. That's been shown in Pioneer 9 and so on. In CKD, you can use it even up to eGFR of 30. There's no problems, and it's safe in older people. And this is probably my last slide. Patients at high risk of CV risk, high CV risk. Of course, we know that SGLT2 inhibitor is the treatment of choice if somebody has heart failure or CKD. But if there is atherosclerotic cardiovascular disease, ADA says you could choose a GLP-1 receptor agonist. Especially if the eGFR is not okay, you can definitely choose the liraglutide or oral semaglutide. Patients with low CV risk, of course, there's no question, you can use it with all the benefits which I have told you just now. So in summary, I think the oral GLP-1 receptor agonist is a real invention, as the peptide invention in early diabetes treatment Pioneer studies showed. It reduces A1C, body weight, pill burden. It can reduce the pill burden. Oral semaglutide is a scientific breakthrough because we never knew that peptides can be given orally until this molecule has come into the market. The global Pioneer trials have clearly shown that oral semaglutide is effective in A1C reduction and weight reduction up to 5 kgs. And when compared to SGLT2 or DPP4, of course, if you remove heart failure and CKD, oral semaglutide might be quite effective compared to these agents and also as an add-on to insulin therapy. And in patients with baseline A1C of more than 9, you can get a good HbA1c reduction of 2%. And cardiovascular safety, the trials like the SOUL trial is yet to come, but it's got cardiac safety. Cardiac benefit, we have to wait for the results. So I'd like to thank you for your attention. Once again, thank Dr. Kanungo and also my good friend Jayant Pandey for the introduction. Thank you.
Thank you, Vijay. It was a very simple, crisp, and direct presentation on a very innovative molecule, the oral semaglutide, and you have given not only the mechanism and the preparation and the properties, but you have given the practical aspects of initiation, escalation, and maintaining the dose. With this, we'll go to the panel discussion straight. I invite Professor Ashok Das sir, and also Dr. Mukulesh Gupta, Dr. MP Barua, Dr. Bijay Vishwanathan, and Dr. Abhay Shahu. And first, we'll take up the questions with Dr. Bijay Vishwanathan because he has a quick session and he'll be leaving soon. So, to start with, we'll take questions related to semaglutide. And the first one that we have received is why oral sema is held as a game changer and a life changer.
As I told you, Jayant, I think so far we never knew that peptides can be given orally. And I have used liraglutide for the last decade or so. And I've been very impressed with GLP-1 receptor injectable liraglutide and dulaglutide. But when I say a tablet, patients are very happy because patients are not happy injecting themselves with insulin and with another injection of liraglutide. Therefore, it's a game changer because it's a tablet.
Yeah, very true. That's why we tell it, and it's used.
And also, Jayant is also a lifesaver because, as Vijay beautifully described, it has a proletarian effect on the cardio, renal, obesity, NASH, neurological benefit still to be shown. So, I mean, it's a proletarian effect, pleiotropic effect beyond description, which comes through oral. And the quantum of change also, Vijay, if I may say, is quite heavy. No, the amount of weight loss. You see, amount of weight loss. The American press said is a sunshine drug because the weight loss was almost about some places 25 kg in experimental. So it's a both, as Vijay said, game changer, life changer because it affects all the aspects of diabetic comorbidity. Am I correct, Vijay?
Yeah, absolutely, sir.
Very true, sir. Very true.
Very true, sir.
But the question comes to mind: can we apply this protein in a pill concept for developing oral insulin?
Yeah, I think so. That's up to Novo Nordisk to do it. So we are only clinicians. So I think if this can work, if it can work for semaglutide, why not add SNAC to?
I think very beautiful.
I'll add something. Actually, oral insulin is already there. Oralin is there. Actually, they have tried, but still they were not successful to do that. But still, I don't know because there was in between. There is Apriza was there, inhalation insulin. Then Oralin came, this oral insulin, and but still they have not yet succeeded to reach the target.
But before that, the GIP also has taken the same route, and today we have a GIP analog modulation, Jayant, and of course Vijay must have spoken about it. I missed one or two slides. The tirzepatide. It is even more effective than semaglutide. Am I correct, Abhay? In the India trial. So I think, Jayant, you are correct. It will be applied more and more to many of the proteins, starting with tirzepatide and other things which are undergoing trial. And as Vijay put it, it will be the pharma which will be putting it in the laboratory and giving it to us. But the future is very bright.
Yeah, Dr. Barua I want to take an opinion of Dr. Barua. Yeah.
Actually,
Manas is here. Manas.
Novo
could have made oral insulin a decade or 2 decades back. But then the bioavailability is not that good, and the cost is going to be very high because we have to supply huge quantity of the crystals orally, which is, by injectable, you need to only, inject a few units. So I think that's one reason. And you cannot have a very long-acting insulin orally, but probably you can only supplement a short-acting part of the annual part as of now.
Yeah. So let us move to next question. We have a question from Dr. M.R. Behera. The weight reducing effect of the semaglutide, can it be independent of glycemic control? Is it recommended for non-diabetic weight reduction?
Yeah. So, Jayant, off the record, people have been taking in India liraglutide, though it's not approved by the CGI. They have been taking in people without even pre-diabetes. This is off the record, so it should not be recorded. So people are using liraglutide, and I'm sure oral semaglutide also will be used by the same people to reduce obesity. It's approved in the United States, but not in India. So
yeah. So we have a question: the glycemic and the extra glycemic effects of semaglutide. Can you summarize again for our listeners?
Yeah, because as I said, it works on 6 out of 8 octet mechanisms. So I showed you a picture of the liver, muscle, kidney, brain. So it works on multiple sites. So it's going to be a wonderful drug because we know GLP-1 receptor injections work very well. And now we have a tablet form, which is as good as liraglutide.
Perfect. The last question will be, what are the ongoing trials in oral semaglutide after the launching is ready?
So as I said, there is something called SOUL study going on, looking at cardiovascular benefit. So only then you can say this is as good as SGLT2 inhibitor. Then I think there's a study called FLOW study, which is happening in patients with CKD. And then there is some focus study where retinopathy has been a little concern in one of the SUSTAIN studies. SUSTAIN was the injectable semaglutide. And SUSTAIN 6 showed some progression of the retinopathy, especially proliferative retinopathy and maculopathy. Therefore, there is this study called focus study, which is looking at proliferative retinopathy and non-proliferative retinopathy. So all these are studies which are going to come in the next year. So till that time, don't use it in people who have retinopathy.
Yeah, very right. So thank you, Bija. You have done a wonderful job. The message was very clear. And I request Professor Das to just conclude this incretin part, because I think the session is the diving deep into insulin and incretin. So I
think, Jayant, as you rightly said, and Bijay very beautifully put, that is Bijay's, I think let us be a little relaxed. Bijay's trait, he speaks few words, but conveys everything. And very cool. He is Mr. Cool. Beautifully he has put everything together. I particularly believe that oral semaglutide will stand out as the molecule of the decade for 2 reasons. The price is one thing which will not discuss it here, because that will come down as the use increases and the more drugs are prescribed, or we have other people to support the drug, like the agencies, like the reimbursing agencies, all that. That is a different story. But if in a single pill, Jayant, just see, oral pill, you can achieve a great deal of weight reduction, cardiovascular, renal benefit, and the FLOW and SOUL, both so prospective data, as Bijay rightly put it, a lot of kidney benefit. It is also a drug to be used for the people who have dementia complex, whether Alzheimer's, non-Alzheimer dementia complex. It has been used it's a pleiotropic effect. So I think this incretin invention is really innovation. So only when invention is with value, we call it we call it innovation. So it's an invention with a great value. But Bijay, thank you very much. Thank you very, very much.
Thank you for joining us. Thank you for making it so simple. Thank you.
Thank you, Dr. Kanungo.
Thank you.
So we'll go to the insulin part. And we are getting very simple questions for the beginners, and I think we'll start from Dr. Manas. And the first question is the indications of short-term insulin therapy. We have to redefine rather for the benefit of our listeners.
Yeah.
And Dr. Abhay Sahu is with us.
Firstly, refer to one of the articles published not recently, in 2009. Professor Ashok Das sir is there. It was in JAPI, although it was published in favor of premix insulin, the first premix guideline in the world. But it actually tells you what are the indications for your usual common practice, diabetology practice. You can say that for short-term insulin, if you ask me where do I use it, say for example, patient is going for surgery, patient is going for pregnancy. Pregnancy you can compare to the whole lifetime of the patient is about 9 months, so you can short to medium term. And also patient comes to you with high HbA1c at the very beginning, initial part of diabetes with glucotoxicity. HbA1c is pretty high, patient is drug high. There also we use insulin. Okay. Mostly we use basal insulin because people do not want to go for premix insulin, which of course at times require 2 doses. But with the advent of newer co-formulation, which was discussed today already in this session, it's probably that is one of the options for using as a short-term for averting glucotoxicity. And then, of course, if the patient choice is there, at any point of time, you can use it. And for patients having diabetes for a pretty long period, of course, that cannot be short-term. Then in that case, you have to be prepared for a maybe lifelong therapy of insulin. But the other instances which I have already mentioned, there can be good cases of short-term initiation.
Very, very nice, very appropriately described, and I think this part of the discussion is very clear for the listeners.
Can I say
Professor Das,
Manas is voracious reader. Manas referred to my paper. I think I'll send you the copy of the continuation of the paper, Manas, where we also discussed. Manas, are you here? Manas? Yeah. Manas, we just also discussed one concept which Professor B.K. Sahai, my senior from Hyderabad, Rakesh's father, Professor Sheshaya, and many others had given. Also from Japan, that concept had come, that if you give a short-term insulin in type 2 diabetic, you know it better than me, young type 2 diabetic who had got very short history, if you give short-term insulin for between 2 and 4 weeks, we can have a prolonged honeymoon. You are young people, all of you must have been honeymoon for about 25 years. But here honeymoon can extend not only 2 to 3 to 4 months, it can be up to 2 years. So in the early on, if you give short-term insulin therapy for 2 to 4 weeks, Manas, I'm repeating 2 to 4 weeks, I reviewed the literature in that paper, you can find a free period from diabetes for about a couple of years. So that is also one use, which I'll send that paper to you.
Yeah, there is an extension of metabolic memory, which
exactly.
Your last decade.
Yeah. The simple works are at times very informative and valuable, and that is very useful, especially for the beginners.
So now, Jayant, I'm giving to any young onset type 2 diabetes, even for the ones who were cured of the COVID, were getting insulin at the time of COVID and steroids. I'm continuing insulin for remaining part of the diabetes therapy for a long time. I'll pass on the data to you because it's worthwhile seeing whether this short-term diabetes gets totally cured by insulin.
Yeah, very nice, sir. This is what we need to pass on to the younger generation. And another simple question has come. I want to start. When should we start insulin type 2 diabetes? Because our undergraduate curriculum and the postgraduate curriculum doesn't have clarity in approaching a case of type 2 diabetes. So if I'm a fresh medical graduate, you have to guide me regarding initiation of insulin therapy in type 2 diabetes.
So, correct. So I think if you go by the conventional approach, most common scenario is OAD failure, which is defined as continuous 6 months use of adequate dose of sulfonylurea drugs, and you're not getting good results. And you can extend that to other OADs which are available in the armamentarium. Then, of course, it is good time to go for insulin. And of course, if you go by the HbA1c criteria, it is well accepted that more than 9.5 or 10 HbA1c, it is better to start insulin and continue it till the blood glucose is stabilized or sufficiently low, like in the range of 7.5 or 8, where you can try oral tablets. And third condition is any acute metabolic complication, you straight away start with insulin, like hypersmolar coma or diabetic ketoacidosis. And you have to be very careful while withdrawing insulin in such patients. And patients with type 2 diabetes who have recently lost a lot of weight, who are metabolically compromised, or they're not very stable, and they're in a catabolic state. Of course, even without looking at their blood glucose, even without looking at their HbA1c, you should start insulin. Allow the patient to gain some weight and become metabolically stable, and then only think about withdrawing insulin. And of course, in any scenario where patient is having moderate to severe infection of any kind, it is always safer to start insulin, and then of course think about converting to OAD if the patient is suitable. And finally, patients sometimes may present to it, advanced complications. In India, you may get serum creatinine of 2 or eGFR of 35 at the presentation, and in that patient, probably it is always better to start, in my opinion, start with insulin rather than other drugs, because it's already too late in terms of the long-term complication development in diabetes mellitus. So I think these are the few scenarios I'm giving, but it's always patient-specific, and you have to take an individualized case-based approach. And
you have completed the list. Manas, you have completed the list and nicely have simplified the indications in insulin in type 2 diabetes. We'll go to Dr. Muklesh Gupta. Sir, I'll ask you challenges in India for insulin initiation and intensification. We have seen our patient, when we talk of insulin, becomes very reluctant. It takes long to convince. The inertia is very high at all levels. At the patient's level, at the physician's level, at the caregiver level. So what are the different challenges we face and you come across in your daily practice?
Exactly. It's a very pertinent and a very practical question, because we want to initiate injectable therapy. Specifically, we talk of insulin in many of the patients, but we face with a lot of challenges. And these challenges, they are at the level of the patient and they are at the level of the physician both. At the level of the physician, if I talk of, then the most relevant is the time. Because the moment you need to talk about injectable therapy or insulin, you need time to convince, to talk to the patient, to understand his views, and to give knowledge about the advantages of the insulin, whatsoever they are, and to educate the patient on this line that now this is something which is important for that individual. You need at least 20 to 25 minutes before all these things, they can be transmitted, or you can say explained to the patient. Then if you talk of the patient-related issues, inertia issues, then it is the injection per se. Number one, myths around insulin, dependence, maybe the end of the world, maybe the thinking of the patient that this is probably the last thing which can happen to him. Then interference in his day-to-day life, maybe the challenge of injecting in public. There are many other factors. Then the cost. All these things, they will come to the mind of the patient. There are certain common factors like the risk of hypoglycemia, the risk of weight gain. These are common to both the aspects, whether it's the physician or the patient as such. So these are the limiting factors. But to me, probably, all these can be broken nicely. They can be really convert a bad sort of notion in the patient about insulin to a good one, if suppose we can spend that 20 to 25 minutes. And this is what is the average time which I think is really required for converting or starting insulin in any person for the first time in his life.
Very, very rightly told, Dr. Muklesh. It's first we have to break the inertia in the physician's mind and have to spend little time to overcome and tell him in the long term what are the benefits we are going to get. So you have discussed all the issues related to initiation and intensification, also told the solutions. Now we have received few blanket questions. I'll start from Dr. Abhay Shah. Professor Sahu, are you here?
Yes.
Yeah. So the question is, which insulin and which device? When you are asking, suppose we are going for insulin in a type 2 diabetes patient, which insulin and which device? So what is your answer to this?
So first thing is, when we are discussing about which insulin, probably for me, all insulin are same. Whether you go the previous insulin, normal human insulin, then subsequently the second generation, like you can tell this Novo mix or Humalog mix, then the newest one you can think about Rajodec. For me, blood glucose control point of view, all are same. But vis-a-vis to tell that, when I am telling about Novomix or Rajodec or Humalog mix, these are the certain insulins. If you compare with our first generation human insulins, probably the risk of hypoglycemia is significantly less with these insulins. And of course, again, if you think about these newer insulins, of course, the amount of weight gain is also less in comparison to the old generation insulins. So if you think about the advantage, probably the number of hypoglycemia will be less with particularly specifically Novomix or Humalog in comparison to particularly this normal human actrapid or human insulin or whatever the insulin you will tell. Again, if you compare this Novomix and Humalog in comparison to specifically this Rajodec group or the newer group of medicines, then again, there is further reduction in hypoglycemia with use of this Rajodec group of insulins. That means, as with successive generations, as the insulin, everything is getting changed, the dynamics is getting changed, the PKPD data is getting changed. So that leads to actually significantly less hypoglycemia. Again, the risk of weight gain will be significantly less. So this is the way how we can tell what sort of insulin one can take. And again, when you are planning for an insulin, then you have to discuss with the patient what is the financial status, what sort of patient can continue, and whether patient can go for this newer generation insulin or not, because financial part is one of the important factors before deciding what sort of insulin you are planning. So from the efficacy point of view, all are same. But of course, these newer insulins have the advantage of less number of hypoglycemia, overall hypoglycemia, nocturnal hypoglycemia, and also there is less weight gain in comparison to the older generation insulins. Fasting. Then coming when you are thinking about device, again, with particularly with successive generations, the device has also significantly improved. You see, when we were using the previous devices, whether it is Novopen 4 or particularly this Humapen, in comparison to this, when you will see this now, whatever we are getting the flex touch, you just see what are the force what we are applying before giving the insulin. So probably in this flex touch or this whatever the newer devices, probably the force is significantly less, and also this smoothness or smooth going up insulin is almost a painless thing for the patient. Also, patient did not get any sort of convenience point of view that is good for the patient. So if you think about the pen point of view, of course, this newer generation pen is far superior than this older generation pen. But again, before deciding what sort of pen someone can give, we have to think about what sort of insulin we are prescribing. Because if you are planning for a human actrapid or mixed, probably this older generation pen is suffice. But again, this newer generation pen, which is already a pre-filled pen, or you are going for cartridge, probably this newer generation pen will be far better for those group of patients.
Very right, Professor Sahu. You have touched upon all the generations of insulin and device, and then it's all according to the affordability and the availability at the place we can choose and advise our patients. So the time is almost over. Quickly, I'll ask one question is to Dr. Muklesh and Dr. Manas before we end the session. We have a question: how do you manage the insulin-related weight gain and also hypoglycemia? Dr. Muklesh. Please unmute.
As Dr. Sahu has already mentioned, that with the advancing generations of insulins, whether we talk of the basal insulins, especially the long-acting or ultra-long-acting insulins, they have become peakless and flat. So they are the best to be used once hypoglycemia is there looming on the mind of the physician. So these ultra long acting insulins, whether it is U300 or Degludec, both of them, they are equivalent in terms of the profiles. They are flat, peakless, and very less amount of hypoglycemia. In fact, in practical situations, probably we don't get much of hypoglycemia, significant ones at least. Then second is, because of this factor, it becomes easy for the patient and the physician both to intensify the insulin. So it becomes safe. We can ask the person, so there can be simple algorithms, 2 units every 2 to 3 days. And it has worked very well during this COVID times. So as far as the basal is concerned, giving that power or empowering that patient to intensify, gradually increase the dose of insulin 2 units every 2 to 3 days till the fasting is nicely controlled. And then you can come back and talk to us for further addition or control of the prandial insulin. This is regarding the hypoglycemia part. If I talk of the shorter acting insulins, now we have got FIASPs, very fast acting insulins. They are near physiological and therefore they come in. That means the action onset is very quick and the action goes off with the meals. And this becomes near physiological. So you don't have that shoulder. And therefore, that hypoglycemia, which happens postprandially, is not there with the faster acting insulins, which are now available with us. If we talk of weight gain, once again, the newer insulins, they lead to less of weight gain. And because that weight gain is basically because of less of hypoglycemia, so the person is not consuming to cover for that. And therefore, there is minimalistic weight gain. In fact, if you want weight gain, then insulin is something which has to be used, as Dr. Barua has already mentioned, that wherever the patient is in catabolic state, like tuberculosis, then certainly this is something which has to be initiated right in the beginning so as to make the person more metabolically safe. So these are my views on the hypoglycemia and the weight gain.
Very, very
well said. I just want to say a few words to practical points. Insulin therapy comes with a lot of responsibilities, both on the part of the physician and the patient. Monitoring is the key, for which, Dr. Mukulis has already mentioned, like you have to titrate. For titration, you need to counsel the patient monitoring. And as a physician, you need to understand that what kind of drugs, other drugs you're using. Like, for example, if you're using pioglitazone, probably that's not a good choice if the patient is gaining weight. And probably you can use SGLT2 inhibitors, which can neutralize the weight gain a little bit. And you should not use excess dose of insulin. And for the patient's part, it should be counseled that insulin is not a certificate for go out and eat everything. It's just a therapy. You cannot just think that from now on I can eat everything because my problems have been taken care of by insulin. So dietary discipline is still more important, even if the patient is given insulin. So those kind of things are to be remembered and told to the patients, and the patients, physicians also should remember all those things.
Yeah. Very rightly covered. That was the last question. In fact, I was about to ask you the myths existing in our country regarding insulin and how do we dispel it. So I think that's also mostly covered. I request Professor Das to give a concluding remark.
Wonderfully, you conducted a big hand for you. Thank you very, very much. I will just like to mention one thing. That there is lot of wrong, what should I say? Long advertisement for insulin. There is a lady, foreign lady, I will not name her, who constantly writes insulin not necessary. There are people who keep on insulin responsible for kidney failure, heart failure, whatever it is. So therefore, we on RSSDI tried a particular program to put insulin in its proper place and not allow any myth to get into the insulin therapy. So therefore, I will just end this session by saying two things. There has been rapid innovations in the field of insulin. So newer insulins, better delivery devices, which all of you discussed. But there is a gap between the innovation and the adoption. What is necessary today is to bridge the gap between the innovative insulin that is available today and the people, and appropriate. I don't say put everybody on insulin. In the appropriate case, it must be started, because the insulin penetration in our country is less than 20%, 19%. Along with OHA, it's about 25, 26%. Latest DCGI data. Whereas the insulin required in at least 40 to 50% cases. Therefore, we have to march for that, work for that. And it is usually a challenge that insulin never fails. Insulin gives you a great sense of well-being. And insulin probably postpones complications. So a lot of benefits, and we have to bridge the gap. Thank you very much. And all the panelists have done wonderfully well. And Jan, thank you very much. Abhay, thank you. Nikhilesh, thank you. Manas, as usual, and wonderfully you spoke. Manas is an old friend of mine, not old friend, young friend, but for a long time. And thank you, Jan, and thank you very much. And
I thank all panelists, Dr. Bijay Vishwanathan, Dr. Manas Barua, Dr. Mukulesh Gupta, and our mentor, Professor Ashok Das, who has done a wonderful job to this session, diving deep into the insulins, and we have covered the incretins as well. And I thank all the listeners who have asked beautiful questions and make this session interactive. So thank you. Thank you, everyone. With this, we'll move on to the last session, and that is session 5, last session of the day, not conference, because we have conference tomorrow also, and it starts at 11 a.m. instead. Today we started at 1 a.m. So the last session is very interesting, and we have very renowned figures in the field who are working, and it's a very active and very current issue. It's COVID-19 and diabetes. And I invite Dr. Sunil Kota, my co-chairman, to do a introduction of Professor Sujoy Ghosh, who is a national, international name, and everybody knows him. But the issue is very burdening, the COVID-19 and diabetes. You know, the first wave, second wave has given us a lot of experience, and we are going through the third wave, restricting our life, and again we are on virtual mode. So here we have faculties like Dr. Sudhir Bhandari, Dr. Satya Das, and all interesting issues from new onset to the in-hospital management to the mucormycosis are covered, and we will take all the questions of yours in the session. So I request Dr. Sunil to introduce Sujoy and start the first presentation.
Thank you so much, sir. Thanks to the organizers for having me here. And as already Jain sir has stated, it indeed is a wonderful session.
Ladies and gentlemen, first of all, I would like to thank Dr. Kanungo for having given me this opportunity to interact with all of you. I have been asked to talk on new onset diabetes. Now, we are all aware of what the definition of diabetes per se is as far as the American Diabetes Association is concerned, whether we are talking about a fasting plasma glucose more than 125, a postprandial more than 200, an A1C of more than 6.5, or classical symptoms with A1C or with random glucose more than 200. Now, that's something which we are all aware of. But when we are talking about new onset diabetes, we are talking about people who have recently developed diabetes. Now, when we are talking about recent diabetes or new onset diabetes, what are we essentially talking about? We are essentially talking about, number one, people who have had undiagnosed diabetes, which has now got diagnosed because of being tested incidentally, or people who have truly developed diabetes at this point of time of testing. Now, it's very important that we recognize new onset diabetes. Unlike macrovascular complications, which start way before the onset of hyperglycemia and diabetes, microvascular complications usually will start only after development of hypoglycemia, though it might still be there in pre-diabetes, but it's more common with uncontrolled hyperglycemia. Organ dysfunction may not have started, so it gives us a window of opportunity for strict glycemic control. And of course, newly diagnosed diabetes, we've got several management options. And if we are able to properly early on, we are able to delay failure of beta cell or the destruction of beta cell. So in a new onset diabetes, the kind of diabetes that can occur is all of that in that list that I've enlisted here. I'll just quickly go through all of them. So first, if you're talking about new onset type 1 diabetes, most people with type 1 diabetes who are newly diagnosed, they will not have too much of a preceding undiagnosed period. And if you look at the stages of type 1 diabetes, you have stage 1, stage 2, and stage 3. And we are talking about when we are able to diagnose, say, stage 2 and beyond. In terms of presentation, The individual might present with diabetic ketoacidosis as the first symptoms, might present with osmotic symptoms, weight loss, and in someone who was previously continent, again, history of incontinence and nocturia. In terms of management in early cases, intensive glycemic control would be the key. Insulin would be the only drug to be used, maybe 3 to 4 times daily. And we would try to achieve good glycemic control, treat DKA if that has happened, and restore normal body function. Intensive glycemic control has been shown to have benefit. Type 2 diabetes, new onset, can happen. That's probably the commonest cause of new onset diabetes, where there's a problem of insulin resistance and an apparent insulin deficiency. There's impaired incretin secretion and eventually beta cell failure. So the pathophysiology of type 2 diabetes, I'm not going to talk about. Most of these patients, however, will remain asymptomatic or would be screened while screening for some other cause, and they remain undetected for a long time. They might present with a lot of problems, including infections, which are not getting well soon, ulcers, wounds not healing properly. Of course, might present with complications of diabetes, including both macrovascular and microvascular complications of diabetes. Management, I'm not going to talk about because that's not predominantly part of this talk today. Just 1 or 2 lines about the individual bits, lifestyle measures. We are all now talking about reversal of diabetes or regression of diabetes or temporary remission of diabetes is probably a better word. Their lifestyle intervention has an important role, and also management of other comorbidities like hypertension, dyslipidemia. Smoking and tobacco quitting is very important. In terms of diet, avoidance of energy-dense diet, restriction of fat and oil, carb counting for type 1 children, and more of green leafy vegetables and other vegetables, dietary fat and sodium restriction, avoidance of hypoglycemia by adjusting the diet. And sometimes people have tried keto diets and very low calorie diet, but please don't do that unless it is supervised. Exercise, aerobic exercise, very important. Children and adolescents, they need exercise, adults too, particularly not just because of, the direct calorie loss benefit, but also because the body tones are better and better cardiovascular fitness. In terms of pharmacotherapy of newly diagnosed diabetes, we are aware what the ADA-ESD guideline talks about, that the first line, apart from lifestyle modification, would generally include metformin. And if individual has high risk for ASCVD, heart failure or CKD, then the SGLT2s and GLP-1s come in. Sometimes we would want to go for dual therapy as well, particularly if HbA1c is high to start with. That is what the AACE guideline tells us. In terms of pharmacotherapy, of course, decisions must be individualized. Like I said, metformin would still be probably number 1 drug in most of the circumstances. Incretin-based therapies and SGLT2 inhibitors would be again a good group of drugs. Sequentially, you can treat or go for combination therapy, something which is being, backed by the verified trial. Insulin may be required in extreme cases, particularly those with osmotic symptoms or presenting with complications. Early good glycemic control might improve rate of decline of beta cell. And this is when you're talking about insulin therapy and injectable therapy. I'm not going into details of that. GLP-1s is now thought to be the first injectable that we should be using. And in other cases, you are supposed to be using insulin. Now, again, a new onset, another form of diabetes could be latent autoimmune diabetes of adult, where the age of presentation is more than 30. There is presence of antibody and initially response to oral agents, but then there is a rapid decline of the beta cell function and is associated with variable degree of insulinopenia and plus minus insulin resistance. Pancreatic or type 3C diabetes, which we see in India quite commonly, at least in this part of the country, that is fibrocalculous pancreatic diabetes is a common cause of them. And there are other causes in that group, but the commonest that we see is either post-pancreatitis diabetes, pancreatic surgery diabetes, or FCPD. Particularly if you're talking about FCPD, it is associated with exocrine pancreatic insufficiency in most of our patients. there's usually loss of glucagon, there's malabsorption, and there might be variable abdominal symptoms. And usually they are treatable with oral agents to start with. We usually do not use incretin-based therapies in such individuals, and ultimately they will need insulin therapy. The next group of disorders presenting as new onset diabetes could be maturity onset diabetes of young, which is MODY or monogenic diabetes, which itself is a topic of its own. Flatbush diabetes is a rare presentation. New onset diabetes after transplantation, the more transplantation, particularly renal transplantation at our unit that we are seeing more and more post-transplantation diabetes. This is something that we have to be aware of. All patients before transplant, they are evaluated for hyperglycemia, and even post-transplant, they should be regularly evaluated for presence of hyperglycemia. There are certain risk factors: family history, obesity, hepatitis C positivity, ethnicity, and transplant-related drug therapy might be all risk factors. And treatment is standard like any other form of diabetes. Here we can use insulin, metformin, and linagliptin has been used quite commonly at our institute. Endocrine syndromes presenting with hyperglycemia, acromegaly, Cushing's, thyrotoxicosis, pheochromocytoma, all of them can be there. I'm not going to talk about those in details either. If you can see here, this particular gentleman has presented with hyperglycemia, malocclusion of teeth. Now, this is Cushing's. You can see the stria, recurrent fungal infection that a patient might present with. Drugs. Now, drugs are very important, particularly in today's world, particularly, for example, steroids, which are being used in quite high doses. Fortunately, this wave of COVID, we are having less of lung involvement. Otherwise, we've seen so much of steroid-induced diabetes in the last 2 years or so. And COVID and diabetes, I think no talk nowadays is complete without talking about COVID and diabetes. Diabetes is associated with an increased risk of severe COVID-19, and COVID-19 is also associated with new onset of diabetes. Now, when we are talking about new onset of diabetes in COVID, you can see almost 20% were diagnosed with new onset diabetes after COVID. This could well be previously undiagnosed type 2 diabetes, or it could really be new onset diabetes, which is predominantly type 2 diabetes, but we now know that even type 1-like diabetes might be precipitated with COVID infection. There are several postulated mechanisms for that. Maybe downregulation of ACE2 receptor leading to increased angiotensin 2, angiotensin 2 mediated hepatic glucose production and impaired insulin sensitivity, defective insulin secretion, or there could be direct damage of beta cell with oxidative stress. So when you have someone with a new onset diabetes, what would your approach be? Remember that type 2 diabetes would be probably accounting for more than 90% of all new onset diabetes. Still, a good clinical history and examination and supplemented by laboratory investigations is important, not only to establish the etiology of diabetes, but also to diagnose comorbidities and also to screen for associated complications that might have already set in this individual with diabetes. So in the history, look at the age, because some of the disorders that I talked about is more common in certain ages. The presentation is important, presence of comorbidities and complications, drug history, including transplant. Dietary history is important because we'll want to try and modify that, familial predisposition, and look for secondary causes of diabetes, because otherwise you will never find those causes like endocrine causes of diabetes. In examination, the BMI is important to know, features of malnourishment, malabsorption, features of insulin resistance, features of secondary diabetes, presence of features of hypertension and dyslipidemia, and presence of complications. So all of that will come in. In terms of the laboratory evaluation, you have to look at certain things related to diabetes per se. If you are worried about insulinopenia and want to confirm it, then look for C-peptide. If you are worried about severe insulin resistance, or you want to be sure that the oral agents will work, even then C-peptide will be useful. In type 1 diabetes and in LADA, the antibodies are going to be useful, and screening for secondary causes of diabetes would be useful as well, and of course for comorbid conditions. So to summarize, new onset diabetes detection and management is very, very important to be able to pick up disease so that it can be treated, managed, complications prevented, or at least progression delayed, and complication managed. Type 2 diabetes would be the commonest cause, but we should keep our eyes open for other possible causes. And in complicated cases, the primary care physician might wish to refer the patient to an endocrinologist or diabetologist for opinion. I shall stop there. Thank you very much.
So, thank you, Dr. Shuja. It was a very nice presentation on new onset diabetes. With this, we move on. I request Dr. Kota to introduce our next speaker, Dr. Sudhir Bhandari.
Thank you, sir. Yes, we have yet another wonderful speaker. I did not go through the lines. You can actually go through his achievements, phenomenal, and is a wonderful speaker from whom we have learned a lot. And during these testing times of COVID-19, we all have understood that management of inpatient hyperglycemia has become a challenge, and it always is imperative on our part to learn about this. And it would be really a wonderful session, and it would be very informative and educative to all the doctors over here. So over to Sudhir, sir.
You know, Dr. Bhandari is the Dean in SMS Medical College.
Welcome to NUCD 2022. I am Dr. Alok Kanungo, and I am in discussion with one of the foremost physicians of the country, Dr. Sudhir Bhandari, and he is the pioneer in management of COVID cases in India. We'll have a discussion. Dr. Bhandari, welcome to NUCD.
Thank you.
You remember when the first wave came, you are the one of the first few physicians or doctors who handled it courageously. When we did not know anything about the virus, nothing about the disease, nor even about the drugs. What was the initial challenges for you?
It's a very interesting question. I must share with you, sir, that when the first wave came, our fear psychosis was peak and our confidence was very low because we did not know how to handle it. But we very patiently, very judiciously, and with the academic manner we handled it. Because, you know, when the first 3 Italian patients came to Jaipur with the COVID positivity, we did not have a specific drug to be used. So we very prudently and very interestingly, we did the research, and we wanted to create a bridge between point of no treatment till the specific treatment will be available. And after thorough review of literature, we created a bridge of using 2 antiviral drugs, that is lopinavir and ritonavir, and 1 hydroxychloroquine, and we got the ratification of the ICMR. Now, you'll be extremely happy to know, sir, that all our 3 Italian patients became negative with ritonavir, lopinavir combination with hydroxychloroquine. We got queries all over the world. We got queries from United Nations. We got queries from White House. Now, going back to that time, you'll be extremely happy to know, as of today, the first effective drug for Omicron is Pfizer's Paxlovid. You must have heard the newly introduced Paxlovid these days in America. And this Paxlovid is a combination of 2 antiviral drugs. One is the new antiviral drug known as nirmatrelvir, and second is a ritonavir, which we used in March 2020. So we created a combination of drugs, and we used antiviral drugs. We created the infrastructure, and we intensely worked on the investigation. We were the pioneer institute to do the 200 to 300 CT scans per day, including pulmonary angiography, to find out the microvascular complications of the COVID. So we handled it by new combination of drug, intense investigation, which included D-dimer, IL-6. We started working on the cytokine storm, CT angio, pulmonary CT angio for pulmonary thromboembolization, and all kind of respiratory support. After that came the remdesivir. At one stage, WHO did not agree with remdesivir, but we spoke a lot in favor of remdesivir, and immediately that we heard that US FDA approved the remdesivir. We picked up the early diagnosis of cytokine storm, and we started using a drug tocilizumab as early as in March 20, and which was ratified by UK in November 20. So we were very brisk to make use of situation. Meanwhile, we created the infrastructure, more ICU beds, more oxygenated thing. Sir, I would share with you the clinical difference in the first wave when the COVID was having R0, that is one person will infect how many other person with a value of 2. In the second wave, which came Delta wave in April 21, which has a very excessive R0, that is 7 to 8. So this one patient of Delta infected 7 to 8 patients, and which is almost 3 times in present Omicron, which is 20 to 25. So initially, our confidence was low, but we found out antiviral drugs, supportive treatment, management of cytokine storm, and created the infrastructure. We gave hydroxychloroquine prophylaxis to all the health workers, and they stood prevented. So this is the way we developed the confidence in second wave. We developed immense infrastructure. Second wave, as you know, was a very aggressive wave. It caused lot of mortality and morbidity that required early oxygenation and ventilation. In first wave, 10 to 12% people required hospitalization, but not so critical. In second wave, 10 to 20% required hospitalization, and they had a high morbidity and mortality. A lot of them went on high flow oxygenation, BiPAP machine, non-ventilation, and then intubated ventilation. The cytokine storm was huge. The post-COVID hyperglycemia was a major issue. Patient developed huge complication in terms of mucormycosis or black fungus. These were the challenges of second wave.
Yes.
But sir, yeah. So this is the way we develop the infrastructure and treatment methodologies.
Dr. Bhandari, it's so interesting to know about your journey and so advanced in your approach. But in the second wave, we found that the diabetes was causing a bigger problem. There were new onset diabetics, steroid-induced diabetics, and managing glucose was really, cytokine storm was taking hayward, and we had problem. What was your experience in handling diabetics?
Sir, let me first explain to you our experience of second wave. Suddenly, second wave started in month of April and May. By the time people had received only single dose vaccination, that too also 30 to 40% only senior citizens. So population was not very well protected. So in second wave, we started having huge respiratory embarrassment, early hypoxemia, patient requiring early oxygenation, and there was a paucity of the ICU and the oxygenated bed. Now, the reason was huge and high incidence of pulmonary pneumonia, and people used to have infiltrates in the lung with a very high scoring. Secondly, we started having issues of ARDS. Thirdly, very high pulmonary embolization with raised D-dimer. This was coupled up with the cytokine storm, which was diagnosed by high IL-6, high CRP, high ferritin, high LDH. These were the important markers which most of the people had. So we had to manage the viral phase, the first week, in which we used the antiviral drugs. The remdesivir was a mainstay. In the second week, we had to manage the cytokine storm, which we managed with the drugs like tocilizumab and the steroids as per the recovery trial. And many times we use the COVID plasma to begin with. But what happens? This was coupled up with significant hyperglycemia. There was a new onset diabetes. There was a people turning diabetes who were glucose intolerant. People having uncontrolled diabetes who were having controlled diabetes. This was partly because of remdesivir, partly because of Delta variant itself was found to affect the beta cell, and there was a hypoinsulinemia. And thirdly, the steroid was the mainstay of treatment as per recovery trial, which also led to the hyperglycemia. So uncontrolled hyperglycemia was one of the challenges in the second wave, along with the respiratory and the pulmonary components. But we managed this hyperglycemia by DPP-4 inhibitors, which was absolutely recommended in case of, but mainly was the insulinization. As per the needs and demands, we use the basal bolus, we use the twice a day. We use the basal insulin, those who are marginal patients, but definitely almost 70% patient required management of hyperglycemia. Now, this hyperglycemia invited a new trouble in the second wave, that a big number of patients develop black fungus or mucormycosis. And etiopathogenesis to the black fungus or mucormycosis were attributed to A, Delta virus itself, B, because of massive thromboembolic phenomena, there was a tissue necrosis where the fungus grows. So we had a lot of issues of the oral black fungus, the loss of vision, the central nervous system black fungus, and at the same time, the hyperglycemia as a result of virus, as a result of remdesivir, and as a result of steroids as per the recovery trial. So we had to be very careful about this thing. Most of the patient requires oxygenation. So we used to use the wetting water in the oxygen concentrator, the oxygen supply. So that also was a risk for the fungal infection. So truly speaking, we had to manage, number one, the most important aggressive pulmonary insufficiency by oxygenation and various modes of ventilation. Secondly, we had to manage associated septicemia or multi-organ failure as a result of cytokine storm. Thirdly, we had to manage in each and every patient the uncontrolled hyperglycemia, flare-up or new onset diabetes, and in some patients who developed the black fungus or mucormycosis. So second wave was very challenging, and above all, many patients who recovered, they suffered post-COVID complication or post-COVID syndrome, which was significant in second wave than first wave. Especially the post-COVID pulmonary fibrosis was the biggest challenge. Post-COVID fungal infection in the form of aspergillosis, it was another big challenge we had. So a lot of post-COVID syndrome, and post-COVID, we have a saying in medicine, from head to toe, whether CNS, the forgetfulness, the clouding of concentration, the visual disturbances, persistent headache, the loss of appetite, loss of taste, depressive symptoms. Psychosocial symptom was another big challenge, because each and every family lost someone their member or someone their friend or acquaintances. So tremendous psychosocial trauma was also a very important outcome of second wave. But by the time the vaccination began, so we have been very lucky. Our country produced indigenous vaccines. Look at today, we have vaccinated more than 153 crore people, more than summation of populations of many countries. So probably a wonderful vaccination drive which crossed across the second wave, and now 93% people have got first dose in our country, 70% plus has got 7 doses in country, and which is protecting us from any more side effect. And that's the reason the way we migrated from aggressive second wave to third wave, probably vaccination is protecting us in severe, critical, and ventilatory required state of the COVID.
Dr. Bandari, that's very nice. But now third wave has come, and Omicron is spreading very rapidly. And what is your forecast? How do our hospitals will be burdened? Will it have that much of ICU load, or what do you think?
Sir, it's a very intelligent question. Probably you are well aware of everything, sir. That hospitalization in the second was to the tune of 20% because of respiratory insufficiency and complications. The hospitalization in the Omicron is less than 1% or 0.5%. As I said to you, sir, that R naught value of Omicron is 20 to 25 against 7 to 8 of Delta wave. It means one infected person, if not taken care of, not use the mask and the social distance, can infect 25%. But few reasons. A, we are well vaccinated. B, our herd immunity is very good. I'll give an example. In the state of Rajasthan, we did a sero surveillance, and you'll be surprised. We found herd immunity or significant antibodies up to 91%. Sir, when this sero surveillance was done, the children's vaccination had not started, and by that time, 74% children had protective antibodies. It means there was a subclinical infection. So a good vaccination, good herd immunity by subclinical infection has been protecting us against significant, moderate, and critical Omicron symptoms. So far, 98% Omicron people are asymptomatic or mildly symptomatic. There has been another theory, sir, that though there has been a 30 type of mutations on the spikes of the Omicron, but because of TMPRSS receptor, which is affected in essential for penetration of these spike proteins into the lung, which is not happening. So these Omicron viruses are not able to penetrate lung. People are devoid of pulmonary pneumonia, except people with the elderly age, comorbid condition. That's a part apart, immunocompromised people. Otherwise, because of TMPRSS receptor not coming into action, like they are not able to penetrate the lungs, and there's only superficial symptoms of ILI like coryza, sore throat, mild fever, etc. Another important thing is that, so your question, practically there's a less than 0.5% people requiring hospitalization. ICU beds are empty, unlike second wave. Wards, oxygenated beds are empty, unlike second wave. And all those few patients who are in ICU requiring oxygen and ventilation are the unvaccinated ones, sir. Very strong statement it is that 80% of the admitted patients are unvaccinated, or they are the people who got vaccination before the June of 20. It means the antibody levels have fallen down within 3 to 6 months. And that's the reason there's a logic of prefixing or pre-transferring to the booster dose to a lesser duration. And even we may think of the second booster dose like many countries have thought of it. So as on today, Omicron is not causing any burden on the health system. But another important thing, sir, you can deal with pandemic in two ways. To treat, you, me, all can jointly treat, infrastructure can do, but that is not a way. More important thing is to prevent. Sir, thousands and lakhs of the patient, like 14 lakh patients today in America, if it comes to India, our hospitals will be short of the place and the manpower. The issue is that prevention can happen only by vaccination or masking and social distancing. Sir, masking is extremely important in Omicron because of R0 factor is 20 to 25. One affected person of Omicron can affect 20 to 25. Secondly, the risk of affecting other is so high, sir, because most of these people are asymptomatic or mildly symptomatic. So patient may take it as a casual mild cold or casual coryza, not take seriously that it could be Omicron. He may not use mask, he may not maintain social distancing, and he can infect others. So because of the milder nature of the symptomatology of Omicron, probably the masking is much more important. And you know it very well, sir, that an infected person wears the mask. Practically, he protects 95% the people around. Absolutely. But even if we are wearing mask and there's an infected person unmasked, our exposure chances are very high. So I think as on today, there's no burden on health system, provided people at large cooperate with us to maintain this no burden state.
Thank you. Thank you so much, Dr. Bhandari. It was nice talking to you. And when listening from the most expert of the country, it gives a lot of a positive sense.
Sir, I would like to say a few words about the treatment part of Omicron, sir.
Yes, please.
People should know. Now, we need to know the treatment methodologies. The best drug for Omicron is a Paxlovid. And Paxlovid is one drug which is available, is by Pfizer. The combination of nirmatrelvir with ritonavir. Second best drug is Stromivab, which is a newer monoclonal antibody. Third is a remdesivir can be used, but for 3 doses only, 200 on day 1, then 100 on day 2 and day 3. And lastly is tolpuvinamab. There's been some controversy about that, so we'll not talk about it. So this is the way we can handle. Otherwise, in a significant or moderate cases, otherwise simple medications are enough to treat the asymptomatic or mild patients.
Very nice. I think our delegates must have understood a lot of it. They must have gathered a lot of things. Thank you very much, Dr. Bhandari, and we'll meet you in the panel discussion. Thank you, sir.
Thank you.
Thank you so much.
Very successful interview with Professor Bhandari, and it's from Harsh Maut. He is the Dean and Principal of Sawai Man Singh Medical College, Jaipur, one of the largest in the world, and they have catered to highest number of patients in first wave, second wave, and the third wave. So you heard the inpatient management, diabetes management, and starting from the first wave to the latest, the newest management, the drugs which are not yet available in the country. We have Professor Ashok Das here, and I request Dr. Kota to introduce Dr. Satya Das for the next presentation, the mucormycosis, diabetes, and COVID-19, the evil triangle. Dr. Das is here with us and watching us, and he'll be sharing his views in panel discussion. Before that, Sunil to introduce Dr. Das.
Thank you, sir. We have one more wonderful session by Dr. Satya Das, and he is from the University of London, who has qualified in the year 1982, trained in medical microbiology, and a lot of research on different types of infection. In fact, I'm really happy to understand that he has studies with respect to molecular pathogenesis studies in microbacterial tuberculosis, H. pylori, and whatnot. Over 115 staggering publications, and we would be very eagerly listening to you about the mucormycosis and COVID-19. Over to you, sir.
1 second. I am Satya. I am Dr. Alok Kanungo, and I want to thank you for accepting our invitation and to join this NUCD, a son of the soil. Even though you have been educated from the childhood at UK, but you have the link with Odisha, and we welcome you to this NUCD.
Please unmute.
Hello, everybody. First of all, I'd like to thank Dr. Kanungo and his team for inviting me to talk at your conference today. Very nice to be with you all. I wish I could have been there in person, but it's not possible. Bhubaneswar is also one of the places I visit very often to see family and relatives from London, but maybe another time. So this is the title of my talk, Diabetes, COVID-19, and Mucormycosis, an Indian tsunami. It's such a grandiose title, but I think it's appropriate. And you'll see why. What I'll do is to discuss the incredible synergistic but evil interaction between diabetes, COVID-19, and the catastrophic effect that combination has in causing what has been regarded as a tsunami of mucormycosis infection in India. This is otherwise a rare disease, even by Indian standard. I will also describe how or what can be done to improve management and prevention of this dreadful condition, which has killed thousands of people, particularly in India. I came across this interesting article in the Hindustan Times, New Delhi, published May 21st, which says that mucormycosis, the black fungus, has infected at least 7,250 and killed at least 219 people in India. And there are the states there and the statistics, but the three biggest in terms of cases and deaths are respectively Maharashtra first, Gujarat second, and Madhya Pradesh third. There are some interesting comments in that article, and one of the things is that because of this tsunami of mucormycosis cases, which are classically treated with amphotericin B, the country is running out of supply of amphotericin B, and that every attempt should be made to procure a drug for mucormycosis from international sources. And I think the next one is interesting in terms it really summarizes that evil interactions gives rise to this catastrophic disease, which is that diabetes lowers the body's immune defenses, coronavirus 19 exacerbates it, And to make matter worse, the steroids used for treatment of coronavirus which is important because it controls the anti-inflammatory side of the COVID-19 pneumonitis. But unfortunately, because of its immunosuppressive effect, predisposes to infection, including mucormycosis. And it's like adding fuel to the fire. And then these are very interesting statements in that article. It says India is a COVID disaster, but it didn't have to be. There is anger about COVID in Modi's constituency. India's COVID-19 patients turn to black market and also over the counter to prescribe themselves. And that is one of the big problems, of course, in controlling such a dreadful infection. Then, interestingly, says a senior government official says there is no big outbreak, yet it is difficult to say why a growing number of cases of mucormycosis are being reported from all over the country. So, what is COVID-19 associated mucormycosis, or CAM? It's a notorious fungal co-infection that occurs with COVID, but very importantly, to realize it can occur during COVID for many weeks or months after recovery from COVID-19 infection. It accounts for about 0.3% of COVID-19 co-infections. It's been reported in many countries around the world, but India is the epicenter, with this alarming increase in cases of mucormycosis compared to other countries around the world. So during the first week of June 2001, India is reported to have had 20,000 cases of COVID-associated mucormycosis, abbreviated to CAM, and by far the hardest hit country in the world. And this is really nicely illustrated in the next global map of the world, and saying in India, all red, there's no other red country, so to speak. So just focusing then on the problem in India, then prior to COVID-19, mucormycosis did occur, but it was rare even by Indian standard, although, not surprisingly, it's much higher incidence compared with developed countries, some 70 times higher the incidence, because of the humidity, the heat, and the tropical nature, which favors the growth of this fungus in the environment. So there was, again, more statistics. There was explosion of cases of CAM during the second wave of COVID-19. Is estimated that it's around 68,000 cases in total in India. As a result of which, the government of India has declared CAM a notifiable disease, and indeed many state governments declared an epidemic. I think that was important because it required implementation of control measures, guidance in procuring amphotericin B and other agents to control the disease. What is very interesting is that in this particular scenario of diabetes and COVID-19 interaction, the form of mucormycosis that one sees is mostly that one which affects the sinuses, and the orbit, and eventually the brain, and that is called rhino-orbital cerebral mucormycosis, or shortened to CARCOM. And this is by far the most common type of mucormycosis seen during the pandemic in India, followed by pulmonary mucormycosis, with which you may also be familiar with. Mortality from mucormycosis has increased dramatically from about what was very bad already, 50% mortality rate pre-COVID, to around 85% during the pandemic, which is related, it seems, to lack of awareness, crowded hospitals, unavailability of health resources, healthcare resources, overburden, and in some cases unqualified, so unregistered healthcare workers, and poor diagnostic facility and quality. So let's just concentrate on this more common form that is in diabetic patients in COVID, CARCOM. The initial presentation is the paranasal sinuses, from which the infection spreads into the orbit and then retrograde into the brain, and almost always fatal, of course, in that particular situation. The cosmic study findings found that commonly is, as I've explained above, is necrotic ulcers, black lesions, and hence the misnomer of black fungus, necrotic ulcers in nasal cavity, and in the eyes, the orbital apex syndrome, and then, as I said, retrograde spread to involve the cavernous sinus, causing cavernous sinus thrombosis, and the frontal lobe of the brain most commonly, and death. Ear involvement also happens sometimes, manifests as otitis externa, failing to respond to antibacterial treatment. The patient outcome, the increased mortality is with pulmonary cases, disseminated cases, and cerebral forms, which you can get in CARCOM, and of course, particularly in very badly controlled diabetes with high hemoglobin A1C level. In terms of risk factors for COVID-19 associated mucormycosis or CAM, the most important is diabetes, but very importantly is uncontrolled diabetes. And that is reproducible in the Indian literature in at least about 65 to 70% of cases of uncontrolled diabetes. And it's also not just uncontrolled diabetes, it's the hypoglycemia from that, and sometimes the diabetic ketoacidosis. These impair innate immunity, i.e. stability of granulocyte and macrophages to migrate phagocytose and kill spore of E. coralis and stop the infection from going any further. This Mucorales mucormycosis, interestingly, they possess a ketone reductase, and which enables it to thrive in high glucose condition in hypoglycemia, and results in a very poor prognosis. Interestingly, some statistics that in the almost 1.4 billion population of India, about 75 million, probably underestimate, 77 million with diabetes. And that is, so the control of diabetes is terribly important to the controlling COVID-19 as well as the COVID-19 associated mucormycosis. Very important contributing factor in this is the treatment of COVID with steroids, corticosteroids. And that is found again in around 70% of cases of CAM. But also, it's the inappropriate dose. Initial course in India, there's a very high dose of corticosteroids were used, which increased that risk even further. But that was recommended in the Indian guidelines to start with, and then reduced to be complied with the WHO guidelines later. And then, very importantly, also, non-severe patients who started taking corticosteroids out of fear and without sometimes consulting medical staff and going over the counter and getting the drugs and self-treating. And that no doubt contributed to this massive explosion of mucormycosis cases, of the black ones in India. It should be appreciated that corticosteroids cause lymphopenia and lymphocyte dysregulation, and hence increased risk of opportunistic infection, including mucormycosis, as well as inducing hypoglycemia in patients with diabetes. And the other treatment modalities in COVID-19 which is contributed to this is monoclonal antibodies. And obviously the one that was the most commonly used is tocilizumab. And obviously that is important in dampening down the inflammation and bringing COVID pneumonitis under control. But unfortunately, it also reduces immunity and increases risk of opportunistic infection, including mucormycosis. Antifungals, particularly voriconazole, which is inactive against mucorales, it can lead to breakthrough infection with mucormycosis. Inappropriate and over use of broad-spectrum antibiotics and antifungal in post-treatment prophylaxis interfere with the microbiome in the sinuses, and this possibly could increase risk of opportunistic infection as well as mucormycosis infection. Neutropenia, very well recognized risk factor for both bacterial fungal infection, including mucormycosis, and organ transplant because it's use of corticosteroids and immunosuppressive drugs. Similarly, so, and that combined with poor infection control practices and environmental factors which are dominant in the Indian climate. So what is mucor? Because mucor is a very rare infection, as I told you. It's a fungus, it's a filamentous fungus. It's widespread in nature, it's ubiquitous in nature, being found in soil, in fruits and vegetables. And it is the cause of the disease mucormycosis, which previously was known as zygomycosis. Most common, there's so many mucor species, but the most common are the rhizopus, the mucor, the rhizomi. And on culture, on subarachnoid plate, which is a fungal plate, the appearance is not a black fungus, as you can see. If anything, it's a white fungus. It's fluffy and it's powdery-like. That's because of all the filaments that's coming up and liberating, which then liberate the spores. And that's what you see on the right on a microscopic finding. Is all these long filaments, and there is this kind of sporing structure which called branchiospore, which contains millions of spores, which are then liberated into the environment, into the air, into the soil, which obviously when we breathe it in, come in contact, can germinate, produce hyphae, which is the invasive disease-forming form of the organism. And comparing Aspergillus, which is far more common than mucor, the mucormyces, they're much bigger. The filaments are larger, wider, compared with Aspergillus. They also don't have any septi, unlike in Aspergillus on the left. You can see some septi there. And the mucor branches at a wide angle, 90 degrees plus, whereas Aspergillus branching is at 45 degrees, so-called dichotomous branching. So there are very interesting microscopic differences which can give a clue to the diagnosis. And here we're seeing in terms of the different forms of mucormycosis, how the pathogenesis, how they present, the risk factors. Let's say the most common in terms of diabetes and COVID-19 is the rhinocerebral mucormycosis. And as I've said, it's the spores from the fungus, which gets into the sinuses and fades, and then goes through the cribriform plate and through also the orbit into the cavernous sinus, causing CST and eventually death. So it commonly manifests as ptosis, proptosis, permanent vision of loss, sinusitis, and so forth. The other forms of pulmonary mucormycosis and disseminated mucormycosis in terms of the context of diabetes. The disseminated form, which obviously is infection of the bloodstream and spread into different parts of the body, is particularly in iron overload situation. Iron is very important in a lot of microorganisms to grow, and that is also true for mucor, neutropenia, and immunosuppressive situations, but not necessarily diabetic ketoacidosis. Very important in mucor is angioinvasion or vascular invasion. This is the hallmark of mucormycosis. And it is this which leads to ischemic necrosis of infected tissue, death of the tissue, causing black lesion. And that is what people have latched onto, or the media has latched as black fungus. It's not black fungus, it's the disease that manifests as dead tissue, which is black. But it impairs the delivery of immune response as well as antimicrobial therapy. That's why it's so difficult to treat when it is established. And of course, it contributes to hematogenous spread in the bloodstream to other organs. The glucose, there's a glucose-regulated protein receptor, GRP78, on endothelial cells, to which mucor can attach to and does attach to, and then invade as a mechanism by which it invades both the blood vessels into the bloodstream and also into the tissues. And this is a very nice pictorial explaining the pathogenesis with the environmental source of the organism, widespread soil, decaying matter, the right condition, which helps it to germinate. And that we must not also forget, building constructions are a big place for this, because there's a lot of demolition, a lot of soils, a lot of air, a lot of soil, dust being generated. And these are rich sources for the fungus and its spores, which gets into healthy host, doesn't cause anything, because we're very, very competent and intact innate immune mechanism with neutrophils and macrophages, which gobble up the spores and prevent it from germinating to hyphae, which is really pathologic form of the organism that invades and causes so much destruction. However, in COVID patient, you have double whammy, because COVID, which can directly affect the innate immune system, then you've got is indirectly through the treatment of COVID, as I've said, things like the corticosteroids, particularly impairing the innate immune mechanism and allowing the spores, the mucormyces spores, to germinate into hyphae, invade, and cause disease. And this is, again, this is saying that GRP78, the essential receptor for mucormyces, to latch onto and then invade into the bloodstream and into the tissues, and then spread, because the dreadful disease that it does. So the problems with mucormycosis is a rare disease. It's not very often thought about, and it's difficult to diagnose, difficult to manage, high morbidity, mortality, as I said, and it requires urgent and repeated surgical debridement often. So as a result, of course, there are clinical guidelines to help us manage mucormycosis, which deal with the whole spectrum of epidemiology, pathogenesis, clinical presentation, diagnosis, treatment, and prevention. There are international guidelines, and there are India-specific or India-centric guidelines. And I think both are important. And just saying in the international guideline, this is from the European Confederation of Medical Mycology and the mycosis study group, which is widely used globally. But as the India-centric guidelines are very good as well, and it's really tailored very much for COVID problem, for COVID-associated mucormycosis problem in India. The diagnosis, again, I've told you about the hallmark intravascular invasion, the black eschars, the lesions, necrotic black lesions. So we need a biopsy of the tissue. We need a tissue sample for microbiology to do microscopy and culture on fungal plate. If it doesn't, then we can do molecular diagnostic looking for the fungal DNA by 18S PCR. Also, because if you do grow the organism, we need to know what antifungal drug is susceptible to help manage, to treat this condition. But that usually is done in reference laboratory and takes a lot of time, at least a week or two. Then, of course, histology using H&E and fungal stents like PAS or GMS to go more remote. Silver stain stains the fungus black, and here is again the mucormyces with its aseptate hyphae and broad branching. And then these are, of course, the clinical presentations I think many of you become aware of in India, in far more cases than I have seen in London in my hospital. I'll be lucky to see no more than 1 or 2 cases a year, but you probably see hundreds. So you are far more expert in this than I am. But this is what these are the black lesions and the things. Black fungus is really the pathology that creates this black appearance and ischemic necrosis, and it's devastating. Here is the nose getting eaten well. Here we've got the palate being perforated and going through the peripheral plate, then into the frontal lobe of the brain. And in this particular case, you can see the CT MRI scan of intensive hemorrhage in the frontal lobe there, and also this is from a patient who died. And here is the orbit affected. And this requires urgent surgery. In most cases, the patient will lose that eye. But it can also, of course, invade across to the other side and cause double blindness. So this is absolutely catastrophic and very frightening, because there is really not much you can do in many other cases. In terms of antifungals, if you see on the unlike the Aspergillus and Candida, the Zygos here, Zygomyces, which is same as Mucormyces, you can see is very resistant to antifungal drugs. The only thing it's sensitive to are only about 3 drugs: amphotericin B, voriconazole, and recently in the last 5 years, isofluconazole. So in terms of the treatment, by far the most important is not antifungal, it is surgery. Surgery is absolutely critical and it's urgent. You must do it quickly, and so be aggressive surgical debridement to get rid of all necrotic tissue until you can see bleeding tissue, healthy tissue. It may have to be repeated multiple times, but you do need antifungals as an adjunctive treatment to surgery, not as a replacement for. The primary agent, most effective agent, is liposomal amphotericin B, given at high doses, 5 to 10 milligrams, particularly for cerebral mucormycosis, the 10 milligram. If you're intolerant to liposomal amphotericin B, one can use isofluconazole or voriconazole. Both also can be used in an IV to oral switch, which is very useful, but unfortunately, neither of those are as effective as liposomal amphotericin B, which has to be given intravenously. Here, I just want to concentrate on the last 3 here in terms of the other modalities of treatment. Iron chelation, the study about mucormycosis thrives in the iron medium. The way it does it is it grabs the iron, free iron. In the blood, of course, iron is bound to iron-binding proteins such as transferrin. In diabetic ketoacidosis creates an acidic environment with a pH of 7.3 or lower. In that environment, when it decouples, the iron decouples, it comes away from the iron-binding protein and is freely floating in the bloodstream and in the tissues, which the maker grabs it. The maker has it, like desferrexin, for example, it can hijack it. But through that mechanism, it grabs iron, which helps it to grow and multiply. Sorry, the other thing is hyperbaric oxygen, but iron chelation is not, there's no clinical trials. Neither is for hyperbaric oxygen. It's attractive, creating oxygen-rich environment, and it's not widely available. Similar with cytokine therapy, in vitro is active, but no clinical trials. It's very toxic and very expensive. So coming to the last couple of slides, the prevention of mucormycosis and diabetes. It's absolutely crucial to control COVID-19 and diabetes and reduce COVID-associated mucormycosis. So you need to check and through that, of course, the COVID control, you know that vaccination, masking, social distancing, hand hygiene, and so forth. But absolutely crucial is checking and controlling blood sugar level all the time. And keeping an steroid use appropriate. Only patients who really need it, not i.e. those who are hypoxemic and seriously ill. Everybody takes it, and that is really contributed to the problem that we have seen in India and some other places to a lesser extent. And the dosage is very important, as I said, it's be at the correct dose and only for 5 to 10 days. And discontinue any type of immunosuppressive drugs as far as possible, because these are all contributing to allowing the fungus to multiply uncontrolled. Use a mask, and certainly that should reduce chances of inhaling the spores of Mucorales. Must avoid being near any construction site. And also, very importantly, once the patient recovers from COVID-19 discharge, must closely monitor for early symptoms, signs of mucormycosis, so including chest pain, respiratory insufficiencies, could be pulmonary mucormycosis, or the rhinocerebral, intranasal blockades, excessive nose discharge, facial pain, eye problems, and so forth. So in conclusion, despite improvements in the last few years, survival from mucormycosis remains very poor. The overall mortality is between 40 and 80%, the latter more in the context of COVID and steroid, inappropriate use of steroid and immunosuppressive drugs, as well as monoclonal antibodies. Early aggressive surgical debridement system and antifungals are vital. And as I've said so many times now, controlling the risk factor is crucial. Diabetes, diabetic ketoacidosis, COVID-19, and this treatment, steroids, MC, monoclonal antibodies, including tocilizumab. So there's some references there, and there are references to international disease, and then India-centric, and these are really good articles. I would sort of encourage people interested in this disease and diabetes to read, and they're excellent, in fact. And there have been so many, but I've just chosen three of the ones I particularly follow, the ones I particularly liked. And with that, I thank you for listening. The question and answer session will follow in the panel discussion section. Just like to thank my registrar, St. Bart's Hospital, Dr. Anthony Batrat, who did some of the initial work when he presented. Not this case, but mucormycosis related to hemato-oncology problems in our journal last year, and also authors of the reference articles, because many of my illustrations are from them. So I'd like to thank them very much. And thank you for listening.
Thank you, Dr. Satyadas. That was a very informative presentation on the evil triangle, mucormycosis, diabetes, and COVID-19. Starting from the microbiology of the mucormycosis to the unholy alliance of these three pathologies, you have very clearly delineated. With this, we'll move on to our panel discussion. I invite our panelists, and there are a few questions very important, but as the speakers were very good, the issues of new onset diabetes by Professor Ghosh and issues of in-hospital management by Professor Bhandari, and also the unholy triangle of COVID-19, diabetes, and mucormycosis by Dr. Satyadas was very informative in the session COVID-19 and diabetes, the 5th session of the 8th edition of NUCD 22, and today's last session. So in few minutes, we'll be closing the session, and I invite all the panelists for the questions. I think Dr. Das is there. Shujo is there.
Yes, Shujo.
Yeah. Dr. Shuja Ghosh, Dr. Bhandari.
I think we can start asking questions, Jan.
Yeah.
Can I start?
Yeah. We can start, sir. Yeah.
Dr. Satya, your presentation was absolutely fabulous. I liked it. Just wanted to know, to make a long story very short because time is less, we also encountered few cases of what we call white fungus, the aspergillosis, and something of the we call it quote unquote yellow fungus. Did you also encounter them during this pandemic or in your career there because of diabetes or hemato-oncology or other immunocompromised patient? I think you're muted, Dr. Satya.
Yeah, you are not audible, sir. You have to make the device audio. Yeah. You have to make the device audio on. Take out the earplug.
Maybe you are not put your.
Sir, can you remove your earphones and try?
Please take out your earphones, Satya, and try without earphones.
Device audio on. And take out your earphone so that you can speak to your device. That's the best thing.
It's not audible.
Hello.
Yeah, by the time Satya sir is audible, I'm taking another question. to Professor Das. Do you think COVID causes diabetes?
Whom are you asking, me or Satya?
Yeah. Professor Ashok Das.
I strongly believe COVID can cause diabetes in two ways. Number one is that COVID has a direct pancreatopathic effect. And we have seen a couple of cases where the COVID was instrumental in producing pancreatic necrosis, and they developed diabetes and they were on insulin. But you may ask me whether insulin for a long time. As long as they were in the hospital, they were on insulin. So we're following them up. Now they're on BITS therapy, bedtime insulin, daytime sulfonylurea. We have to see how they behave. The second way COVID can produce diabetes, Jayant, is the stress induced. You know, COVID is a terrible stress, the diagnosis itself. So we've seen few cases of hyperglycemia or diabetes induced by the COVID diagnosis and the COVID stress beyond the diabetes, NOD, new onset diabetes, which Satya has so beautifully described because of steroid therapy. So I believe there are three ways one can get new onset diabetes. One is what Satya described, the steroid therapy or whatever. The number two is the direct pancreatopathic effect of the virus. And third, because of the stress-induced diabetes.
Very rightly delineated, sir. Professor Das has edited a full monogram on COVID and diabetes, and then it is so informative. I'm a part of the book. Yes, we have contributed a chapter. Yeah. I went through, and by the time I had taken and distributed many of my close colleagues, and it's very informative. So, Dr. Das, are you through?
Satya, are you audible now? Just try speak few words.
We are unable to listen you, sir. Stuti, you can help Dr. Satya Das?
Yes, sir. Satya Das, sir. सर आपका जो ऑडियो का आपको एक आपकी स्क्रीन पे नीचे एक बटन दिख रहा होगा आपको फॉर म्यूट एंड अनम्यूट. अगर वो कनेक्टेड नहीं है तो वहां पे आपको एक ऑप्शन भी आएगा कनेक्टिंग कंप्यूटर ऑडियो.
जो हाथ में पकड़े वॉइस उसमें भी ऑन ऑफ है.
Yeah, it's audible now, sir. You can speak. No.
Sir, can you just remove your earphones? सर आपके ईयरफोन से ना उसको प्लग आउट कर दीजिए आपके लैपटॉप से. उसको लैपटॉप से निकाल दीजिए सर.
You take out the earphone connection to laptop. You have taken from your ears. Now take out from the source, from the laptop. Now you try to speak, sir. You'll be audible.
No, sir, it's not audible. I think the setting.
Okay, I have to ask one or two questions in relation to what Professor Satya said. That we have seen one or two cases of, also published under the name of Dr. Kishku, where he also found aspergillosis. And one case, what they have been described from Chandigarh as white fungus, white mucor, and one case of very severe sepsis with mucormycosis. But lo and behold, with the targeted amphotericin B therapy, he also became all right. And now we give amphotericin B not for the 14, not for 28 days. We give it for about 6 weeks, and we keep them in a room adjacent to the, not adjacent, nearby the hospital, and we give the injection and follow them up. And we have been very, very happy that the turning out has been great. We wrote a lot of articles in the Indian Express, and one such article which I'll focus here, I will just show it here, was on the mucormycosis we found there. And is it visible? Jayant, is it visible?
Not clearly, sir.
So we wrote about that in the second wave of COVID-19, when they ravaged the country, mucormycosis was one of the greatest threats, and we had large number of cases. We did not count the cases, but we said that the opportunistic infection comes from the fungi that we have already discussed, so beautifully described by the Satya. But we also said there are some risk factors. The risk factors, one of the risk factors is emphasized beautifully by Satya, blood sugar control, and indiscriminate use of steroids. You give steroids, Jayant, I know, for 5 days. People give steroid for a very long time, in spite of oxygenation improving. We have brought down the steroid use, and also personal hygiene, because these viruses are there on the wood and also on the zinc. We can see these pictures also along with that. We said that if you don't take personal care of not touching this wood and the zinc, and also keeping the mask clean and dry. Many doctors wear mask which cannot describe, wet, ganda ho gaya hai, and these are the greatest source of mucormycosis. So we in the hospital change mask every day, keeping the mask clean and dry, and ensuring a very, very hygienic surrounding is very important. Last point I would like to say that it progresses very rapidly. I have seen within 1 day infection from the nose to the eyes and to the brain, resulting in a very serious outcome. And nothing can be more serious than death. So it is very important to suspect the diagnosis when the patient comes to you with eye pain or nose pain, sinusitis and fever. And for the prevention, we said that do not start steroids on hearsay's advice. Wait for the doctor's advice. And the importance of following preventive measures are very important. And usually surgery we have performed majority of the cases, both by the ENT and the ophthalmic surgeon, and the results have been rather rewarding. Thank you, Sanjay, for giving the opportunity. Whom to ask question now? Would you like to answer one?
Yeah, Dr. Satya, are you? I think there's another connection.
Yeah. I've just switched on another laptop.
Yeah. So now you are audible, sir.
You're audible beautifully. You know, Saint Bart is the Saint Bartholomew's Hospital is the Makkah of diabetes. You know that all the great scientists of diabetology, type 1 diabetes, Satya, have been trained in Saint Barth. And so it is a fantastic hospital that you are in. I just wanted to know that you said that you had less number of cases compared to India. That is only because of the sheer numbers. In diabetes, COVID, we had sheer numbers very, very higher than the UK numbers. But what type of mucor you saw mostly? This was usually ocular or oculo-cerebral or the rhinocerebral. What was the maximum number of cases?
It's the rhinocerebral in terms of the diabetic patients.
Rhino.
Yeah,
Rhino.
In my at St. Bartholomew Hospital, I deal mostly with hemato-oncology, so it tends to be more dominated by pulmonary ones. But we do still see rhino-orbital.
And what has been the outcome with we have you show the capsopungin and all that. We have also found it not very useful. We have
used the caspofungin doesn't have any activity at all against mucormycosis. As I said, it's a big problem. The big problem is that it's limited number of drugs.
Yeah,
and in effect,
we mostly used the amphotericin B, the liposomal form, and we give it for a very long time. We do not stop within a short duration of therapy. What has been your experience of therapy?
Well, unfortunately, I've not seen one in the context of COVID-19 because that's in one of our sister hospital. But in terms of mucormycosis in our sister hospital, I think we've only had about 2 or 3 cases.
We used, along with other drugs, we used the posaconazole in few patients, the oral posaconazole.
There is, I know sometimes people use combination, but there is no evidence at all that combination is more effective than monotherapy with ambisome. And obviously, it's in a very rare disease like
itraconazole.
Sorry,
itraconazole.
Itraconazole is more often posaconazole. Itraconazole is not as good as posaconazole or isobutanol. So we tend to use only, if we can't use ambisome because of adverse drug reaction or any other factor, then renal function, for example, then we tend to use isobutanol as our second choice, with posaconazole as a third choice.
Yeah.
But these are significantly less potent than ambisome.
Actually, our SCB experience, we have treated more than 200 patients. And as Professor Das told, mostly people required surgery. And initially, the blood glucose control was a challenge. And we primarily gave lyophilized amphotericin along with posaconazole to good number of patients. But along with medications, along with diabetes control, surgery was required because we also had highest number of rhino orbitocerebral mucormycosis, more than GI, more than pulmonary. We had that, and then
have you analyzed the cases, Jan? Was it because of indiscriminate use of steroids beyond 5 days?
Yeah, multiple factors we found, sir. Mostly these patients stayed in ICU for long, at least 2 to 3 weeks. They got high dose of steroid for longer time in the interest of saving their respiratory function and the lungs. And another thing, as already have pointed out, the dirty habits, the dirty masks, and the contamination and the high dose of zinc and the contamination part, and also factors like poor control of diabetes, they contributed towards this ubiquitous fungus. It's a opportunistic fungus.
It exists everywhere.
Yeah, exists everywhere. So only thing in this immunocompromised patient, it took a very severe form, and many lost life because it was potentially dangerous. People presenting with headache and blackish discharge from the nose with the doses.
What I said, that what we wrote in the Indian Express article for the common people, that in a case where the COVID or post-COVID, any eye pain, ear pain, sinus pain, don't take it lightly. Go to a doctor to have a look whether it can be because of that. I want to ask one question to Dr. Satya. You know, the mucorale family that you described, the mucorale family to which this organism belongs. Speaking microbiologically, what is their spectrum of illness they produce, and are they becoming rarer and rarer or becoming stronger and stronger?
No, I think they're not more common or rare or at all, because they're part of our environment, and so I think where if there is a lot of changes to the environment, for example, there's a lot of building constructions going on, which generate a lot of dust. And they're the situations where much more likely to disseminate the organism, and the human contact will be much more. And as I said, if you're a healthy individual, it doesn't cause disease in most healthy individuals. There has to be a defect in terms of immunity, in terms of problems with blood glucose and diabetes patients and immunocompromised patients. It's really having a very common organism. The disease is rare, but the organism is very common in our environment. I think it just tells you how good a normal immune system is at coping with these organisms. We come with it every day.
Yeah, that is
not
amazing.
all of us die from. Not all of us get the disease.
Amazing. And also how true it is, Satya, that when we find a infection specific to a particular condition, a diabetic which comes with a black discharge from the nose is nothing but rhinocerebral mucormycosis. A diabetic which comes with a big eye, you showed those pictures, big eye or the perforation of the palate. I do realize you are an ID specialist, Professor Satyadas. I have found that there are some infections which are specific to diabetes, as under specific to type 2 diabetes, type 1 diabetes. Type 2 diabetes carbuncle is a type 2 diabetes phenomenon in my mind. I'm not seen in type 1. Similarly, the COVID, the mucormycosis in diabetics is extremely common. And COVID, common in the sense, if you get a black discharge, if you're getting eye swelling, if you're getting a nasal sinus problem, if you've got severe headache with some neurodeficit, it is nothing but rhinocerebral mucormycosis. It's a specific infection. And that helps the clinician. That also helps you, Dr. Satya, in arriving at a diagnosis and guiding us how to treat. Am I correct?
Well, I think the diagnosis is a challenge. I think even more challenge for us because we don't see many cases. I think that's why I think it is a golden opportunity really to advance knowledge about the subject. And I think that India is best placed for that because
we have seen hundreds of patients. I
think what's important is that you write up your experience. You're talking about the drug.
My good friend, Professor Jyotirma Pal in Bengal has written a monogram and mucormycosis. I'll forward that to you. I'll collect your number from Dr. Alok Kanungo.
And also soft copy. Soft copy is also very good.
I'll send the soft copy. And we have described more than 200 patients there. So exposure is very high here, as you know, as usual in every segment. But the scientific documentation part has to be done carefully.
I think we'll stop here, and we wish to thank Dr. Satya you profusely for being
Thanks very much for inviting me.
And it must be 7 o'clock, 6:30 there evening, Satya.
4/5.
Yeah,
I was for a couple of years in King's.
It's 4
Hospital.
4/5/17.
Good. 6/17. So great country and great institute you are in. We used to call St. Barth as the Makkah. King's College was not that good that time. I'm talking about 1990 beginning. And so hats off to you for your great work, great interest in the subject and keeping India, bringing India pride. And please come back year after year to join us and to enlighten us.
Thank you very much. But in fact, next year, which will be in 2 years' time, next year, 2023, St. Bartholomew Hospital will be celebrating its 900th anniversary. So this is the oldest hospital in the UK.
It's an epic hospital, Alok and Jayant. You know, it is something like a pilgrimage to go to the hospital. In between, the NHS decided not to open. Remember that time about few years back, they said St. Barth will not admit few cases. They became a bit restrictive. Am I correct? Became little restrictive. They became little restrictive. Not now, about 10, 12 years back from today. They said that they had cut down the number of positions and people had to leave St. Barth to go to Bristol.
That is because there was a big merger of many hospitals and medical schools in London in the 1990s.
Yeah, exactly. I'm referring to that. But it has come back. 900 years is rare. And also, Jayant and Alok are alumni of a college which is oldest in our country, along with Calcutta and Madras Medical College. You know it, SCB, one of the oldest colleges, but not yet 900 years. Thank you very much, and come back again and again and again.
Thanks a lot.
We really enjoyed your talk. Thank you very much.
So we had a very successful session, COVID-19 and diabetes. I thank all the speakers, Dr. Sujay Ghosh, Dr. Sudhir Bhandari, and Dr. Satya Das, and our moderator, Dr. Sunil Kota, and Professor Ashok Das for mentoring the whole session. And the topics were very interesting, the new onset diabetes and inpatient management, as well as mucormycosis, diabetes, and COVID-19. And the special discussion on COVID-19 with Dr. Satya Das was very informative, and we got a global picture in it. I thank all the speakers, moderators, the chairpersons on behalf of the scientific committee. And with this, we close today's
scientific program. 1 minute, Jayant, 1 minute. I'll just summarize today's program because I believe in...
I'll hand over it to you, sir. Day 1 headlines roundup.
I'll just take the headline roundup. We started absolutely dot on time, 1.05. That was decision by Alok. And we had a wonderful inauguration. The beauty of the inauguration was, Alok, that everybody spoke and spoke so beautifully from their heart. That was a great thing you introduced this year. I liked it profusely. And then we had the oration for Professor R.J. Dash. And I must tell you that I hold him in high esteem. And after the oration was over, I got 5 letters, one from Arpan Dev, one from S. Murthy, one from another student called Sanjeevi, again the Sanjeevi, and 2 more. They wrote to us, sir, please forward the lecture to us. We want to introduce it in the ESI and RSSDI. So Alok, we are the first to introduce the oration. So great glory to us. I will write to Madam tomorrow. The second session was on the nutrition. Fabulous session. You know, Dharini made a wonderful presentation. Cheryl was absolutely great. And Dr. Sharma, he talked about the reversal of diabetes in 3 ways. Bariatric surgery is only 1 way. He talked about the carbohydrate restriction, both total and intermittent, and told about the low carbohydrate diet, referred to direct study. And, I was just about to ask him, Even the new drug which is introduced in the country, like weight reducing drug like Rybelsus, the oral semaglutide, or even they also can produce a great reduction or remission of diabetes, because they also reduce. Pioneer 8 has shown that the weight reduction is quite great. But it was a great session, and I like the way the panel discussion was held by Dr. Kanwar. What oil you should use, how much you should use, and what food to take, in what form, what rice to take, how to take potato smashed or whole potato. Both are bad, but which is worse? It was a great session. Then we had a session on the technology. Again, great session, and with the the beauty of the session, the faculty are great, fantastic session. Then we had the session on the oral antidiabetics, and I think the session was good. And I must also tell you the panel discussion which Sanjay conducted was by molecule by molecules. I congratulate you, Sanjay Jain. Don't be in a hurry to go home, but we're in home only. So, but you did molecule by molecule. Started with metformin, sulfonylurea, DPP4, SGLT2. Molecule by molecule.
My dinner has reached just. After I finish, I'll have dinner.
Right. No, I'm finishing soon.
Dinner by kids.
Fourth session was diving deep into insulin. I really enjoyed this session, and the question answer also was very good. I hope people have enjoyed the question answer on the three aspects, both on the oral semaglutide and also the TIR, which was part of the talk and that Dr. Manas spoke, and also main focus on the insulin. And the last session is on the last session was on the COVID-19 and diabetes. And Sujay was fabulous. Dr. Satya was great. And so this interview was also great. Thank you, Alok, for doing the interview. And in spite of the time constraint, we had a beautiful discussion and discussed thread by the various aspects. Dear friends, the people who have joined, I must tell you that tomorrow we're starting at 11. It will be 11 to 11.05. The session will start. And we have for you lined up the program, which is centered around great things. It is centered around the complications in two sessions. Diabetes disease of complications, session 1 and session 2. We also have a session on the clinical pulse in diabetes care. We have the latest about type 1 diabetes. We have Dr. Sanjeevi and Sanjeevi's boss, Dr. Lenmark, who discovered the autoantibodies, GAD and ICA, and we have Dr. Sharda. We have a session on the diabetes and the mental health, very important. And we have a independent lecture series at the end by Sunil, Sambit, and Subankar. I invite you to join tomorrow before 11 o'clock. Over to Alok to close it with his closing remarks.
Thank you, Professor Das. Thank you, Dr. Satya and Jayant and all the members, Devasis and everybody who are present. And it was a really great academic exercise and a lot was contributed. Thank you very much.
Thank you.
And
Thank
we will meet
much.
tomorrow
Bye-bye.
at 11. Tomorrow at 11.
Surely. Bye-bye. Good night. Good night. Subharatri.
Recording stopped.
So that should.
No.